حضورنا الكريم، نرحب بكم مجددا ونرجو من الجميع التكرم بالهدوء وأخذ المقاعد لقرب انطلاق حفل افتتاح الملتقى بعد 10 دقائق. حضورنا وسننطلق خلال 5 دقائق من الآن. السلام الملكي.
أعوذ بالله من الشيطان الرجيم.
يا أيها الناس إن كنتم في ريب من البعث فإنا خلقناكم من تراب ثم من نطفة ثم من علقة ثم من مضغة مخلقة وغير مخلقة لنبين لكم ونقر في الأرحام ما نشاء إلى أجل مسمى ثم نخرجكم طفلا ثم لتبلغوا أشدكم ومنكم من يتوفى ومنكم من يرد إلى أرذل العمر لكي لا يعلم من بعد علم شيئا وترى الأرض هامدة فإذا أنزلنا عليها الماء اهتزت وربت وأنبتت من كل زوج بهيج ذلك بأن الله هو الحق وأنه يحيي الموتى وأنه على كل شيء قدير.
أسعد الله صباحكم بكل خير. عام مضى منذ أن التقينا، وما أشبه اليوم بالأمس، عدا أن الأرقام اختلفت فقد نمت وارتفعت، وعدا أن الأثر تغير فقد تضاعف، لنقف اليوم على شرفة رؤية تتشكل، رؤية جعلت من الوقاية ثقافة، ومن الاستباق منهجاً، ومن الإنسان محوراً رئيساً. أنتم في رحاب شركة الصحة القابضة، وفي ملتقى يعكس تطلعات رؤيتكم، ملتقى نموذج الرعاية الصحية السعودي 2026. الله يحييكم أصحاب السعادة، قادة القطاع الصحي، الممارسون الصحيون، ضيوف المملكة الدوليون، أيها السيدات والسادة. في ملتقى نموذجكم الصحي السعودي نلتقي لنخلق حواراً، لنوحد اتجاهاً بين صانع للقرار ومنفذ للسياسة، وكذلك مقدم للخدمة، لنقيس الأثر، لنراجع ما تحقق، ولنطرح أدوات المستقبل، وكذلك لنستعرض أفضل الممارسات العالمية في تقديم الرعاية الصحية. بكل اختصار معكم وعبر نموذجكم الصحي السعودي ننتقل معكم من إدارة الخدمة إلى إدارة الأثر. لنشاهد.
الأثر لا يرى فوراً ولا يقاس بلحظة. الأثر يصان ويرعى ويترسخ بثبات حتى يصنع مستقبلاً أكثر صحة، وحياة أعلى جودة، ورعاية أبعد أثرا. لأن الإنسان في هذه الرحلة ليس حالة عابرة ولا رقماً في سجل، بل هو جوهر الرعاية، من الاستجابة للمرض بعد وقوعه إلى نموذج يحمي الحياة قبل أن تتألم. عدنا رسم الرحلة، نموذج يضع الوقاية في المقدمة ويجعل الاستباق أسلوب عمل لا خياراً مؤجلاً. نموذج يعيد تعريف الرعاية الصحية كقيمة وطنية ومسؤولية مشتركة تبدأ من الإنسان وتمتد إلى المجتمع وتنعكس على جودة الحياة. من الرعاية الوقائية التي تنير دروب الصحة وتمد جذور الوعي في المجتمع، إلى الرعاية العاجلة حين يلزمنا الزمن. هنا تبدأ الاستجابة السريعة ولا ننتظر، من الألم إلى الأمل. ومن الرعاية الاختيارية التي تحسن التجربة إلى رعاية الأم والطفل، فنحن نؤمن أن بداية الصحة تكمن في البدايات نفسها. وفي رعاية الأمراض المزمنة نحمل الأمل لكل فرد، نواكب خطواته ونقوي جسراً بين أمسه وغده. أما الرعاية التلطيفية فهي رحمة في أعمق لحظات الإنسان، تحيي الكرامة وتخفف المعاناة. هنا تتوحد الجهود لبناء منظومة صحية متكاملة تجعل من الصحة مسؤولية مجتمعية وواجباً وطنياً وأولوية للمستقبل، لأن صحة الغد لا تنتظر بل تصنع. في ملتقى نموذج الرعاية الصحية السعودي 2026 تلتقي الرؤية بنموذجها والقيادة بمسؤوليتها، لتبدأ صناعة الأثر.
الآن وبكل فخر نعلن الافتتاح الرسمي لملتقى نموذج الرعاية الصحي السعودي 2026، الذي بكل تأكيد لا تتجه عقارب ساعته نحو برنامج علمي فقط، بل نحو حياة أطول وصحة أفضل. قبل أن ننطلق في برنامجنا العلمي يجب ألا نغفل وألا ننسى وأن نتذكر ونشكر كل من ساهم، كل من وقف، كل من عمل، وكل من كان صاحب أثر في إظهار هذا الملتقى بهذه الصورة المشرفة، وأيضاً بالتنوع الذي سنشهده معكم خلال البرنامج العلمي. الشكر كل الشكر للجنة العلمية التي نستعرض وإياكم الآن أسماء أعضائها تقديراً لدورهم وعملهم طوال الفترة الماضية. شكراً بحجم السماء، نحييهم جميعاً لأنهم يستحقون. إذن شكراً لأعضاء اللجنة العلمية، وكذلك الشكر والتقدير لمن عملوا على مسألة العدالة والنزاهة وتحملوا الأمانة في تحديد أسماء الجهات الفائزة معنا في جوائز ملتقى نموذج الرعاية الصحية السعودي 2026 بهذه النسخة، واللي اليوم راح نكشف الستار ونعلن أسماء الفائزين في الحفل الكبير في مساء هذا اليوم عند الساعة 7 مساء بإذن الله. خلونا نشكر الآن لجنة التقييم والجوائز التي عملت طوال الفترة الماضية على مسألة التقييم وكذلك الزيارات الميدانية للمستشفيات وتحديد الجهات الفائزة معنا. شكراً بحجم السماء. الشكر والتقدير أيضاً لمن آمن بالفكرة، آمن بالنموذج الصحي السعودي، آمن بفكرة الملتقى، وكان شريكاً مساهماً ليس بمجرد اسمه وشعاره، بل كان شريك نجاح في كافة التفاصيل. شكراً لشركاء النجاح الذين نستعرض الآن شعاراتهم وأسمائهم على الشاشة تقديراً لعطائهم ودورهم واستمراريتهم أيضاً، بداية من شركة أبوت، شركة R1 وماس جنرال وشركة أسترازينيكا. شكراً لكل من ساهم وقدم وعمل طوال الفترة الماضية لنشهد هذا المشهد المشرف الذي يتكرر كل عام في ملتقى نموذج الرعاية الصحية السعودي 2026. الآن ينطلق برنامجنا العلمي، ونرحب بهذه اللحظات بمن ستقود فقرات البرنامج العلمي وكذلك ستطرح لنا خارطة الطريق طوال هذا اليوم عما سيدور في أحداثه. رحبوا معي بمديرة التميز في الخدمات بشركة الصحة القابضة الدكتورة عبير أسماري. Ladies and gentlemen, I would like to welcome now the Director of Service Excellence, Dr. Abir Asmari.
Good morning, Your Excellencies, distinguished leaders, colleagues, and partners. On behalf of Health Holding Company, I'm pleased to welcome you to the Saudi Model of Care Forum 2026. Over the next 2 days, we will be exploring how model of care evolving from strategy into system design, financing, digital enablement, and measurable outcome. The scientific committee brings national and international leadings and structure the agenda very intentionally to guide us through this journey. Today, we will begin our program with a strategy and system directions, moving into system design, then financing and incentives, and how health outcomes are shaped into practice. We will be then focusing on key enablers of transformation: digital systems, precision medicines, integration, before closing with a holistic view of care. Before introducing our first session, I would like to mention that our morning session will run until 1:50 with one coffee break at 12:35. With this context in mind, please allow me to introduce the first session. And for the first session today, to frame our discussion today, we will begin by looking at how models of care evolving in a rapidly changing healthcare system. And to guide us through this perspective, we are joined by Dr. Jason Wasfi. Dr. Wasfi is the Director of Outcome Research at Mass General Brigham and Assistant Professor at Harvard Medical School. His work focuses on translating data innovation and clinical evidence into a measurable outcome across a health system, large integrated health systems. Please join me in welcome Dr. Wasfi.
Good morning. Everyone can hear me? Thank you all so much for having us. I know I can speak on behalf of all of us here from Mass General Brigham that we are delighted to participate. We're grateful for the opportunity to partner with you. I'm Jason Wasfi. I'm a cardiologist. I direct our program in outcomes research in cardiology. For many years, I was medical director of the Mass General Physicians Organization. And what I hope to convey today is that we are delighted to partner with you and other colleagues throughout the world in thinking how to create healthcare systems that are better, that can improve outcomes across populations. A lot of what I've done in my career, both from a research perspective and from a management perspective, is based on the idea that we can deliver better care to populations by changing the way we deliver care. What I'd like to sort of start out by is a bit of a celebration. This is, for the last 70, 80 years in modern medicine, there have been astonishing developments, new medicines, new procedures, all sorts of progress, new available treatments for patients that has largely been based on both preclinical evidence, but ultimately requires validation in well-designed prospective trials. This is a classic experiment by Austin Bradford Hill, really sort of showing how a randomized control trial can show you with high degree of evidence that randomized trials eliminate systematic differences between treated and controlled groups so that you can interpret differences in outcomes between the groups as a causal effect of the therapy. It's an extraordinary tool at saying what causes what treatment is better than what treatment. And so what I'd like to do a little bit with you today is put forward an idea, and we can talk more. What if we took that level of rigor, the same rigor that we put into the development of new procedures, new drugs, new devices, into the way we deliver healthcare? I would say that I think that we can use the treatments we have better and transform outcomes across large populations. So with so many new medicines available, but generally not given to the patients who need them systematically, the next era in healthcare, in your country, in my country, in countries throughout the world, may be more about systems of care delivery. I had the honor of participating recently as an American delegate to the Lancet Commission on atherosclerotic coronary disease. We had an amazing work group from delegates from all over the world, including Dr. Mirwald Alsagnag from King Fahd Hospital in Jeddah. And we put forward the idea that despite the medicines for coronary disease and heart attack getting better year after year, outcomes throughout the world, deaths, have continued to go up over the decades. We think that if you properly treated cholesterol, blood pressure, gotten all the medicines to all the patients who would benefit from them, by 2050, we think you could reduce death from coronary disease by 80% throughout the world. Not necessarily, we would love new medicines to be developed as well, but simply by making sure that the right medicines get to the right patients systematically. These are data from my country. These are national data from the United States. I'm a cardiologist. I think about heart disease all the time. And if you see since 2010 or 2011, this is mortality from heart failure. it had been getting better and better and better and better, but then it's getting worse and worse and worse and worse, to the point where at a population level in my country, heart failure mortality has increased by 1/3 in the last 10 years. And that's remarkable because over those same 10 years, the treatments have been getting better and better and better, and yet the outcomes continue to get worse. These are trials that have happened during those 10 years. And I'll say I have often, I think actually always, been in the room at the national meetings, at the European Society of Cardiology, at the American Heart Association, American College of Cardiology meetings, when these trials are presented and there's a paper in the New England Journal, there's gasping in the room. There's excitement. These new treatments are incredible. Angiotensin neprilysin inhibitors replacing ACE inhibitors reduces mortality by 20% in systolic heart failure. SGLT2 inhibitors, a repurposed diabetes drug in systolic heart failure, reduces mortality by nearly the same amount. We also know that SGLT2 inhibitors now, it has benefits in heart failure with preserved ejection fraction, a condition for which we never had medicines to treat at all, and now we have a class 1 indication in European guidelines. So over the time that these outcomes have gotten worse, the medicines have gotten so much better during a time that outcomes continue to worsen, which raises a question of how throughout the entire world systems of care are organized. If systems of care can improve going forward, we may be able to realize the benefits of these therapies. And it's not something that's unique to my country. We see this all over the world, a similar trend in heart failure mortality you see in Europe. It's almost the same thing. Throughout the whole world, we've concentrated on the development of new drugs, and we've been successful. But now I think we need to focus on systems of care. Part of the problem is that medicines, even when they're available, aren't getting to the right patient. This is hypertension control. Again, I'm a cardiologist. Blood pressure control in no country is better than, say, 50, 60% in terms of the number of people whose blood pressure are at the recommended targets. The medicines work very well. They're widely available. They're cheap. It's just they're not getting to the right patients. And this isn't only about blood pressure. I also had the privilege of being on this US statistics task force to look at cardiology statistics in the United States. And you can see this among overweight and obesity. The prevalence is nearly 40% for each condition. We now do have medicines that are effective at treating them. And LDL cholesterol targets, after myocardial infarction, you're supposed to get the cholesterol down to 70 milligrams per deciliter, ideally lower. Very few Americans are able to get there. Like 4 out of 5 aren't able to get there at all. And to the more aggressive, more appropriate targets, it's less than 1 in 10. So again, the medicines work. It's just that the systems of care are not getting the medicines to the right patients. So at Mass General Brigham, we're very committed to addressing this. We're committed to operationalizing innovative care delivery mechanisms and developing the science of determining what works. And so we did a randomized control trial. We compared for blood pressure, just regular care, going to the doctor, going to the primary care, getting checked, getting treated when necessary, versus a more innovative arm. The innovative arm had nothing to do with doctors' offices. We used the electronic health record, queried elements of the record. Often this was things that were seen on cardiovascular imaging, especially left ventricular hypertrophy on echocardiography, but had been under-recognized. That can be a sign of concealed hypertension. And we screened people at home with population health coordinators, with home blood pressure cuffs. And this is what we found. We found that hypertension diagnosis and treatment got way better. So in a randomized control trial, you can compare systems of care delivery against each other and see what works. And in this case, we saw that a new way of doing it was much more effective than what we had done before. And these results have been done in other systems. Other groups are working on this as well. This is a randomized control trial from rural China, 163 villages. It's a trial of non-doctor community healthcare provider interventions versus usual care for hypertension. And the intervention really makes people's blood pressure a lot lower, but systolic blood pressure 23 points, diastolic about 10. And because the blood pressure is so much better controlled in this intervention, they have less myocardial infarction and they have less death. So you don't need to only develop new medicines to improve outcomes. We can improve outcomes across populations simply by giving what we already have to patients more systematically. This is a fun story. I'd be happy to share this with you. We think that in addition to the evidence generation, we have to be attentive to other aspects of care delivery. In addition to understanding what works better, what works worse, we have to change workflows. And this is a picture of me in one of the newspapers in Boston from, it was 11 years ago. You can see I can look younger. In Boston, we have big snowstorms. I know you don't have this problem here. And then no one comes to the clinic. So it's a big problem. The doctors are there. No one can get there. There may be 2 or 3 feet of snow on the ground, and no one can get to the clinic. And it's a little bit of a pain because you're there waiting for the patients, and none of the patients are coming. I was in charge of getting people to use video-based telemedicine as an alternative to regular care. And it's difficult, to be honest. Like the doctor's like, why are we doing this? Was 10 years ago, 11 years ago. Why do we want to do it? We're doing it the old way. It works well. The patients, what is this? I come to the doctor. Why do I want to try this new thing? But there was one day we had probably this much snow. No one could come. And I said, guys, either we're going to cancel the clinics or we're going to have to do it this way. So you can use these things as opportunities to get people to try new things. And then the last thing I'll say is that even when you know what works, even when you can get workflows to change, systems of governance and finance need to change also. In my country, in your country, in lots of different countries, the systems of governance and finance are very different. In my country, it's largely fee-for-service. So even if you show something works, can get the doctors to do it, the patients to do it, no one's going to do it at scale if it's not in a fee schedule, if there's not a specific payment for the service. And that's why that needs to change as well to truly transform healthcare systems. We also have innovated in response to policy incentives. Mass General Brigham is the oldest and largest teaching affiliate of Harvard Medical School. The older of the two hospitals, the Mass General Hospital, has been around since 1811. And we have data from 1821. I've never known why we don't have data between 1811 and 1821, but we have data more than 200 years about the cost of care per hospitalization at the Mass General Hospital. And you can see what happened in the post-World War II era after the development of the Medicare program in the United States, is that huge increases in the cost of care have happened year over year. And in response to that, the government and private insurers have instituted all sorts of contractual agreements related to the cost of care, incentivizing provider organizations like mine, doctors like me, to reduce the cost of care. And that's why in the United States we have policies now that are shifting responsibility to the total cost of care to hospitals and to physicians' organizations. So this allows us an opportunity to really think about what patients actually need, even when there's not a specific payment on a fee schedule. And in that setting, we've been able to innovate in terms of the care that we deliver. This was something we did in 2014. This is, again, around the same time when we were starting video telemedicine. We had huge problems at the time. You know, these are very famous hospitals in America, and a lot of patients want to come here, and it's not easy to fit everyone in. We have constrained space. So how can we develop a mechanism of getting people the care they need with dealing with these large wait lists? Even though there wasn't a payment for that kind of mechanism, we developed an electronic consult service, which was a way that, not distinct from video telemedicine, it was a way that caregivers could ask questions of specialists like a cardiologist like me. The cardiologist would review the chart, put a medical note in the chart, but not actually see the patient directly. The advantage of this, both for the patient and the referring provider, is that it occurred much faster. We were able to see people within a couple of days rather than sometimes weeks or months. So this was a real innovation that was in response to the policy incentive that we had from the government. And again, Mass General Brigham is an academic system. We're very interested not only in care innovation delivery, but we want to develop the science of understanding what kind of systems of care work, which ones don't work as well. And we found that when we started this, we wrote a paper saying that the electronic consult immediately took up 8% of the total volume of our referrals. And again, our incentives were around the total cost of care. So when we looked back at the e-consults, we found that in 3/4 of cases, they didn't require a visit with the specialists. The implication of which was really important because we were trying to reduce the total cost of care. So it was very important that what we did replaced a billable visit in the office to reduce total healthcare costs. And sure enough, when you looked at where we started e-consult services versus not e-consult services, we found, consistent with our hope and our expectation, that traditional visit requests were replaced. So we were getting the care to the patients that needed it without creating additional wait times for patients that needed to be seen in the office. And then we also were very concerned. We want to be we know that there's burnout in medicine. We want the patients to be happy. We want the doctors to be happy. So we did a lot of qualitative surveys. We asked patients and doctors if what we were doing worked well for them. And there was a lot of really positive response. So the whole arc here is because the government was trying to get us to reduce costs, we had room to innovate. The external pressure allowed us the space and the room to innovate in the way we were delivering care to patients in a way that made care better. And since we did this, it's been over 10 years. Other groups have done it. Other groups have analyzed these types of programs. It seems to be true in different settings that electronic consultation in a setting where there's long wait lists is associated with high satisfaction for patients, for the referring providers, but it's unclear. The scientific gaps are around comparative effectiveness on specific quality endpoints, which needs to be worked out. It was also a good fortune that we had this program in place in 2020 because we didn't have time in 2020 to set up things immediately. But because of the snowstorms and because of the risk contracts and cost pressure, we had experimental programs in place that we could then lead into systematic ways that we could deliver care at a time when patients couldn't come to our clinics or were afraid to come to our clinics. So these types of care innovations can have legs. They can grow, and with circumstances changing, they can become more prominent and more important in the way we deliver care. At this point, again, I started with Bradford Hill. People have done randomized control trials. When you offer cardiology e-consults as part of regular care, you actually decrease the total cost of care, not only because of the replaced visit, but also because procedures and testing are ordered less often. So the science of this area has developed quite a bit. And this is a group from Spain that's looked at this specifically in heart failure patients. It looks like electronic consultation, presumably because the patients and the doctors get the advice faster, seems to be associated with a small reduction in mortality, which is very exciting. In my system, electronic consult, this is something obviously I started a long time ago. I'm very proud of it. It's about 10% of our total referral volume. So it was a major way that care is delivered within our health system. And I think I'll just conclude by, obviously I've been in this space for, 10 to 15 years at this point, and I've seen lots of new programs and changes in the ways that care is delivered. There is so much more ahead. The challenges that you have are the challenges that we've had. They're the challenges that exist in Europe and in other places, that throughout the whole world, we have workforce shortages in healthcare, we have burnout in the healthcare workforce, we have more people who need care than are getting it with long wait lists. The old principles of understanding in a rigorous way what care delivery systems work better than other systems. In the same way that we need to compare drugs to older drugs when we validate new therapies, that's going to be critically important going forward. Changing clinical workflows is always difficult, but certainly can be done. And there needs to be attentiveness to, you can't do anything worth doing without having a finance model and an operational model that supports it. So when we see these new technologies, this is a paper looking at artificial intelligence chatbots. So this is actually a comparison of doctors against chatbots in terms of answering questions online. And I don't know about your clinical practices, but there's tremendous volume of questions coming in. And I don't have time to answer all of them. The patients don't necessarily want to come into the office to get advice. They want to ask on asynchronous messaging. And it turns out, and it's very hard for all of us, but AI can do this in a way that's probably better and strikingly more empathetic than human physicians. So there are advances. We know that this technology is here, is validated today. So thinking about how we integrate this into workflows, how we have an operational financial model to support this will be critically important to the success of the coming generation of how we're going to implement changes in care delivery. I really do believe that this is a time to be very hopeful. Again, I reiterate so strongly in Mass General Brigham, we're delighted to be here with you. There are few things in my career that I find more satisfying than partnering with other colleagues, clinicians, trying to improve systems of care, to better deliver care for patients that we're responsible for. I do think that by the next generation switching from thinking about developing new treatments and applying that same level of rigor to systems of care delivery, we could massively improve clinical outcomes. The same old rules will apply, validating the science of care delivery, changes in clinical workflows, and shifting in a thoughtful way systems of governance and financing for the sustainability of these new programs. Again, we're honored by the invitation, delighted to be here. Thank you so much for the hospitality, and looking forward to getting more of you, to know more of you throughout the day. Thank you so much.
Thank you, Dr. Wasfi. What an amazing start of the day. Before moving into our next session, I would like to remind all the attendees that we are honored to invite you to the ceremony today that held this evening at 7 p.m. under the patronage of His Excellency, the Minister of Health, فهد الجلاجل. حضورنا الكريم يشرفنا دعوتكم لحضور حفل التكريم مساء هذا اليوم برعاية معالي الوزير الأستاذ فهد الجلاجل. Moving into our next session and building on the global evolution of the model of care, we are now turned into how system of care design, the decision of system of care design influence the quality of care, influence the survival and the sustainability. And to take us into this discussion, we welcome Dr. Martin McShane. Dr. McShane is a senior executive within the UK NHS, with an extensive experience in a population health, outcome-based model, and national system articulate. Please welcome Dr. McShane.
Good morning, everyone. Thank you very much indeed for inviting me here. And I was just telling Dr. Wasfi his final point actually set up this talk brilliantly. And yes, that photograph that you saw earlier was taken a few years ago. globally, healthcare systems now face a major challenge. Both here and in the UK, we have seen what in the early part of the 20th century was a system which was designed to deal with trauma and infection and acute illnesses, to now one where we are facing the explosion of long-term conditions, of chronic disease, and also, I think, multimorbidity. But actually, if I invited a doctor from the 1930s, 1940s or 1950s to come and walk through the system of care in the UK now, has it changed that much? Have we really changed the way that we deliver and manage care? And I think this example of a fairly typical patient that I would have seen when I was a general practitioner, primary care physician, would be very familiar to people now. Sandra, an elderly woman who goes to the medical emergency department because she feels unwell. She's found to have hyperglycemia. She's told she needs to manage her sugar. Doesn't mean much to her. She goes home. She really has lots of other social problems to deal with, lacks any motivation. So she goes to see her GP, and they're very enthusiastic. They tell her, get 30 minutes of exercise every day, improve your diet, and I'm going to change your medication. And she comes out completely confused. She feels overwhelmed because where she lives is very remote. It doesn't feel safe going out to walk. Shopping isn't easy, and she's got all her social problems still to manage. And then somebody from the community service comes to see her and has mainly a social care focus, which again doesn't help her with her medical problems. And then one of her best friends passes away, and she feels completely isolated and depressed. And a bit like me, if I get stressed, I like something sugary to eat. I like something to compensate for my emotional distress. She gets ill again, she goes back to the A&E, and she's back into the same cycle. So how do we break that? What will actually change the system of care? And in my experience, working as a frontline clinician for over 2 decades, working as a commissioner in the NHS, working at a national level in the NHS, and then learning about population health management and population health analytics, I think there are 4 key things, and actually it's interesting that the agenda for this program reflects that. A politics, policy, money, and measurement. And actually, it is the money and measurement which will, in my experience, change care the quickest and fastest. So what about the money? And I think when I stepped back and looked at the context of how we use money in the NHS, I could see 4 big buckets. There's specialised care, highly specialised care, which is delivered in a few hospitals. We spend about £300 per person in the UK on specialised care. We spend about £1,000 on general hospital care, about £500 on community and mental health care, and then £200 goes into general practice. Now, if the cost in hospital care goes up by 4%, we have to find that from somewhere else in that budget. If we took it from general practice, that would be a disinvestment of 20%. Now you might think, well, that never happens. Since 2010 in the UK, there has been a 45% increase in the number of doctors working in hospital. There has been no increase whatsoever in the number of primary care physicians. And this is how, unless we understand the totality of spend for our patients across the system of care, if we continue to pay by activity, by organizations, by organs, by process measures, we will continue to get what we've always got. We do not pay by outcomes, experience, or by individuals, families, and communities. And I think this is what learning about population health management did for me. It transformed my perspective, the view I took of the system, to one which looked at everything through the eyes of what is happening to the people we serve. It requires that fundamental change of view, and it also assists us in delivering holistic or person-centered care. So if population health is about delivering health, improving the health of the well-being and saving lives in the whole population, population health management is about how to do it, through using data and information to truly understand what is happening across the continuum of care, to segment, as I will show you, to segment your population, to risk stratify them, to model the impact of new models of care, and then monitor the effect those new models are having on your population and the outcomes that you're getting. It actually requires everyone to act together. It uses data to drive insights on best practice. It focuses beyond just the medical model of care to embrace a bio-psycho-social model of care. You can reduce health inequalities. But I think one of the most exciting things for me, as I'll demonstrate with some case studies, is it allows you to look at alternative models of healthcare and how to use the strengths that you have in your system of care already to better effect. One of the things that I learned in working with the NHS to deliver a program of population health management development, so trying to working across the NHS in England to get people to understand the principles and practice of population health management, was not to focus on what you don't have, but to focus on your strengths. That energizes people and helps them really accelerate change, so that you prioritize the collective use of your resources to best effect. So it's about taking data from every source you can. And one little secret that I learned early on is if you can just link the data that you have in the hospital with the data that you have in primary care, it's almost the first step on the Pareto principle. It's the 80% of what you need to affect good population health management. But if you can add mental health, social care, other factors, other information and insights, you will be able to develop actionable insights around people, around their families, around communities, to improve outcomes and improve the utilization of your resources. So what does that look like? This is a busy, but we talked about going from system to person and back from person to system. So if I work from the bottom up, you take all the data that you have about a person, aggregate it up through your neighborhood, through your local community, through to a larger place, through to a whole system. You can then, at the top, do economic modeling and actuarial projection of what will happen if you carry on doing what you have always done. You can then model what would happen if you implemented some evidence-based practice at scale across the whole system. And we did this for about 1.5 million people in the NHS for a system. And it completely transformed the way they looked at what they were doing. You can then break down your system into places and look within the places at segmenting and looking at benchmarking and variation, risk stratification, and get down to a neighborhood. This is a sort of actionable area. It might be 50, 60,000 people, a neighborhood where through risk stratification and impactability modeling, you can really address the high risk, high cost users of care in an effective way. But you can also go right down to a patient and look at what difference does this make to an individual patient in their outcomes and experience. And I'll demonstrate some of that. And this translates on the right-hand side of this schematic into actions taken at an operational level, reducing those gaps in care, which we all know about, but also engaging people in their own care. It allows you to think about how can we better allocate resources between providers to get this new model of care to work effectively, and allocate those resources at a systematic level. So what might that look like? This is a very busy slide, but I wanted to show you because it's actually a dashboard which we use within the National Health Service when we're doing our development program. And what we have here is a whole system of about 1 million people. And there are the 5 neighborhoods, what we call primary care networks, across the top. And then we could go down and look in each of those at different characteristics. What is happening? Are their populations the same? Because even within a place, even within 1 million people, you can have very different characteristics in the demography and other characteristics of the population you're serving. You can examine how are resources being used? Is there any big variation? And start to ask questions about why that variation might exist. You could get insight into the biomedical drivers, and I've just put up a few there. You can look at this in any way you like. If you were looking at, say, preventative health care, you could look at the factors in your neighborhoods which drive prevention. And you can look at mental health drivers, which are incredibly important and often ill understood or underappreciated in the impact they have on use of healthcare as well as people's individual health. And finally, you can look at social drivers such as smoking, whether people are housebound, their social vulnerability. That gives you a wealth. And what we found was that clinicians especially really look at this information and their data files. They understand data and they start to see patterns in the data which makes them ask questions about how could we deliver care better for this population. Then you can segment your population in a neighborhood into basically the healthy, those who are living with individual conditions or some illness, those with complexity, those with severe complexity, and then those at the end of life, palliative care. And what we find is, as you move across from left to right, the numbers become smaller, but the cost per patient becomes increasingly large. And that allows you to really look at where you could have impact early on in your population. And this is one of my aphorisms which I often use, is the problem is that we tend to measure what happens. What we don't measure is nothing happening. That the work we have done has prevented people from becoming ill, has prevented people from deteriorating, has prevented people from dying. But if you use theographs, you can start to look at what is actually happening to someone now and what might happen. You can do your impactability modeling with experts. What would happen if we managed the care of this patient better? on the evidence we know that exists. And this is an example of a patient. At the top line is a theograph of a patient with waiting for complex surgery who has multiple emergency admissions, the red blocks in the graph you see, A&E attendances, but has very little support from community care. But actually they become so unwell, they're no longer fit for the surgery that was planned for them. And that costs the healthcare system over £14,000. Now, when we model what could happen to that patient if we delivered better care and where the intervention should happen, we find that we need to have a lot more resource in primary and community care, or what I would call enhanced primary care. And that allows them to actually get to surgery in a fit state and have the surgery which enhances the quality of their life. That looks like a lot of care, but actually the cost, if you remember my gearing in the system, hospital £1,000, primary care £200, it costs less than half of the inadequate, fragmented, ill-coordinated care that was being delivered previously. Now, you might, well, that's great theory, Martin, but what about can you actually make it come real? And this I've taken from an integrated care area in Lincolnshire, actually, in the UK, very big semi-rural community, well, very rural community. And they started to look at their data and they identified a cohort of people who are high-intensity users of urgent services, accident and emergency admissions. And they employed 2 care coordinators to address the needs of that cohort of patients. That cost them £80,000 over a year. In 6 months, those care coordinators reduced the cost of those patients, saved the health service over £230,000. That's what I mean by measuring nothing happening. There was a 58% decrease in emergency attendances, 4% decrease in GP encounters. Unfortunately, we can't do much about the work primary care physicians have to do. 41% decrease in emergency department attendance. Now you might say, well, that's just regression to the mean. But because we had data for the whole population, we were able to do case control comparison where the intervention wasn't planned. So this, if you like, had a control cohort that could be monitored, and during that same period, the costs could be compared. So in 6 months, they saved nearly 3 times the cost of the investment that they'd made for a year. This is, again, how you take the strengths in your system and you turn them to be more effective. This is from Imperial Foundation Healthcare Trust in London, major London teaching hospital, where the paediatric department turned itself inside out. They stopped being reactive and waiting for patients to be sent to them, and they went out and engaged with primary and community care and social care to support them with their strengths in the management of patients in the community. And they set up those hubs which were at the center, multidisciplinary teams, and from the data, like they did in Leicester, they identified the most high-risk patients in the cohorts, in the segments, in the population that they were serving. And these are just 2 real-life case studies from that cohort. The first on the left was a 7-year-old girl with multiple complex problems who had a gastrostomy. And what they discovered was that, first of all, the patient was seeing a locum GP in primary care, so there was no continuity of care. And secondly, they were attending urgent care frequently for problems with their gastrostomy. Well, when everyone got together and took a holistic view of this little patient, they discovered that firstly, she was eating and drinking normally, so why did she still have a gastrostomy? And the GP partners realized, somewhat embarrassingly, that they weren't providing great care, so flagged the patient in their system to give them that continuity of care. On the other side, you have where I go from the individual to the family. You have a child with severe asthma who is attending A&E repeatedly because of exacerbations of their asthma, who is failing their school because of their asthma, so the wider biopsychosocial aspect of their care. And when the team got together, they looked at all the things that you would do, their inhaler technique, but they also discovered the parents were smokers. And they could perhaps get the parents on a guilt trip to improve their own health by stopping smoking. So what impact did that have? And this is from a major teaching hospital in the heart of London, in Paddington. A 33% reduction in hospital appointments. 17% reduction in pediatric admissions. that's 1 in 5 children that would have attended accident and emergency no longer attending. And if you go back to my gearing in the system, you can imagine the financial costs. But actually, I spoke to one of the lead physicians who had done this work, and because I know they get payment by results, they get paid for activity, I asked him, what does your finance director think of this? And he said, I'm still running. So what does population health management give us? I think it gives us a quality improvement cycle. It is not about performance management, it is about quality improvement. You plan through understanding your population health care and needs. You look for opportunity and targeting within your population. You predict what new models of care might do for that population. You then design and implement those interventions, and then do study. You look through active monitoring. Are we actually getting the impact that we thought we would get? And if so, do we sustain it? Or if not, what more do we need to do? So it's never a static system. It's a continuously self-improving system. But what I would say, and the Sakti Kuranathi, who is a public health director in England, brilliantly said, and I always have to give him credit for this rather than stealing it from him. He said, Martin, it's 10% about the data, it's 90% about human behavior. It's about engaging clinicians who become enthused and motivated through seeing what is happening across the continuum of care. And I firmly believe that 99.5% of all professionals go into work every day wanting to do the best for the people in front of them. And this way we can help them do that. We can create a system of care which helps them maximize their strengths and their organization's strengths. And what I found rather thrilling was I plucked this from a policy document published by NHS England in November last year. And basically, it sets out the principles that it's asked the NHS now to implement population health management, to understand the context using joined up person-level data and intelligence. Look at the biological, the biopsychosocial factors, and to address underserved communities, to develop a long-term strategy based on integrated models of care at a neighborhood level. Most importantly, I think point 3 is it will understand and allocate resources to manage the provider market, to actually stimulate and support this new model of care. And finally, and most importantly, they will evaluate the impact from those services, care models, and proactive interventions. So, at long last, having spent a fabulous career in the NHS, trying to get it to create a system which actually supports the professionals to do what they want to do on the front line, maybe it'll come about. But what I would say to you is, although policy and politics are incredibly important, basically use what you want to do with the money and information to make sure you get the right policy and politics for your systems of care. So, in this fabulous conference which you've organized, I thought I would just leave you with 4 questions to think about. What data do you have and can use for population health management? What are you going to measure? Because what we measure, we treasure. And if we try to measure the wrong things, or you will get that, people focusing on that. What are you going to incentivize and how? And finally, as I just mentioned, do policy and politics support your intent, or do you need to courageously, subtly, however you do it, influence policy and politics so they do support your intent to design a new system of care which improves health and saves lives? Thank you very much.
Thank you, Dr. McShane, for this an eye-opening discussion. What you mentioned and presented this morning actually emphasize on that how financing and incentives play a critical role to link and align the policy intent with real-world practice. And that will be the main focus of our next panel discussion. And before that, allow me to briefly introduce our panelists for the day, followed by the moderator for the session. For our panelists, Dr. Nawal Noor, Chair of Obstetric and Gynecology and Women Health at Mass General Brigham. Dr. Noor, leading outcome-driven care models for women and newborn. Mr. Khalid Al-Khwaitir, Chief Healthcare Purchasing Affairs Officer at the Center for National Health Insurance, CNHI, overseeing national purchasing and contracting mechanism. Dr. Dominique Samaha, Dr. Dominique Samaha, a consultant orthopedic and spine surgeon, bringing frontline clinical perspective on how incentives shape care delivery. And lastly, Mr. Faris Saada, partner at CapDev with an experience in healthcare financing and system-level transformation. Moderating this discussion will be Dr. Shadi Khayyat, CEO of Jeddah Second Health Cluster. I will now hand the discussion to Dr. Khayyat.
السلام عليكم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وصحبه أجمعين. Good morning, everyone. And first of all, I'd like to thank the organizing committee for the invitation that extended to me to moderate this very exciting session as it's financing and focusing about the value-based healthcare and the relation to the model of care. I really thanks our panelists today. We had a very interesting discussion over the last 2 days. How would we run this session? And we thought we're going to make it as a discussion based, so to share their great experience and the challenge that we see, hopefully, how we can resolve these challenges as we move toward value-based healthcare. So we thought initially, as the focus of the session is about value-based healthcare, that we're going to start with an introduction to the value-based healthcare. And I would just start the first question to Mr. Faris. What would be the value-based healthcare in your opinion, from a concept and why we need to apply it right now?
Hello.
Yeah.
Obviously, why we need to talk about value-based healthcare, we have a lot of outcomes variation when we actually bother to measure outcomes. And we have a cost in healthcare that is unsustainable over the long term that we see in almost, in every country of the world. So it's time to basically try and deliver the best outcomes for every patient in a health system in the most efficient way possible. Value-based healthcare has, in a way, tried to create a framework bringing together the outcomes over cost equation, in a sense that we measure and we strive to deliver the best outcomes for the cost, the best cost along a pathway of care. So what we need in order to deliver this is to think, as the keynote speakers mentioned in the morning, elevate the delivery of care to the status of a science and understand true evidence-based delivery of care would actually, at the end of the day, reduce complications and reduce costs. So striving for better outcomes will lead to lower cost. Outcomes should be the first goal and then the cost. And of course, the key pillars of delivering value-based healthcare is about actually turning that equation into another one, in my view, which is really looking at a care model, a delivery model, and match it with the right payment and incentives model. And that's something maybe we can talk about a bit more, because we have some of the great experimentations with payment models in the world. In the US, over 46 experimentation, maybe 6 of 46 were retained. And we can learn a lot and avoid a lot of mistakes as we implement here in the kingdom.
As a care provider, usually we have resistance that the value-based healthcare will reduce the resources that we can provide to patients. So this is one of the general comment that you see people in the dialogue, or physicians, they are worried about their patients, say, oh, this is going to be limiting the resources. So how would you answer that?
Fundamentally, again, we go back to to evidence-based practices and looking at pathways of care. No one can argue with evidence. Medicine is an empirical science. If you can demonstrate that a given intervention is worth it, really this is the ultimate judge. But today, as we notice, we have a lot of waste. We are not leveraging, preventions. We are not leveraging more leaner ways of working. E-consult was an example also that was given, early on. We have an incredible power of data today, and it's a pity that if we see something working, in 3 or 4 providers, because they simply have access to the data and they have the AI models as well. Why can't we generalize that to all providers? And in fact, the more providers sign in, the more they can compare and learn from one another. So I would say, and this is what we've seen, by the way, in collaborations between payers and providers, what is really key is that the initial focus, that the clinicians are involved in the design of the pathways of care, and that they are on board before the payer or the incentive systems come into the play. So they have to be on board, but of course they have to also be asked to make improvements.
Yeah.
But let them set the targets for improvement. We don't set it for them as a start.
Sure. So I think we're going to get that through the examples. So Dr. Nawal, thanks for being with us here, and it's quite an honor to have you here with us. So just like, we thought, like, since you are a pioneer in, like, providing this very value-based healthcare and, like, with the sustainability of the safety for pregnant lady, because in the Saudi model of care, one of the major pathway actually that we're following is the safe birth. So can you tell us about your experience for the previous years and what is the, like, the outcomes you get out of that experience so we can get it in our plan here?
Yes, thank you so much. And it's such an honor to be here, and thank you for the invitation. I actually liked your last question where you said, what happens when we're actually removing resources as we think about this. But in fact, what we're trying to do at Mass General Brigham is really deliver the excellent care with lower resources that are more impactful. So how do we think about processes? How do we think of models of care that really aren't that expensive, but actually are so beneficial to our patients and really beneficial to our providers as well? So I'm going to take you on a little journey. So give me like a few minutes, and I'm going to give you a couple of models of care that we provide for our pregnant patients. So say your wife or your sister or friend is pregnant, 27 weeks, so middle of her pregnancy. And she's been, doing okay in her pregnancy, and she starts telling you, I went to Mass General Brigham, and it's interesting, they've actually connected me with 8 to 10 women, and they have something called centering of pregnancy or group prenatal care, where I meet 7 or 10 other women who are pregnant at the same time as me, and I'm able to either WhatsApp or chat with them about my pregnancy and my pregnancy experience. And we meet 8 to 10 times during my pregnancy, where we actually talk about my weight, healthcare issues that I have, but also social issues. That model, that group prenatal care model, automatically improves her outcome and her baby's outcome. And so that what the data shows is about 33% of people who've joined group prenatal care have a decrease in the NICU or preterm delivery. So very low cost, high impact, very valuable for the patients. They love it, the patient satisfaction. The providers actually love it because they feel like they're actually part of the journey as well. So now suddenly, this patient develops gestational diabetes and hypertension. She automatically gets moved to another group prenatal care. She holds on to her old friends and she makes new ones who also have the same problem as her, which is hypertension, diabetes, and is being treated by a high-risk doctor. And the same thing, group chats, they're talking about their antihypertensives, they're talking about whether they need insulin or not. And then again, really measuring the outcomes of that have been great. So now she's coming to the hospital, and the hospital at Mass General Brigham, we give her a doula, and we say to her, do you want somebody who's going to be by your side during your pregnancy, during your delivery, and postpartum? In the past, the doula was actually something that patients would pay out of pocket, so that was their own charge. Now we provide it because our payers realize that doula programs are really great. Why? Because doula programs automatically decrease patients' cesarean section rate by 50%, and the data across the country demonstrates this. Now, the doula program is something that, so I'm Sudanese by background, grew up in Sudan and Egypt. Same here, I know that the culture, doula programs are really what we used to do in the past, right? Your family comes with you to have your baby with you, supports you, advocates for you, makes sure you're okay. We're now providing it as a part of care, low cost, high outcome. So now she comes to deliver. She's on the labor floor at either Mass General Hospital or Brigham Women's. And there we have something called an actual team birth that walks into every single patient, talks to the patient, and actually has her tell us what we want her delivery to look like. That in itself has, the studies show, and again, low cost, insurers love it, that demonstrates that the patients themselves have high satisfaction, are going to come back for more care. And then when it comes to the delivery, she has a nice vaginal delivery. Afterwards, because of her hypertension and diabetes, she could stay in the hospital and we'll tweak her. Oh, her blood pressure is too low, we'll increase, we decrease her high blood pressure medication. Her blood pressure is too high, and that tweaking takes days. So now we've discharged her to home hospital. And the data that demonstrates home hospital, again, much lower cost, taking care of patients in their house, whoever wants to be in the hospital for a long time. And that insurers are actually liking. Again, shifting the resources back to your point, but making sure that the outcomes are much better. What we found is patient satisfaction has increased, the readmission rate for those patients has decreased, their length of stay, of course, has decreased, allowing that bed availability for a more complex patient. All of those types of tweaks and designs have really been helpful. But no, there's one more thing. She graduates from the home hospital, and now we have a van. It's an actual postpartum van that goes to her neighborhood. Again, we're monitoring her blood pressure, her diabetes. We're also making sure she doesn't have postpartum depression. So we're actually matching the patient through all the journey of her pregnancy and her postpartum to ensure that she and her baby and family have great care.
Well, so from that I can, guess that the improved outcome was mainly because of more adherence to a pathway. So it's not something out of usual we're doing, but it just, there's somebody's watching us that we are, making patient, they go on the pathway.
Correct. Yeah, okay. Thank you.
Okay, so I think we're going to come to that later on. You talked about, an out-of-pocket payment. So in your experience, what all, patients' needs were included in the package, for the value-based healthcare, or they have a certain percentage that they need to pay out of their pocket?
So the way that insurers are in the US, it's very complicated. It depends on your insurer. So the payers make the decisions on certain things. But if you're able to demonstrate that there is a decrease in cost, so if we can actually decrease the length of stay, that really impacts the total cost of the care and also of out-of-pocket payments. So our goal is actually really just a reduce, so that patients don't have that impact, but also the total cost of care.
Well, I guess we'll leave that question to Engineer Khalid later on. So, Dr. Dominique, in your experience, I know that you have a local experience with the, applying this value-based healthcare, especially on a common problem like a low back pain. So, can you tell us your experience, please?
Yes, good morning. It's such an honor to be here. Thank you, Faris. Thank you, Dr. Nawal, for your insightful experience. I would like to come back to the question that you asked, Dr. Khayyat. Yes, the value-based healthcare is a new model of care that everyone is trying to adapt, and everything new is scary. Everyone doesn't want to adapt, to take this new model because it might be scary and reduces the resources. But in fact, do we really need a lot of resources to treat people? Don't we need efficiency? Don't we need to improve the efficiency? So how can we improve the value equation in value-based healthcare? It's simple. We need to improve the outcome, patient point of view. Until today, a lot of us were looking at the treatment from the doctor's point of view, from the healthcare provider point of view. But is this what the patient really wants? It's not sure. Therefore, when you will apply the value-based healthcare, you will improve the efficiency of treating the patient. How? In our experience, we created what we call an integrated practice unit for low back pain. It gives an end-to-end service in the pathway of the patient who is suffering from low back pain. So we know exactly at each step of the way what is the cost, what is the time needed, and a patient who comes to us with low back pain will know in one visit what kind of treatment will he have, a conservative treatment or not a conservative treatment. But to be efficient, we of course needed to collect the data and to collect the outcomes and to reflect and to share this data and these outcomes with the patient, to explain to them why it is important to have their input, and to explain to the doctors also with whom we share the data, we explain to them why the outcomes are important so they can adapt the treatment, adapt the treatment to the situation. You know that, for instance, in spinal surgery, we can do fusion or we can do without fusion. And both indications are rightful and are justified. One is less cost than the other. But if we take the patient need, when we discuss with the patient and explain to him and understand from the patient what he needs, believe me, we understand that the patient doesn't always expect what the doctor wants to reach in his treatment. So the value-based healthcare allowed us with a patient centricity model, with data collection, with offering an end-to-end service to be able to adapt our treatment and all our previous ideas of treatment to a best patient experience, and really we have improved our costs, and all led us to have agreements with the insurance company on the bundled payment model. The bundled payment is very important to have it if you control completely your pathway by being an end-to-end service provider.
I think we'll come to that later on. So, Engineer Khalid, so now to the CNHI. So CNHI is Center for National Health Insurance. So as a payer right now, we know that the transformation process for the healthcare now in Saudi, they're moving that the MOH will be the organizer, the HHC will be the provider, but the CNHI will be the payer. So in your view, just we can have in 1 minute what be the CNHI and how that's going to be the contracting body. And then later on, what's the value-based healthcare? Do you think it's going to be a challenge or it's going to be an opportunity for success for CNHI?
Thank you, Dr. Shadi. Assalamu alaikum wa rahmatullahi wa barakatuh, and happy to be with you all today. I'll give a brief about CNHI for those who may not be aware a lot about CNHI's role within the health system transformation. So as you mentioned, Doctor, CNHI is the single public payer. We purchase healthcare from public and private providers. Our purpose is to deliver sustainable value-based healthcare coverage for all beneficiaries. And the mission to do that is to ensure that this health coverage is data-driven, so data is key, and to ensure that it is following a value-based purchasing approach. And the value-based purchasing or funding, this will enable, at the end, efficient and high-quality value of care. So our ambition, and it's good that you mentioned, is it a challenge or an opportunity? It is a challenge, because moving from an input-based funding to a value-based payment model, it is a challenge, but it is more of an opportunity that we already gone through huge steps and milestones. So our ambition is to have a system transformation to make it sustainable. We all know that our resources are limited. We've seen great examples, and this is what we are going to drive through our value-based purchasing mechanism. This is driven by risk-adjusted capitation, and this is what we are working on right now, which is aligning funding with population needs for clusters. This, at the end, will improve outcomes. It will shift the gear regarding providers from focusing on treatment. They will focus on prevention. So the RAC, or risk-adjusted capitation, will move the needle and the focus to focus more on the proactive approach and prevention that and achieve the examples that the esteemed speakers has mentioned. And this also will enable accountability to providers to ensure that a valuable healthcare is being driven. All of that is driven by data. So I mentioned data-driven. So we are in the healthcare ecosystem. We've achieved great milestones in integrating data. This has helped us in identifying eligible population across all clusters, calculating the risk-adjusted capitation, and define the outcomes clearly. And regarding data and integration, we have great examples in our purchasing from private sector. We moved to 100% paperless claims last year. This gives us great granularity on data, which will help measure outcomes better, better visibility on clinical outcomes and KPIs, which will result at the end in better value. So this is maybe a brief overview of what is our role and how are we purchasing through risk-adjusted capitation.
I think it's going to be a complicated because you're going to go per disease, like, disease itself and per, population capitation. So it's a kind of more of a complex process rather than being a straightforward. But I think we're going to go through the challenge together as a providers and as a payer. So back to you, Dr. Dominique. So you had kind of touch base about DRG and bundle payment. So which one you think it would be better to serve to have a better outcome from value-based healthcare?
So, in fact, the DRG is an excellent model of care and is a necessary step to go toward the bundled payment. What is DRG? DRG covers an episode of care when considering the inpatient phase. But is the care journey only an inpatient, or it's also a pre-operative or pre-inpatient or post-inpatient also? In the case of surgery, for instance, after the inpatient episode, you have all the episode that is the physiotherapy, for instance, the care of the patient, and most importantly, and what is most costly, is the eventual complications and readmissions to the hospital. In this case, since you are readmitting and you are creating a new episode of care, you reapply the DRG and then the cost will go and will increase. Of course, it's an excellent step that leads to the bundled payment. But what is the bundled payment? A bundled payment will reduce the variable that are incurred to the payer because it takes into consideration the pre-operative phase, the operative phase or the inpatient phase, and the post-inpatient phase. So you don't care anymore about the cost for the complications, eventual complications, about the cost of the readmissions, the physiotherapy, the dressings, and the different consultations and radiology. And you cover the whole real episode of care. So being hospitalized for 7 days, 1 day, 2 days, it's not a problem because all is covered, and you avoid, most importantly, the cherry picking. Because when you are following the DRG principle, you know very well that it goes from no risk, middle risk, and high risk. So maybe in some experience in some countries, they saw that they kept for the private, they chosen the less risky, and what is more risky was going to the public hospitals. So it's a necessity, it's an excellent step, but I think we need to move forward to go toward the bundled payment, which covers the whole cycle of care, the whole journey of care, and hence the payers are relaxed from all the different variables in the care journey, and the providers are pushed toward becoming a centers of excellency and better efficiency.
But I guess still they will be keeping the DRG for acute illnesses, is that right?
Yes, of course.
So even if you move to the bundle, still the acute incidence will be kept there?
You are totally right, yes.
Okay. So back to you, Mr. Faris. So now in Saudi, with the Saudi model of care, we have been, it's the inspiring parts that we believe it will work on our mortalities at the future-wise. Because, touch the chronic care, the planned care, safe birth. So all the aspects that we are looking for, and hopefully that will be reflected on mortality, through the model of care. So how would you think that the implementation of value-based healthcare, how it will enhance the outcome of the Saudi model of care?
Yes, I think the key challenge in the Saudi model of care now is to bring it to life on the front line, right? Because it's been well developed, and you want to turn it into routine practice everywhere. And the idea is, if we take, I think Khaled obviously mentioned some examples that relate more to population or chronic disease management. If we want to move, we take one condition, for example, such as safe birth or maternity. We already have data. We already have some hospitals involved that we can compare and learn from. So we can see, for example, that we have first a case for change. So we have C-section rates varying between 10 and 52% This is not normal. We have a lot of unwarranted C-sections. We have C-sections that could be prevented that are happening in the emergency room because of lack of some risk monitoring. And again, there could be, even in a good hospital, some 15% of the patients could fall off the cracks. And that's still a lot of people, right? You have also variations in when we start measuring and symptoms and function, in patient-reported outcomes, for example, and we measure 10 during pregnancies, we see, for example, wide variation also in urinary incontinence, if reported. So 3 to 20%. And we know that there's a relatively easy treatment for that. Yet it's not available to everyone. And we know that when untreated, the risk of post-delivery depression, infection, mother-child bonding, breastfeeding confidence, greatly increases. So just imagine for a second if we are able to measure using standardized measurements and monitor all these variables, what is it that we are able to learn and do? And today we're doing that in maybe about 6 hospitals, but there are plans obviously to go to 20 and 30. This is the way we can really improve things. So if we have standardized measurements, we track patients, we get the truth from the doctor, the clinical outcomes, as Dr. Dominique mentioned. We get the truth from the patient-reported outcomes. We bring them together. We understand what's happening. We even have predictive outcome models that can predict complications. The second step is to learn and understand what the variations are telling us. And then work with the clinical teams on interventions. So high incidence of of urinary incontinence. Do we have pelvic floor training available for every woman there? Breastfeeding confidence, is there patient education, etc. And then from that point onward, we can set targets together with the physicians, so not independent of them. Essentially, bundled payment can be constructed on the back of that actually looks at this holistically and basically takes into account incremental steps. So first, I will not focus on 10 proms, or I will focus on the main complications and maybe on 3 or 4 proms or 3 or more symptoms that we know are the most recurring here. I want you to improve these. I want to start in a simple way. And we can set targets. And in a simple way, you could have, because if we have all hospitals measuring using the same instruments of measurements, we are able to do some risk adjustments today in Saudi Arabia, and we are able to rank them and give them a simple bonus for the top 25% and penalty for the lowest 25%. That's a simple P4P model, for example. So there are very practical ways in which we can start, provided we all measure the same thing, we agree on a delivery pathway, and we turn it into a science, as the keynote speakers beautifully made the case for. And yes, we can move forward. We need to really transition to making a difference on the front line, and 3-4 steps are separating us from that. And of course, we can talk about many of the enablers, but I didn't want to bore you repeating what we always hear about the data and infrastructure. We can go through that. But really, I want us to focus on the ball. Today, we can sign up more hospitals for the safe birth, for example, model of care, and make a big difference.
Back to you, Dr. Nawal. So in your experience now, I would say you have developed this program and you're a provider in the same time. How were you able, to incentivize, hospitals or providers who do better than the others?
I think that's a great question, and actually sort of piggybacking on some of the comments that were made before. I think that there's a couple of things I wanted to sort of backtrack on. When we think about lessons learned, what are you were all in the middle of designing some great new things in Saudi Arabia. What I would say is don't follow the US system, right? We are so expensive. We spent way too much money on our health care. I think that's seen all over, it's always in the media. I think when we think about bundles of care, a pregnancy is an episode and it's a bundled care, but it's how do we think about our quality of care and creating metrics across the system of what is considered acceptable or not. So you talked about the C-section rate anywhere between 10% to 50%. We are totally not on the 50% agreement, right? We really have to figure out what's the right C-section rate per hospitals. So some hospitals might have low-risk providers, and so their C-section rate could be 10, 15%. And then, for example, Mass General Brigham, we are a tertiary care hospital. A lot of the patients are sent to us. Our C-section rate is somewhere between 30 to 33. Is that right? Is it not? I don't know, but from a insurer perspective, from a payer perspective, they really do scrutinize us to think about what are the metrics and are we too costly? And so to come back to this point of how do you incentivize, we incentivize our physicians by measuring them, right? We are actually keeping metrics on every physician, on their C-section rates, on their hemorrhage rates, on their episiotomy rates, on their, so we actually have dashboards that demonstrate there are certain providers that do better than others, and then we sort of actually have conversations with some, and they'll say, well, I take care of patients with lots of previa, so guess what? Not only is my C-section rate going to be high, but I might have more hysterectomies, right? So we actually do incentivize our physicians to provide the quality of care that we want and desire from them. And I would say that the final point is that if you heard the journey that I spoke, it's not rocket science, right? It's just compassionate, multidisciplinary care, taking care of our patients where they're at and ensuring that there's great outcomes, as we talked about, and our esteemed colleagues talked about data-driven. It has to be data-driven. We have to make sure our patients are happy with the care they deliver. We want to make sure the families are safe, and we want to make sure that our providers are satisfied. So with that trifecta, again, it's not rocket science, but it is truly like coming back to our roots of what we used to do a long time ago, which is be around and surround our patients and make sure we pay attention to them and listen to what they have to say. And so when they have complaints or when they feel that there's something not right with them, let's pay attention to them. That's, again, just being a good physician at the bedside.
Okay. So Engineer Khalid, do you think now, because in the model of CNHI, we're talking about like, value-based healthcare, and we're talking about like, population capitation. So do you think including such an incentivizing program will be easy to apply from the beginning, or you think that's going to be a future phase until you establish your system?
Thank you, Doctor. And Dr. Nawal mentioned something great, which is incentives start with measurement. So I think we're in that phase. And in order to measure, we started with policies and regulations. And this has been great in the past year, where we established clear contracting mechanisms with providers. And through those regulations, we're measuring outcomes. And after measuring clinical and financial outcomes as well, the plan is to immediately start to implement either financial incentives through the risk-adjusted capitation, or even non-financial incentives as well, which will drive at the end a better outcomes and better patients' experiences, hopefully.
Okay, I guess we have 1 minute more if somebody want to add something before we close this interesting session. Okay, so thanks for all panelists for this great discussion, and thanks for sharing true experiences, like, how the value-based healthcare has, like, improved an outcome. And I think all of our panelists, they focused clearly that data that we need to measure is the key, how we can, like, make sure we have a good adherence to this, outcomes of the patient, and have it documented, get it, reported, and that will help, how we can improve the value-based healthcare, and hopefully we'll also enhancing more our Saudi model of care, we can get a better outcome. At the end, I'd like to thank all our panelists for their great support for preparation for this session, and for the, the opinions and discussion that we had. Hopefully you have an enjoyable time here in Riyadh, and I will be back to the organizing committee. Thank you all.
Thank you to our moderator and panelists for such a rich discussion. As we continue, we broaden the lens from financing to the broader questions of what truly shapes the health outcome, from leadership decision to the frontline execution. And to explore this from different systems and different delivery perspectives, please allow me to briefly introduce our panelists for the next panel discussion. Professor Awad Al-Amri. Professor Al-Amri is the Chief Executive Officer of Al-Mana Group of Hospitals, leading multi-hospitals care delivery models across the kingdom. And next we have Dr. Faisal Saif. Dr. Saif is the CMO of Security Forces Hospitals with an extensive experience in clinical governance, quality, and patient safety. And Mr. Tim Goodhue. Mr. Goodhue is a health industries partner at BWC, advising health systems globally on performance improvement and outcome measurement. Moderating this discussion is Dr. Khalid Al-Mulla, CEO of Al-Ahsa Health Cluster, with a system-level leadership across integrated care delivery. With that, I will hand the discussion to Dr. Al-Mulla.
Thank you. Assalamu alaikum. السلام عليكم، أسعد الله صباحكم جميعا. حقيقة سعيدين بتواجدنا معكم اليوم، وحب نشكر ال Organizing with Scientific Committee on the behalf of the panelists for the great organization, and would like to welcome the panelists today, which I am honored to be moderating this session with them with such leadership and strong background in healthcare system. Professor Awad Al-Amri, حياك الله. Professor Awad with long-standing experience from the academic and private sector as well through many systems. Professor Faisal Saif, who's had a strong academic background as well as multiple organization leadership as well as transformation in healthcare system. And Dr. Tim Goodhue, who had partnered with WBC with a strong background also in healthcare transformation. So I'd like to welcome them all. Professor Awad Al-Amri, let me start with you with this very interesting discussion about how can we transform and shape healthcare outcome. Healthcare outcome are often shaped long before a patient enters in clinic nowadays, through ways system are structured and governed. From your perspective as a leader, what is the single most important system level decision that determine healthcare at scale?
Thank you, Dr. Khalid. I'm privileged and honored to be here. It's a very good question, and I believe, in my humble opinion, the best way to structure a healthcare decision model is based on outcome, as previously mentioned by our colleagues. Often, most of the systems are structured based on a volume-based or based on a service-based, which is not the optimal, will not lead to the optimal results. When the governance, financing, and incentives are aligned toward an outcome of a healthcare-based, we will see a different results. We will see people, they will take the prevention, patient-centric, and data-driven will become the priority, and that's the real game changer in the whole healthcare systems. And I believe the healthcare outcomes or a healthcare system is not incidental, it's always designed, and the outcome it's always designed. Thank you.
Thank you, Prof. Awad. This is a very holistic approach through how the system can change and how can we interfere designing the system in the right way. Shift to Professor Faisal Saif. With your experience, many healthcare systems are now moving beyond surface volume toward measuring real impact on people's life. How can executive leadership shift organization from care delivery toward truly outcome-driven healthcare?
Thank you, Dr. Khalid. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm glad to be back here. I always like to start with a small story. But before that, I want to express my gratitude for the organizing committee for my invitation. Although I left the health holding company, but my heart is still there. I'm carrying the message. I'm the ambassador of the health holding company to the organization I moved to, whether it's NEOM or the Ministry of Interior. So thank you again for the invitation. I will share with you a small story at the beginning of the model of care implementation. And maybe some of the people here in this room were part of that story, or some of them heard about it. When we started to implement the model of care, we focused on one thing. We wanted to execute X number of pathways in a very specific period of time, in a very short period of time. So we're chasing numbers. We were not really chasing outcomes, and we were not after change in attitude. So what happened is, and by the way, that was everybody's anticipation in the organization, executing X number of pathways in a short period of time. So people in the front line, they got the message. What they did is they executed the pathways. Did it change the outcomes? Did it change the attitude? Probably not. I will give you an example of hypertension. We wanted to implement the hypertension pathway, 100 individuals. People in the ground took this as a project. It started. They enrolled 100 patients. Then it ended. Then we went back to doing whatever they were doing before. That's not a real outcome. That's not a real impact. Some people, they thought they are smarter and they wanted to make this sustainable, so they developed a hypertension clinic. So you go to that clinic for your hypertension, then you go back to the family physician for everything else. That's not what transformation is about. So we really have to focus on how can we shift things from actions to real outcomes. The difference between care delivery and outcome-driven healthcare, care delivery is what we do every day, what we do as actions. It doesn't necessarily help patients. We hope it does, but maybe it doesn't. While outcome-driven healthcare is that you are talking about outcomes. How are we changing? It is the change that happens in people's life as a result of our actions. So there are several things we have to do this. One is start at the top. Whenever you are designing your vision, mission, and strategy, you have to focus on outcome or patient outcomes. And you have to take this to everyday's meetings, reports, cards, and you always have to ask this question to anybody who brings a project or an idea, how this is going to change the outcome. So people in the future will be ready with an answer. Whenever they present an idea, they will tell you how this is going to affect the outcome. So this is the first thing. The second thing is ownership. We must have an ownership of the entire journey from end to end. And this is either by implementing integrated practice unit or system of care or whatever. But somebody or a body has to be responsible from a disease or a system, from prevention, screening, all the way to palliation. You cannot segment it. Once you segment it, somebody responsible for prevention and screening, somebody responsible for acute care, then if somebody fails, the failure gets pushed to the second department or the second group. And that's not good. People have to be responsible for the entire journey. If they fail, that failure will chase them in the next phase, and they will have to be responsible for that. The last thing is you have to align incentives. And maybe some people will laugh about this, but we have a lot of incentives in our hand to align them with outcomes. We have overtime, we have leadership incentives, we have courses, seminars, trips. We can align all those to people who are really achieve outcomes, not just actions that might not result in outcomes. Thank you.
Thank you, Prof. Faisal. For the audience today, this morning, we heard about how important is the system change, and now we heard from Professor Awad and Professor Faisal the importance and real examples of how we can implement changes within the system to provide optimum care. I'd like to ask Dr. Godhu, transformation no longer optional, but the challenge is where redesign effort should begin for the greatest changes. What structural changes, in your opinion, is needed today to improve outcome? Is it strengthening primary care, improving integration, or investing more in prevention? Can you elaborate and tell us about it?
Assalamu alaikum, and it's a pleasure to be in Riyadh. Thank you for the invitation. I'm pleased my fellow panelists already touched on it in one way or another, talking about either alignment or owning a pathway end to end. But I think the key is going to be more and more focus on the actual care integration, how through the hospital systems we reach down towards primary care and help to fill and bridge the gap that may exist. And from the primary care lens, how we offer a stronger and reach upwards to the top of the license on what primary care can deliver. And the ultimate balance between that is struck when you have that shared understanding of the geographic enrolled population that you're responsible caring for. We had this in Australia and in New Zealand, and you understand the health needs. We know here we're dealing with cardiovascular disease, cancer, diabetes, COPD. If we work together and we understand our regional priorities, and we bring together those that are responsible for the tertiary and secondary services, as well as those on a shared plan who are responsible for the primary care, we can really get quite targeted with our interventions in delivering truly integrated care that deals with the holistic aspects of what needs to happen in the region. So we can make sure, for example, that we're aware of those people who have indicators of HbA1c or diabetes that need to have that kind of ongoing care and management that can easily happen in primary care, which can create genuine, large savings and far better health outcomes of prevented hospitalizations and the like in the tertiary care system. We have here in Nafis as a platform. It provides an excellent infrastructure to enable this. We also have the risk-adjusted capitation, which will come online. These are all great enablers, so I really think the Kingdom is well positioned to really strengthen and move further forward on pursuing integrated care to its fullest potential.
Excellent, thank you, Dr. Goodhoe. Professor Awad, as a senior leader, senior decision maker face usually many choices with limited resources, can generate the greatest return on health. Where should leaders can focus and invest maximum population impact, workforce development, digital system, infrastructure, or community-based prevention? Where should they start, from your opinion?
It's a very tough question. If you can choose all of the above, will be the ideal answer. However, if you will make a priority, so always there is two priority. Always the priority investing in people and enabling people by technology. And again, you can ask a question, and I like to give an example. Why the healthcare system in Saudi probably is the best in the Middle East? Because the government had invested a lot the last 30 years by sending people abroad and training people. So that's an example. Then they established the Saudi board, etc. So that's a real example of investing in people. So always you have to invest in your people. Always you have to maximize their capability. On top of that, you have to enable them by technology and digitalization. And it should be both, because the modern medicine is relying on technology, in fact, and automation. The future of medicine, the traditional medicine doesn't exist anymore, which is a lot of physicians, they become angry when I mention that. It's not patient and physician anymore. It's a collaborative work. It's everybody's there, plus the technology. And I'm not a big believer of investment in buildings, because at the end you can make a 7-star hotel, but you will deliver poor services. I would rather invest in my team and the people and train them, plus the technology. And again, We see often an announcements of we bought the system by 300 million riyal or 400 million SAR or $100 million, but often many systems they failed because the implementation did not focus on training the people. And again, training people doesn't mean training physicians only. Healthcare workers, including physicians, nurses, receptionists, and all the people, they work together in getting an outcome. Since the leaders will focus on this kind of mentality, I believe they will have a major outcome.
Excellent. What strong message where workforce is the main enabler in any transformation. Thank you, Professor Awad. Professor Faisal, how do you balance short-term performance targets with long-term population, health improvement, and system sustainability when it comes to that?
This is a very tough question, but I'm sure any one of you who went to any organization at the beginning, they will tell you short-term gain, quick wins, low-hanging fruit, right? Nobody tells you anything else. Well, let's be honest here. I'm sure that deep inside we say we don't care. We should not care about short-term gains, and we should focus on long-term outcomes, because that's why we are here. But being practical, that's not true. My advice to everybody is you have to do both, unfortunately. For politicians, and for them to trust you and give you resources and give you budget to do your long-term projects, you have to show them some quick wins. And you have to capture the low-hanging fruit. I'm not going to be hypocritical here and say don't care about short-term gains or low-hanging fruit. You have to. You have to, and you have to show quick wins, and you have to harvest the low-hanging fruit for you to be there in your position to continue and have some long-term outcomes. But let's see how can we manage this. You have to have both, as I say, but you need to do two things. One is you have to have two separate systems for measuring both. You have to have a system to measure the short-term outcomes or the quick wins, and you have to have a different system to measure the long-term outcomes. And you have to treat them differently, but you always have to keep in mind that your main target is the long-term outcome. That's why you should not mix them, because you don't want one of them to affect the other, either not the so-ready outcomes from the long-term outcomes, or the quick wins that will make you happy with the quick wins and forget about the long-term outcome. So this is one thing. You have to make sure you have to keep both. But as a leader, it is your most important responsibility to keep the focus on everybody on the long-term outcome, because if you don't, nobody will. Everybody will focus on short-term outcome. You as a leader, it is your most important outcome, most important job to keep the focus on long-term outcome. The second thing is you have to trick the system sometimes, and you have to focus on the short-term outcomes that will serve the long-term outcome. For example, access. Access is something you can do quickly, will show results, but it will serve the long-term outcome. Some screening, it can show results, but it will serve the long-term outcome. Vaccination, for example, it's something that can show the effect quickly, but it will serve your long-term outcome. So you can have both. You can do both, but you always have to keep in mind that you are the main guardian for the long-term outcome. You have to keep talking about it. You have to keep it visible on the dashboard, and you have to make sure that your team are focused, and you have to be transparent and honest with them, because some of them will not understand why you are focusing sometimes on short-term outcome. You have to explain to them why. You have to say, we are doing this because politics demand that we focus and achieve some long-term outcomes, but our main focus is the long-term outcome. So unfortunately, the short answer, you have to do both, and you have to get used to this.
Thank you for making this harder for the audience, because Professor Awad mentioned how important to invest in the workforce as the main enabler, followed by the digital system, and now which is both our long-term, of course, effect. Now also you have complement that with focusing on short-term success, which I really agree that it's also an important one to focus on. Dr. Tim, as you can see, those strategy and outcome ultimately depend on the implementation across frontline teams and care pathway. What, in your opinion, what governance or measurement tools or accountability mechanism best to ensure high-level return while balancing between those short-term and long-term outcome?
No, thank you. It's an excellent question, and having worked in health analytics and outcomes measurement in Oceania, the US, and now in this region for 2 years, it's something that is definitely not a set and forget approach. It's not that we come up with the strategy and just hope that that's going to happen. Of course, we need to have key performance indicators, key risk indicators. We need to be having clearly assigned benefit owners, benefit realization plans, but importantly, having both a formative evaluation as well as a summative evaluation of how our initiatives or our proposed systems changes are going. And picking how we do that is critical. It's always a good idea to look closely at the quadruple aim and ensure we're taking a balanced view, making sure that we're improving cost efficiency, making sure that we're providing better patient outcomes, better population health outcomes, and importantly, along with investing in the workforce, better clinician outcomes, because we know that clinicians that are enjoying their work do better work and have better care provided to patients. So selecting a bunch of indicators, almost like a balanced stock portfolio from these domains, but also some long-term downstream indicators like reduced hospital admissions. Although this can take some time to see materialize, it needs to be balanced with some more early indicators like training, better understanding, improved satisfaction scores at the time of service. And when you have this balanced view, then you can get a good indication of what's working and what's not, and whether you're tracking towards achieving those targets and those benefits that you set out to. And the last thing I would say is, particularly as the clusters are moving through their stages of maturity, and in the system where there is perhaps not yet enough guidance around a framework to measurement, in the absence of guidance, people will choose their favorite indicator. Every clinician has their favorite set for joint pain. Everyone will pick something different for patient-reported outcomes. This makes it very challenging as a system to compare, to look at our peers, to say what are we doing well and what can we learn from over here. So having some kind of standardization, some kind of framework around, we all will at least use this patient outcome measure or this NESET measure, at least means that as we work through the system changes, we can have a coherent and fact-based understanding of what's working and not working to hold ourselves to account.
Excellent. Now we heard about how we set the priority for the transformation, as well as some tricks or probably tools that we can do the measurement. I would like to end up this discussion with some highlight from you, Professor Awad, about some pain point that we have within our system, particularly the fragmentation that we have. Because fragmentation remains the biggest barrier within any healthcare system. From your opinion and your experience, how can executive leadership enable integration, a team-based model of care rather than fragmentation and soiled care?
لقد سئلت عن عظيم. So let me ask the audience, with the decision of making an integrated system, it's a departmental based or an executive based? So who believes it's a departmental based? Raise your hands, please. Okay. It's a tricky question. Who believes an executive-based? Raise your hands, please. So most of the audience, they believe an executive-based. And I believe, and I do agree with you, and I believe the decision of making an integrated system, it doesn't happen organically. It's a decision of the executive. When the executive, they redesign the whole system based on accountability, based on patient-centric, based on a patient journey, we can see a different results. Let's give an example, just to make it easy. An orthopedic patient. So is it a responsibility of the orthopedic department? So we'll visit the orthopedic surgeon, will be treated, will be sent to radiology, then will be sent to physiotherapy. And again, if it's a departmental based, the orthopedician will tell you, I have done my job, it's finished from my department. If it's an executive based, the whole departments will work together from the call center till the pharmacy at the end to work together to make the patient journey optimal. So again, if you design the system to collect, to measure, to incentivize every part of the whole journey, you will move the system from a fragmented to integrated system. Otherwise, will remain always fragmented. Thank you.
Thank you, Professor Awad. Your transparency will encourage me to highlight our final point about another pain point in the system. I'll handle it to Dr. Faisal. Data and performance indicator can drive transformation, of course, but poorly designed metrics can also create unintended consequences. And I believe most of the audience may argue with me about this. What's the right tool as outcome measurement, and how can we, as a leader, ensure KPI that will improve the healthcare rather than create administrative burden?
Okay, that's everybody's pain. KPIs is, nobody likes KPIs, right? Who loves KPIs here? Oh, mashallah. You must be working with quality departments. Okay, yeah, KPI is something that we have to live with, or outcome measurement in general, something that we have to live with. You cannot be doing any work while nobody's measuring it and you claim you are successful. You yourself, we need to know if what you are doing makes sense or not, if it's successful or not. But we have two issues with KPIs. One of them, and I always said that, anybody can put a KPI and make it adopted. Only one person in the ministry can remove KPIs, His Excellency the Minister. That's why you end up with thousands of KPIs. Maybe 90% of them don't make any sense. So how do we deal with this? Whenever a KPI comes, and the other problem with KPIs is we always look at them as an end result. And this is, we achieve the KPI or not. So I would suggest three things. One is whenever there is a talk about a KPI or an idea about a KPI, we have to ask ourselves two very important questions. One is, does this help patients? Like measuring this outcome, does it help patients? Does it reduce harm? That's the first question. Does it do one of the two, or maybe both? The second is, can we do something about it? Like if it shows us the KPI is good or bad, does it lead us to do something? If it's bad, to fix it, or if it's good, to do something else on top of that. So before you accept any KPI, you have to ask the person suggesting this KPI those two questions. Does it help or reduce the harm of patients? Can it tell us what to do next, whatever the result is? The second thing is we really have to focus on leading KPIs, that we can do something about them, and outcome-based KPIs. And we need to have less lagging KPIs and process KPIs. We still have to have both, but we have to have more of leading KPIs and outcome-based KPIs. The third point is you have to measure the KPIs that people can do something about them. if you are showing the KPIs for frontliners, they have to be focused on the processes they do every day. So whenever they see something good or bad, they can actually do something about it. While if we're showing this to leadership, we have to show trends, variations, trajectories, and most importantly, risks, because that's what they need to deal with. You cannot show them daily activities, KPIs, otherwise they will get stuck into the daily operations. But they need to know what is the direction of the organization, where is it going, is it getting better or worse, and most importantly, what are the risks associated with anything we do, because one of the most important functions of a board is managing risk. The last point that I want to reemphasize is we need to always to look at KPIs as a learning tool. Do we learn from the KPIs? Do we learn from these reports? Do we do the right analytics? Do we do the right thinking? Are we getting the right lessons from the KPIs? Are we changing the practice? Are we improving patient outcomes by looking at any specific KPI? Let's not penalize people, but let's look at what can we learn from the KPIs and the KPI reports.
Excellent. Thank you, Professor Faisal. Sure, please.
Just let's to entertain the discussion. I love the comments by Professor Faisal, and I do agree totally in it, especially looking to the process and processes. Often, what's the problem of a healthcare system? It just, most of the people, they copy and paste what they learned earlier. Well, they learn in medical school, and they live on it for another 30 years. And this is not absolutely the right way how to do it. And I think always, as mentioned by Dr. Faisal or Professor Faisal, always you have to go on a trend and you have to look to the data carefully and you look to the problems. When you look to the problems, you can redesign the process and processes the best. For example, and here we have a great ER physician, Dr. Saad Asiri, and I worked with him for years. Always when we look to ER, then again, where is the problem in ER? Then we sit together and we play with the process and processes to solve a problem. So that's typically an innovation, because people, they think always innovation is just bringing something like an iPhone. It's not. Innovation is just playing with the process and processes to get a different results. It's different from an invention. So always I would recommend all the healthcare workers, they go, where is the problem, and try to innovate a new process and processes. Sometimes you will find the process of 7 steps, you will make it 4 steps, it totally makes sense. And let's just stop the way of we think usually, هكذا وجدنا آباءنا. This is the standard, this is the policy, I will not change it. Often who wrote the policy? We are the one who write the policies, and we are the one who can change the policies. So always feel free to critique and to think about redesigning the process and our processes and a healthcare system. Thank you.
Thank you, Professor Awad. This is very informative and a very helpful point. How can we design the process and procedure that can help us leading to this transformation? I want to end up with you, Dr. Godho. How should the healthcare system build a partnership to achieve what Professor Awad mentioned about designing these processes and procedure beyond healthcare, such as education, municipality, to address social demand as well? Can you please?
Yeah, I'm glad we're talking as well about the social determinants of health, because as we know from the literature, 80 to 90% of the health outcomes are influenced by the social determinants of health. When we're trying to understand who's most likely to return to the emergency department, quite often it's about whether or not they leave the emergency department in a taxi or with a family member. If we're trying to provide an intervention for people to receive dialysis, that's very tricky if they don't have stable housing or they have a long way to travel and it's very inconvenient for them to make their appointments. So we need to work together with the education sector, with also the social sector, to make sure that we are wrapping the support around the most vulnerable beneficiaries in our geographic area, so that we can really achieve the full outcomes that we're trying to drive. And critically, for those vulnerable populations, there's a lot of literature on the life course or life trajectory or trajectories of disadvantage or advantage, and particularly in the early years of childhood. There's a very limited period of time to alter that trajectory, and if we don't address it, that individual is set up for a long lifetime cost that far exceeds that of others, and there's not a lot we can do to rectify it at that stage. So it's very important that we pick up early in school through the medical checks and otherwise those kids that need the extra supports, whichever part of the social aspects or income disparity or whatever it may be, so that we can make sure that those social determinants aren't negatively and adversely impacting in a system where already we have financial sustainability issues with increasing year-on-year costs to deliver care. It's very important to jointly work with the other sectors.
Excellent. Thank you, Professor Awad and Professor Faisal and Dr. Tim for this very informative session, and we'll handle it to the organization committee. Thank you. Thank you.
Thank you to our moderator, panelists for such an amazing discussion. As we move forward, we shift from the broad healthcare outcome drivers to more of a focused example on how models of care translated into practice. Maternal and newborn health offers a clear lens on how system policy, clinical design, and system integration come together across the care journey. And to continue this conversation, please allow me to introduce and welcome back Dr. Nawal Noor as she returned to the stage now to share her perspective. Dr. Noor.
Hear me? Yes. As many of you may have heard in the prior panel that I was at, I was talking about value-based care. This is not going to be that conversation. This is sort of care in the most extreme form. I'm still talking because I'm waiting for my slides to come up, but let me introduce myself, Nawal Noor. I'm originally from Sudan, and I actually did most of my medical education in Boston at Harvard Medical School and then Mass General Brigham. It is an honor to be here and also to have women's health be a part of this program throughout the 2 days. So I really wanted to appreciate the organizers. There we go. So what I thought would be really interesting right now is just talk a little bit about multidisciplinary care in its top form as we think about providing care to our patients. I'm blessed to be in charge of a Department of Obstetrics and Gynecology where we've been named the #1 hospital at the Brigham and Women's Hospital for 4 years for the Department of OBGYN, and it's been an honor to be leading so many exceptional providers and teams. So what I wanted to talk a little bit about was sort of the multidisciplinary care and how do we do, how can we really work this well? And think about complex obstetric care. There's going to be some IVF cases. There's also going to be fetal surgery cases, as well as gynecologic cases. And I will promise you I will get this done in 25 minutes. But I really wanted to also get to a sense of like, how do we think about reviewing the equity-informed, high-reliability organizations? And before I get going, has anybody heard about equity-informed, high-reliability organizations? There's a few people. I'll talk a little bit about it, but there'll be others who will also mention it later on. So here's the story, okay? And I love telling stories if you don't know me by now. You have a 25, and these are true cases. Some have happened a few years ago, and one just happened last month, which I'll fill you in on. A 27-year-old patient who had a placenta precreta and a previa. That means that the placenta is stuck to the uterus, and it actually is closing over on the cervix. Emergently, she was taken to the operating room. She had a stat C-section. She had a hysterectomy because the placenta was so stuck to her uterus. Postoperatively, she was stable, and then she started complaining of some pain. So they decided to send her down to the CAT scan to just make sure, was she bleeding or not. And in fact, she was bleeding, she was hemorrhaging vaginally. She was stabilized, she had a uterine artery embolization, she was transferred to the ICU, then to postpartum recovery, and it was eventually discharged on postpartum day 5. So stat section, ICU, and then discharged home. The neonate, because the 27-week was early, went to the NICU, the neonatal ICU, and was discharged home 2 months later. So both mom and baby are doing exceptionally well now. So before I go on, I'm just going to I like this audience participation. How many people feel like this was a great outcome? Great. So was this a successful outcome? I would say in the end, as you think about it, yeah, mom and baby are home safely. But from our perspective, there were 3 safety reports that were filed. And a safety report is when we think that the care was not delivered in the exceptional way that we wanted it to, with the kind of quality that we accept in our hospital. It was complicated. There were a lot of people involved. You had the nurses, the maternal fetal medicine, anesthesia, blood bank. We had, she had a uterine artery embolization, so interventional radiology. We had ICUs, MDs, we had the NICU. So many people taking care of this patient. So what's the problem with that? The problem was that when the patient was actually complaining of pain, the patient didn't feel like she was heard, and the provider, who was a resident, didn't feel that she was heard either. And the resident said, I think there's a problem with this patient. And nobody was really paying attention until it became an emergency, and then she was then taken to the CAT scan. And so, again, how do we listen to our patients, and how do we empower our providers and our patients so that then when they say something is wrong, we actually believe them? So this is a long slide where it talks about lack of clear system protocols. There was an issue when we were transporting the patient. There was nothing in the bed that would help when we needed to take care of her as she was hemorrhaging. So there's a lot of aspects to this care that we could have done better as a system. And so the equity-informed care looks at the system breakdown. How can we make it better? Human performance. How can we communicate better? How do we miscommunicate? Could the resident have actually gone to the attending and said, I'm really worried about this patient? Did the attending go, never mind, don't worry about it? And then how do you escalate that more? And then behavioral choices. What do you do when you're not feeling heard, and how do we update? And so the quality improvement interventions were really so that this case doesn't happen again. She should have never gone to the ICU. And so our goal is ICU beds really should only be for patients who come in and need the ICU, not from a case that we could have prevented. And so this is one of those scenarios where the multidisciplinary care team didn't quite work well. And so from a human performance perspective, we need more huddles, we need to debrief, we need to think about it, how could we have improved the situation? And then escalating without blame, because there's a lot of finger pointing. Well, I told them, and she told me, and he said that, and no. We're trying to think of systems of improving the quality of care at the end. So now I'm going to talk a little bit about what MGB does great. And so these are multidisciplinary teams that really do impact the care of our patients in a most phenomenal way. So here for REI, it's an IVF example. And these are cases, the names, some of them have been changed and some of them have not because they've actually been published in the media or in some of our journals. So Melissa is this incredible patient who has actually spoken to our board members and has come and spoken a lot of times about her experience at Brigham and Women's Hospital. She was 38 years old and was diagnosed with unexplained fertility. She had IVF. Evie was born, and unfortunately, Evie passed away from SIDS. So weeks later, she was then diagnosed with breast cancer, like truly traumatizing for Melissa. And she needed to do a double mastectomy and have chemotherapy, but and XRT, radiation therapy. But before that, we sent her to the IVF folks for fertility preservation so that she could actually, after her surgeries and radiation, she could get pregnant again. And with that, in fact, we were able to use her eggs that were previously frozen. She had a daughter born in 2021 at 24 weeks, again, needing to go to the ICU, the NICU, and then the pregnancy with a second baby now. And this is demonstrating how we have like the breast surgeons, the radiation oncologists, we have IVF, we have the nurses that are taking care of all of her care on the phone and in the hospitals. We have the maternal fetal medicine doctors. We have so multidisciplinary care with really great outcome. When they debriefed about her and when she talked about her care, she talked about how she felt heard, and the providers who took care of her really felt good about her story. This is Sarah, fake name, fake picture, who was a 7-year-old diagnosed with brain tumor. Truly, several of these cases come to our hospitals for care. And one of the things that we are really ensuring and promoting is that even if you are 7 years old, you have to think about your future, not just the cancer today. So we inform the families that, yes, your daughter has cancer, but she may one day get pregnant, get married and get pregnant, so let's think about her future. So she ended up going to the fertility preservation program with ovarian tissue freezing. And again, thinking about the multidisciplinary team, how do we guide families from the trauma of my daughter, my 7-year-old daughter has cancer, to, hey, one day she's gonna get married and have kids, inshallah. So thinking the multidisciplinary care, what we think about for patients big and small, and the care of their future. So the other things that we do that are really cool, and I like to use these words, but we really do some pretty amazing things at Mass General Brigham, and fetal surgery is one of them. And this is also one of those exceptional teamwork things that almost seem seamless with their outcome. We operate on the fetus in utero, so through the belly, into the uterus, and into the fetus. We repair cardiac anomalies, vascular brain malformations, we repair neural tube defects, and numerous other procedures. So this is one of the first that we did at the Brigham and Women's Hospital, and we've done this for quite a while and established a team that has now collaborated internationally throughout the world. And this was one of the first cases. So he ended up, John had a fetal aortic valvoplasty done in 2009, and he was diagnosed at 25 weeks with this condition. Now, this condition tends to get to hypoplastic left heart syndrome, which is a problem with the heart, and the rate of technical success with our consistent multidisciplinary team is about 80%. As the data goes on and we keep collecting data, our numbers and our metrics, as we talked about quality, keep improving because our teams are getting better and better. People say, why do you have grapes on your slides? Well, that's the size of a heart of a fetus when our great surgeons actually operate. So through mom, through the uterus, into the baby, operating on the size of a grape to repair a heart is pretty remarkable. The procedure itself is about 90 minutes. There's 5 minutes within the fetus. So again, size of grape within the fetus, 65% on first pass, and the majority are discharged the next day. And again, we talked a little bit about length of stay and how do we think about cost, we are always considering how do we discharge patients so that they don't stay in the hospital that long. Lots of simulation. So practice, practice, practice. The teams come around, they talk about it. When we try to train the younger physicians to come through, we train them through simulation until we get to the point where we're actually doing the procedures under ultrasound guidance over there. So our outcomes have been remarkable. And one of the things that I always like to say is, yes, we are doing innovative work, but innovation is not successful until we publish it, right? Until we actually are able to tell everybody this worked or this didn't work, and these are our outcomes. And in some ways, although we are competitive, we want you to do better. So hopefully by talking and incentivizing you, you will think about, oh, we could do this, or maybe we are doing this, but let's do it better than other places, because in the end, we want the outcome for our patients to be the best. And so lots of manuscripts, you can see from 14 to 33 to 7, depending on our prenatal diagnoses and tracking and improvements in our challenges. We also operate in utero. Here's another really great story of a patient who was 31 years old, and she was 20 weeks with a fetal open neural tube defect. Same thing, underwent the procedure and had an uncomplicated procedure and now is currently pregnant. So this is one of our, we'll wait and see what happens, and hopefully next time I come, I'll be able to tell you her story. The other thing that I think is really probably our true exciting aspects of in utero surgery, fetal surgery, is this vein of Galen, and it's gotten a lot of publicity throughout, like CNN and NBC, and this particular story of baby Denver, who had the vein of Galen, which is an issue with the brain, repaired. So in utero, placenta protects the fetal brain from volume overload. The delivery was 70% of the cardiac output goes actually to the brain vessels. Babies do well in utero, but once they're delivered, they actually don't do very well. And so again, the way that the procedure is, ultrasound guidance, taking this tiny little coil, and this is smaller. I showed you the grape before, but this is even smaller than a grape, to demonstrate that, in fact, you're actually doing the repair of the vein of Galen. So Denver was born at 35 weeks. And there was no supportive medication, respiratory and cardiac functions were normal, and the brain imaging was without damage. Again, I'm just showing you publications of where some of these were done. And again, this was a multidisciplinary team. So you have the neurosurgeon, you have all the nurses, you have the maternal fetal medicine, you have genetics, you have all of the different teams that think through how to make our surgeries great and how to make them better. So with debriefs and huddles, but also with lots of simulation and a lot of alignments of thinking through the anesthesiologists as well, who are part of it, and how to ensure that the patients are safe. We're constantly thinking, how do we do this better and how do we become even more innovative? And what's the next procedure that we need to do? So we've talked about the heart, and we've talked about the neurotube, and we've talked about the brain, but there could be other procedures that we could do in utero that we haven't gotten there yet. The final case I wanted to talk about, and again, what I love about these talks is that I think when people think of obstetrics and gynecology, they think of us as like, oh, they deliver babies, right? We are surgeons. And so as obstetricians, we think about this innovation. We think about using AI. We think about the next steps of teaching the next generation. And so here's another case, and we do cancer. We do a lot of, and our gynecologists don't just operate. We're one of the very few fields where gynecology oncologists actually deliver chemotherapy. So we're both gyn-oncs and med-oncs at the same time. And there's always little squabbles of should we be doing med-onc, but we actually are delivering chemotherapy to our patients. So here's one of the, a case that happened a month ago. And so I want to say our team arrived around 1 a.m. yesterday, and I'm still texting the surgeon about this case. So this is, as we say, hot off the press. She was in her usual state. She actually worked at Mass General Brigham, so she was in the hospital, and she had a syncopal episode. And she underwent chest and imaging. They did imaging from top to bottom, actually. So again, please forget about what we were saying before. This is like high-cost care. And I don't want to go through all of the details here, but the point I want to make is required to take care of her. Bottom line in all of these tests is she had a large mass in her pelvis, but also around her heart. And so we had all these consults. We had the cardiac care unit was involved because the mass was around her heart. We had the pulmonary team because she was having trouble breathing. Remember, she had a syncopal episode. We had cardiology as well. The ECMO team was consulted because they knew that when she needed her surgery, she was going to need to be on ECMO. Med-onc was involved because it's a mass. Gyn-onc team was involved because the mass also was in her uterus. Cardiac surgery was consulted because they needed to ensure that she was going to be okay, and vascular as well as urology, right? So lots of people and lots of opinions and lots of thoughts. So when you think about your teams, do they always get along? Do they always agree? Do they always think that? This was a pretty poignant team who all they wanted to do was take care of the patient. And that was their north. That was their due north. We need to make sure she lives at the end of this. So again, I was getting pictures of this yesterday. This is the case where the surgeons were operating on her chest, her abdomen, and pelvis. And when I texted last night, I was like, how long did this case last in the operating room? 10 hours. 10 hours in the operating room with all the various surgeons on ECMO with the anesthesiologist helping support her to remove all of the things that needed to do, the masses. And here were the different types of cancers that were seen around her different organs. And she had a pelvic mass, she had an IVC mass, and she had a cardiac mass. She had an uneventful recovery, which is, again, the good news story. She recovered in the cardiac surgical intensive care unit. Post-op day 1, she was transferred out. Post-op day 5, she was transferred to Gyn-onc. Post-op day 9, she was discharged home. So remember, this is a woman who, at a certain point, we would have all thought, she's not going to make it. Post-op day 9, she was discharged home. She was diagnosed with a benign metastasizing leiomyomatosis and was given one med orally. That's it. I think the point I wanted to make, and when I asked the physician last night, the surgeon last night, and I said to her, so how long did it take? 10 hours. I said, what are the lessons learned? So you debriefed, you had consults, you thought, you called your colleagues elsewhere. Not her herself. Everybody was thinking about this patient. You reached out to colleagues. And so what was the lesson learned? And this goes, and that was the argument, wasn't so much of, they were so focused on her and wanted to take care of her that in the end, they all agreed that she needed to go to the right places. And so I think that's the lesson. It's not meant to point fingers or assign blame. It's really just meant to get to a point where we say, as a system, can we improve? And we think of equity in mind so that all of the care that we deliver to our patients should be equitable. We look at system reliability, like where did it break down from a system perspective? We look at the human reliability. Did we patient needed? Did we look at our behavioral choices, like assessing what we brought into this? And then the organizational reliability of applying a balanced response to both the system and the human response. And so with some of the cases that do have, we have a team of people who do this high reliability, who come in that are not part of the care, who are scrutinizing every step of the way, saying, how could we have done it better here? Should we have had a system here in order to ensure that our outcomes are great? And with that, I hope you now are going to take home with you that we are OBGYNs that do a lot of exceptional care, but really we don't, you can't take care of a patient without a team. And the teams have to think about working well together and communicating well. So if anybody as a part of a team walks away and says, I didn't feel heard, or I didn't express myself well, or we should have thought of X, Y, and Z to care for our patients, then we have a breakdown. And with that, I want to thank you again for this opportunity, and I appreciate it.
Thank you, Dr. Noor, for sharing just a practical insight on how model of care applied in care delivery. As we continue, we will be shifting from clinical models to the system that sustain them at scale. And as model of care evolve, all of us know that by now, digital transformation.
So we implemented a number of solutions that you might encapsulate them in what you call a hospital without walls. So virtual care. You want to provide services to patients remotely if they don't need to come to the facilities physically. On the operations side of the healthcare system, think of HR, finance, supply chain, and the other operations staff. You also want to provide them access to the services so they could do their jobs also remotely. On the clinical side, we really wanted to increase the digital maturity of the business processes, so we reached 100% paperless documentation across all of our facilities. And we also unified our electronic medical record across all of the hospital system. And for all of the staff, we wanted them to be able to collaborate, to work together without the physical barrier. With a virtual collaboration platform, they could chat, they could collaborate around documents, they could meet virtually, and that's all before COVID-19. And on the operations side, we also increased the digital maturity, so you don't focus on the clinical and you leave the operation parts, you end up with an uneven digital transformation. And the timing was ideal, actually. We were about to debut our children's hospital in Riyadh. It's a 400-bed children's hospital. You might call it, at that time, our greenfield, perfectly positioned to be the nucleus of our digital transformation. But there were challenges at that time. And the challenges, although we implemented all of these solutions thinking that this is digital transformation in the end, that was a scattered kind of approach. It wasn't really systemized. There was unclear roadmap. We also ended up still with some disconnected systems, and culture challenge was still there. We didn't have a methodology that would deal with culture challenge in a very effective way. So in essence, we knew that digital transformation was the way to go, but we didn't know where to begin. And at the macro level, and I'm sure my colleagues here before me have talked about a lot of the global challenges. And one of them, take for example, the healthcare costs, which we share the global challenges as a hospital system. I mean, 1/10 of the GDP of the country is going to go to healthcare in a few years from now, which is an enormous chunk of the production of the country as an economic production. Aging, which probably it's on the horizon. If the slowdown of the population growth continues and maybe plateaus, we might start seeing also the population, or the aging population challenges here also in Saudi Arabia. So that's something we're probably gonna have on the horizon, or we had on the horizon at that time. Also chronic diseases. 23% of the Saudis are diabetic. I was looking at the stats just recently. 1 in every 4 Saudis is hypertensive. 24% of Saudis are obese, and you could go on and on when it comes to the chronic diseases. and has a hospital system that focuses a lot on preventive care, that's a major concern. Again, it reflects on digital technologies that you implement and you plan to implementing in the future. So in addition to all of those, we had also challenges that you might add, and they are more strategic. So inconsistent care quality. If you have a hospital system, you're going to have it definitely, multiple facilities. They're going to have different kind of standards and end up with different kind of care qualities. And even within the same facility, you're probably going to end up with the same issue between one department and the other. That might be an issue. Fragmented workflows is another issue. Limited access in remote areas. We serve a lot of patients in remote areas, and we want to provide them with the same level of healthcare quality and accessibility to the patients that live in large cities as well. And the ever-escalating cybersecurity threats, especially with the emergence of AI. The last studies were talking about close to 80% of cybersecurity attacks nowadays are AI-enabled, whether fully or partially. AI has made cybersecurity attacks more accessible and more effective. Many of you probably could recall the recent incident that occurred a few months ago in October of 2025, where a teenager with little to no technical knowledge, let alone cybersecurity expertise, was able to launch a large-scale cybersecurity attack on multiple organizations using agentic AI. What he has done is he has requested and instructed the agentic AI to scan the landscape, identify vulnerable organizations, exploit the vulnerabilities, encrypt their data. It was a ransomware attack. And not only that, he was lazy enough to request from the agentic AI to request what amount of ransom from each organization based on the revenue of the organization, the status, the situation of the organization, what amount he's going to ask. And even beyond that, he requested from the agentic AI to write the emails to be sent to those organizations. This happened. So if that doesn't wake us up at night, I don't know what, whether you are a CIO or a hospital top management administrator. Also, unstructured technology adoption in many places. Again, many organizations think that they are excelling in their digital transformation by seeing some areas within their hospital system or within the same facility implementing advanced technology capabilities, but others might lag significantly, which is in the end going to end up with more issues than benefit to the whole and overall organization. So how did we tackle all of those? Maturity models, digital maturity models were our effective solution. They provided clarity, credibility, and structure. And in healthcare, there are a number of maturity models from many organizations. Some of them are popular, others are not. But the Health Information and Management System Society, HIMSS, provides some of those popular maturity models for certain areas. And we did actually adopt many of them. And MRAM and OMRAM, so one of them targets the inpatient setting, trying to increase the digital maturity within the inpatient. The other one is the outpatient setting, optimize care for us. AMAM, which is the analytics maturity model provided by HIMSS, provided us with visibility and insights. Infram, which is the infrastructure, it focuses on the infrastructure of technology in the organization, ensured for us performance and cybersecurity. And the CCOM, which is the community care model, provided us or connected the dots for us between the hospital, PHCs, and the community care that we provide to our patients. Taking on multiple maturity models at the same time is really an ambitious kind of approach, but it worked in the end. There was a lot of challenges, but we were able to overcome many of them and mitigate many of them. In the end, the outcome would be a holistic transformation, a stronger ROI, and you're going to build resilience in the end. Resilience, I think, should be one of the strategic objectives of organizations nowadays. I mean, it used to be accessibility to healthcare, quality of healthcare, patient safety, and maybe cost efficiency. But I think after the pandemic of 2020, maybe resilience should be added to those strategic objectives of any healthcare organization. So a little bit about the Ministry of National Guard, Health Affairs, الشؤون الصحية بوزارة الحرس الوطني. We're a hospital system that serves the National Guard service members of Saudi Arabia and also large portion of the population. We have healthcare facilities scattered across the kingdom from east to west, north to south, and we have a unified medical record electronic across all of our facilities. We're on one electronic medical record system in all of our facilities. Our journey with digital transformation has been long but rewarding in the end. What's important is outcomes, which I'm going to touch on maybe later. But in the end, we became the first healthcare organization in the world to achieve the quadruple, which is 4 HIMSS Stage 7 accreditations. It's an exclusive club that we probably have debuted. There's only 2 healthcare organizations in the world currently that have those 4 Stage 7. Stage 7 is the highest level of digital maturity that you could reach based on the HIMSS maturity models. But HIMSS is not the only maturity models and certifications that we rely on. It's a holistic approach. We rely on all of those to be almost like our North Star collectively that helps us during the digital transformation journey recorrect the path and the direction. So in the end, we're moving in the right direction during the digital transformation journey, guided by many of those organizations and more. So we rely on local entities as well as international entities during the journey. Take, for example, the Digital Government Authority, which assesses all government organizations, not only in healthcare, based on their digital maturity. In the last assessment a couple of months ago, the announcement has placed MNGHA second among all of the government organizations. And in healthcare, we stayed in the first place for the 3rd year in a row. We also rely on the National Cybersecurity Authority of Saudi Arabia. And again, that's the important kind of point that I want to make here, which is you really want to excel when it comes to digital transformation, but at the same time, you want to solidify your gains. You don't want one back-end failure to render all of the digital transformation gains useless. You don't want a cybersecurity attack to provide or to end up being more of a situation for you that's worse than not having those digital tools. So focusing on high availability, so redundancy across the infrastructure is important. So high availability setup, disaster recovery infrastructure. So if one of your components, even a complete data center, whether it's in the cloud or on-premise, is not available, another one would take over. And you want very strict and strict compliance with cybersecurity measures and controls. And the National Cybersecurity Authority of Saudi Arabia, they provide very solid controls that you could follow on the essential cybersecurity controls, the critical systems, data cybersecurity controls, social media, et cetera, et cetera. What you also want to plan for is business continuity. There gotta be business continuity plans, because if it could happen, as Murphy's Law goes, if it could happen, it will happen. You will end up with failures, no matter what you do, with high availability, with disaster recovery, with all of those cybersecurity measures. You're gonna end up with failures, and you have to have plans where business could continue. You could still receive the patients in the ER. Your outpatient visits that are scheduled are not going to be canceled. Your care in the inpatient setting is going to continue in a safe way, even without the availability of the EMR system and the other clinical systems that are installed and implemented within the facility. Another entity, which is the world's best smart hospital list, which has some sort of guidelines. We have been in the list for 5 years now, consecutive years, and that's a very prestigious kind of list where you have 350 hospitals every year get included in this list globally in the whole world, and that's out of over 220,000 hospitals. So from 220,000, you just select 350 and include them in the list. Those are the world's best smart hospitals. And again, their guidance, not being included in the list, having the badge and having the publicity is important. What's more important is really following the guidelines, getting the indication from those entities that you are really implementing digital solutions in a proper way. That's what's really important. ISO, they provide a set of certifications where you could follow, for example, cybersecurity. In addition to the National Cybersecurity Authority, the ISO 27001, very important. For business continuity, 22301, for the quality of IT that are of services being provided, the 2000, and also for innovation, the 56002 and 56008, to make sure that you are not only implementing the basic solutions, but also innovating in your realm. Enough about awards. Let's talk about a little bit of outcomes here. So 95% compliance with closed loop workflows. These are 4 key business processes, clinical business processes, that any hospital provides. So for example, the closed loop medication administration. You really want to make sure that every medication that you administer to the patient follows the same and comply with the 5 rights. It's the right patient, right medication, right route, right dose, right time, etc., etc. And if any of those is not met, you got to have either a soft or a hard stop to ensure the patient's safety. In our case, we have implemented a hard stop. So if it's a liquid medication, the infusion pump is not going to infuse the medication. If it's not the right time, or it's not the right dose, or definitely if it's not the right patient. So same thing with the blood product. So the blood transfusion process is not going to proceed if there is any mismatch. And also specimen collection. All of the lab specimens that are taken, they have to be properly labeled, and the process of scanning and ensuring that there is no mismatch is implemented. So this will take us to having a unified barcode for every specimen that we take, lab specimen. And this allowed us actually to end up with almost 0 test tube mix-up errors, and also enabled for us a full lab automation. In our case, the last encounter that those samples have with humans is when a nurse or a lab technician drop them in the capsule and then put the capsule in the pneumatic tube system. Then the pneumatic tube system gonna go to the central lab, get dropped on the conveyor belt, get distributed to the analyzers automatically. They get analyzed, the results will be posted on the EMR accurately, without human involvement. This has shaved off around 17 minutes of every lab transaction that we have. We do around 80 million every year. So you could do the math, 17, 80 million. It's a lot of cost saving, but most importantly, the lab tests, the results themselves are arriving to the provider 17 minutes faster. Again, quality of healthcare. What you get from those assessments, from all of those entities, not only from one or the other, is in many cases those validators that you deal with, they have long experiences, and they provide you with what we call gold nuggets, not mentioned in the books or in the standards. One of them, for example, is a flag that indicates to the front desk staff that the patient is not using the patient portal. So if they're not using the patient portal, they could educate the patient about the patient portal and its services and the value to the patients. Why this is important? Because having patients engaged in their healthcare treatment and healthcare journey, according to studies, improve the outcomes in the end. And what's better to engage the patient with their treatment than to have it through the patient portal, so they could see their lab results and the clinical information, and also have easy accessibility, convenient accessibility to the healthcare services provided by the healthcare organization. So what were really the enablers from a strategic point of view for us? So strong leadership, buy-in, and also championship was really a major enabler for us. A structured governance, a stakeholder engagement, phased execution to do it in a safe way, and you don't really interrupt any of the existing business processes, and also metric-driven decision-making process. Technology is just part of the picture. I mean, the larger portion of the picture is related to humans, humans that drove the journey, a committed group of healthcare provider champions, constant feedback, unified communication, and phased removal of legacy systems. Only legacy systems, not clinicians, by the way. What do we recommend to any organization who want to learn from our journey here? So start now. Even if it's imperfect, this is going to give you an understanding where do you stand. Align technology with strategic objectives, not technology trends. Nowadays, the buzz is all about AI. A few years ago, it was blockchain. Between AI and blockchain, it was the metaverse. Continue chasing those shiny objects is not going to get you anywhere. It's not going to really allow you to achieve the strategic objective of the organization. Invest in the digital infrastructure. That's really important now and in the future, and that's given. It's going to be needed in the end. It's not going to be wasted. That's a major, major investment. Engage clinicians early in the process. Co-ownership reduces resistance during the implementations. It's a difficult kind of process, and you need partnership with a very important entity, which is the clinicians. And also govern with metrics, using data. Data beats guessing every time. Thank you so much for listening.
Hazmi for sharing such an impressive experience at National Guard. We will break now for a coffee prayer break for 20 minutes. We will be back at 1:05. Please be back promptly to resume our sessions. ضيوفنا الأعزاء، الرجاء العودة إلى القاعة الرئيسية حيث نستكمل برنامجنا العلمي. Our guest, we would like to welcome you back to the main hall to resume our scientific program. Thank you. Welcome back, everyone. I hope you had a wonderful break. We will now continue with our program, and as we continue, we will be turning to precision medicine and its role in shaping the future of care delivery. And to take us into this discussion, we are joined by Dr. Ahmed Al-Fares. Dr. Al-Fares is Deputy Executive Director at King Faisal Specialist Hospital and Research Center for the Genomic Medicine Center of Excellence, where he leads an initiative in genomic and precision medicine on a national and international levels. Please join me in welcoming Dr. Al-Fares on the stage.
Assalamu alaikum jami'an, ahlan wa sahlan. So it's really an honor and privilege to be with you today, share our experience in implementing precision medicine at King Faisal Specialist Hospital and Research Center. I hope in the next 25 minutes or less, I will walk you through what is precision medicine and what is the goal and what we do with precision medicine. So, to start with, if you are in a clinical facility or any clinical care, you would go with this process to evaluate any of your patients. Usually you go with examination, you will do your blood testing, and then historically we do single gene in genomics, and then we do more larger panels, and then we do now something called whole genome sequencing, where we test all the genomes in each individual. This shows you the evolutions of genetic testing, which change what we call precision medicine. So when I started my fellowship, we used to do single gene. We look for one particular disorder. Now we moved to, at one time, we can scan the whole individual, whole genome, and we learn. And I will show you the value now, why this is important, not only in genetics, but in the all precision medicine. So we believe the genomics and the whole genome, which is the king of all tests. Why? If you are in the clinical care, all these tests, which used to be genomics testing or genetic testing, which are very complex testing, it can be now all replaced with one single test. And this shifted the evolutions of providing the clinical care to go way beyond just rare diseases. And then, if you get tested for genome testing for any disease, we would give you why you have this, and then there are other more information important related to your health care.
For example, would you deliver something in the future based on your genome? And then the third one is, are you a carrier for specific diseases, which is very related to our populations who are consanguineous populations. And this is, well, when we talk about premarital, فحص ما قبل الزواج, that's something very important that we want to apply, premarital marriages. And that's something we know by knowing your carrier status. Then, in genomics, we always say it's take too long time. Now, this field shifted dramatically, and now we can have a results in a very fast way in only 30 hours. If you are a healthcare provider, this is faster than MRI, faster than echo, faster than blood culture. It's one of the fastest tests now, can help and aid the diagnosis, mainly in the critically ill babies. But that's not the purpose why I am here to lecture you about why genomics is important in rare diseases. I am here to present to show you how this genomics testing can go even beyond just what we think is rare diseases, where genomic testing are being applied for each subspecialty, for each one of us in this room, and how we utilize it. And I will share our experience at King Faisal. One, if you are working in OBG and obstetric and gynecology, genomics, we used to do an ultrasound and alpha-fetoprotein. Now, by taking simple blood sample from the mother, we can know what is the gender of the baby. Does the baby have a particular syndrome? We can predict during pre-gestational testing for a pregnant woman or an IVF, which embryo we return. And then we can do testing for the whole fetus, for example. A usual practice in genomics is using ultrasound and theta alpha protein. It's completely now shifted to use genomic testing that has been replaced. So this is one. Two is pharmacogenomics. So we know now if you get a medication, based on a larger clinical trial, we will say, yes, this medication will be right for you or no, and then, or this medication is not right for you or no. We implemented pharmacogenomics and knowing which exactly drug is right for you based on your genome profile. And believe it or not, this is one of the booming market in the healthcare, and the Congress in US wants to forces by law, each drug before you prescribe it, you should have pharmacogenomics profiling. Why this is very important? We have done a local study in King Faisal, and in this room, around 70% or 30% of us in this room will change our medication based on our genome, and this is our local population. For example, a statin, which is the #1 anti-hyperlipidemia, maybe you don't need to take it or give you side effects. And based on your genome, we can immediately tell, yes, this is the right drug and this is not the right drug. And this is not a rare disease. This is a precision medicine. This is how genomics changing the healthcare. And we have published this, we shared it. That's how we are changing, how our experience in pharmacogenomics change the medications for our patients. And we are not stopping there. We are pushing genomics to be part of the electronic healthcare. And this is one of the areas where genomics is not a difficult thing. Genomics is an easy thing. It will be part of the electronic healthcare. If I prescribe XY disease, then an alert will show, no, based on my genome profile, you should not take this medication. You should take XYZ other medication. And this is something we implemented called Clinical Decision Support System, something we implemented at King Faisal to guide the physicians. Genetics also in cancer, God forbid. Before we treat all patients with one trial, we give them a trial of chemotherapy for 3 months, 4 months, 6 months, and then depending on the response, we change the chemotherapy. Now, we can predict exactly what is the right chemotherapy, is this genes are responsive or not responsive, and this is a targeted therapy. A liquid biopsy. Before, we need to go with an invasive procedure to take a sample from the biopsy. Now we don't need to do this. We can tell from the blood sample, which has DNA cancer, does this individual has or how the progression of this cancer or tumor. And this is it's just from the simple blood sample. we can predict the cancers. Now, in microbiology also, genetics has a major change in this. We can now do sequencing for all the non-human DNA in your body. And basically, this is simple to a tissue culture. So if you send a sample to tissue culture, that will grow only bacteria. We're using metagenomics, where we sequence everything except your DNA. Is there a viral? Is there a bacterial? There's a story that I always tell at King Faisal, a patient who came with an organ transplant. And then that patient was very sick in the ICU. We did everything. We couldn't understand what's happening, why he has sepsis. And then a sample sent to us to do metagenomics testing, and we identify that this individual has a microbiome fungus causing his sepsis. This fungus living only in horses. It's never been seen before in humans. Then we treated him with antifungal. The patient recovered. We asked him, from where you get your kidney? It was outside the country. He got his kidney in the farm horses. And this is where he transmitted this fungus that has only existed in horses. This would never be think or thought of unless we do something like this, where we do genomics to identify this bacteria. Then, genomics also can be applied in complex disease. We want to identify, based on your genome, do you have a risk for hypertension or no? Do you have a risk of diabetes or no? And by identifying high-risk people, we can, in all these diseases where there is a predisposition, so instead of saying smoker, not smoker, obesity, not obesity, we say, does your gene predispose you to one of these chronic complex diseases? And we work very closely with our colleagues in the family medicine, where we identify at high risk of this individual, and we push them to family care. They take care of them by start early prevention. What I'm trying to say here, genomics is a part of the family medicine and healthcare. And then if you go on organ transplantation, genomics is a very essential part to find your exact match. Believe it or not, our close exact match is usually from Germans, and that's where we always exchange organs or blood between the two countries. So I hope I was able to convince you genomics is not only on rare disease. Genomics on complex disease, genomics in cancer, genomics in reproductive health. Each module that we are talking about, module of health of care, genomics has an angle or has a value to add in. And وزارة الزراعة عندها فرع خاص بالجينومكس حتى agrogenomics. Then in the last 5 minutes, I hope that if you are field in the bioinformatics and data, genomics will generate the biggest data that you could think of. And using this data, you could learn a lot of information. You could use it to different scale. You could use it to know what are the most common diseases in my population. And this is a list of common inherited disease in our population in Saudi Arabia. You can use it to say, I want to study XYZ because these diseases are more common in our population and we are supposed to study them more than others. And this is an example of a diseases that is common in our population. And if you called me at 2 o'clock in the AM, the first thing usually as a geneticist, when a baby is sick, I ask, what is the family name? From a family name, we could tell what is the gene, what is the diagnosis, and what is the variant. As a healthcare provider, we use family names as a marker to establish diagnosis. And this never happened in any part of the world. This is our duty to our country to understand it and do better research, targeted our population. Then, knowledge is difficult. And what I am showing you here, a knowledge that it changed from, yes, it caused the disease in 1 month, and then in 12 months, this genes or this variant, it's not anymore causing the disease. It shows the complexity of the field where we need dedicated people to do this. And then, machine learning and AI. You cannot give a talk without mentioning AI. If you use an outcome and generate this data, you will have an AI system. What if we use the outcome to train the AI? And I will show you one excellent example, how this is being applied in genomics. One, for a variant classification. Two is sharing the data and sharing the knowledge. We, at King Faisal, for example, wants to share this with everyone. As of yet, there are no SEDAIA published regulation how we can share the data, at what level we are allowed to share genomic data, and that's still during policymakers for development. So that's where we apply it. It's not there. There is something we call it جينات الوناسة, recreational genetics. So you could do your genomics to know where are you from, what's the color of your hair, are you smart or no, are you tall or no, and all of this we could tell from your genome. For example, I did mine and it shows, yeah, I am maybe a little shorter, you can tell, but my IQ is in the higher side. I hope you agree on both. So then, where is this future trend? Where are we going? And I will, in the next 2 minutes, 3 minutes, I will close. Where is this field? Let me show you one example. We usually get this trend. We collect information and then we have a knowledge. Let's shift this. Let's say we want your DNA only. And from your DNA, we will know a lot about you. And we will reverse the knowledge from a data collections to, by knowing your data, we can predict too many things about you. A big application of this is this. Forensic medicine now using a DNA from a crime scene to predict the facial profile of the criminal. By having a DNA in the crime scene, we can predict how does this criminal look like, only from this DNA. Is he black? Is he white? Is he Asian? Where is he from? How he would look like as a face, and we can predict the face of this individual only by knowing the data. So the traditional teaching of medicine is by organs. We think genomics is all organs. Traditional teaching of medicine is male and female. Genomics is not about gender, it's about you. Traditional teaching of medicine is we believe in data sharing between all centers in the country. Everyone should have an access to this data, so we help elevate precision medicine within Saudi Arabia. And using this is an example. I'm just sharing with you the screenshots, and then this is how a report will be generated by your facility. And it shows you a goal that making this data, sharing this knowledge with everyone in the country, hopefully will be able to help you to implement precision medicine in cancer and rare disease and reproductive genetics in all aspects of precision medicine. And this will take me is, when we take all care of this, we replace it to you, we provide you with the data, then the price is what we claim always. Genomics is expensive. By doing a collaborative effort, one test isn't equal to CBC or electrolytes. It will cost around 500 riyal, which is way less than MRI, way less than an echo. If you are a decision maker in this room, this test can replace many other tests, and it's way cheaper compared to any other, and you would not require any infrastructure facility. So that's will end my talk. I hope that I was able to convince you, share our experience at King Faisal for implementing precision medicine, convince you genomics is everywhere in healthcare. We believe genomics will change the healthcare, how we are practicing it today. And then an initiative and a goal from us at King Faisal and working with everyone in the country, how we elevate precision medicine within the country. Thank you so much.
Thank you, Dr. Faris, for walking us through how precision medicine fits into the healthcare systems. As we continue, we will be moving from innovation and capability to critical question. How do we scale transformation from strategy into execution? And the next session will focus on translating ambition into delivery, drawing on global lessons and national experiences. And to explore this, please allow me to briefly introduce our panelists, followed by the moderator for the day. For our panelists, joining us, Dr. Riyad Al-Ghamdi, CEO of the Saudi Public Health Authorities, bringing a population health and preventive perspective. Next, Dr. Luis Lepon, Vice President of Advisory at Mass General Brigham, supporting large-scale transformation across international health system. Dr. Amit Sif, partner at KPMG, with an experience across clinical practice, commissioning and integrated care redesign. Moderating this discussion is Dr. Saleh Al-Tamimi, CEO of Riyadh First Health Cluster. With that, I will hand the discussion to Dr. Tamimi. Welcome everyone to the stage.
Assalamu alaikum wa rahmatullah. Good afternoon, ladies and gentlemen. It's really my pleasure to be moderating this afternoon panel, and I have a wonderful global experts that will talk to you about really cool things. But the theme for this panel is about taking strategy to execution. And the reason why this is important is that we always read that at best 30% of organizations succeed in executing their strategies. It seemed like really a terrible number, but there is certainly conviction that most organizations fail somewhere along the line in executing their strategies. So we have three speakers from different places of the world, from Amit from the UK, Luis from the US, and Dr. Riyad from Saudi Arabia. And each one of them comes with a totally different experience in trying to address this question, how to take strategy to scale, how to execute it in the best way. But let me start with you, Amit. In your role as VP and CMO at the United Health Group, you led the design and the rollout of the National Population Health Management Project in England. Tell us about this and how you managed really to succeed in executing your strategy.
Thank you, Dr. Salah. So, well, pleasure to be here and really excited for the conversation to follow. I think for me, the key word here, and no word has been wasted in designing the whole forum, is lessons. And what we can learn and what we can take out. And I think the key aspect, especially following my colleague Dr. McShane this morning, and how we were able to succeed and scale from only 6 out of 41 clusters to all 41 clusters across England, was the buy-in of grassroots clinical staff and individuals on the ground. What we have found so often in transformation is a wonderful, correct idea at a very senior level, which is delivered as a top-down mandate with no clear return on investment or skin in the game for those who have to carry out and execute the program, which is the frontline clinical staff and their teams. Failure is inevitable, which is why your statistic of 30% is very poignant, because I'm sure in the 70% failure rate, very few of the grassroots staffs were consulted, were bought in, or really saw what was in it for them or their patients' families. What we were able to do differently here was engage at a grassroots level and co-create. So the concept was high level, the concept was data-driven decisions in spending, the concept was scale fast and fail fast, rapid evolution of the highest impact interventions to deflect the needle, to change the curve. but the actual doing and the implementation was co-designed at grassroots level. So our teams would go and sit in local communities, explain the methodology of interventions and impact interventions, help link the data sets, help understand the wider determinants of care, and also therefore what are the other outcome measures that we could be looking for. Are they all necessary health related, blood test related? Of course not. Human beings aren't blood tests. Human beings are happiness and outcomes and being able to be successful, productive members of society. So we took a much broader and holistic approach. What this enabled the grassroots teams to do was come up with real interventions of impact and meaning, and a real time scale to measure their success or their failure. A key message was, as I said, scale fast, but also fail fast, and failing fast is okay. It's better to fail fast than to fail slowly over many, many years and not actually change the intervention. After carrying this out in a very select and small number of clusters, we were able to scale it to the rest of the clusters across England and demonstrate that the concept of population health management and interventions of the highest impact was sound. At grassroots level, the effect is in weeks. So we were able to see a tangible improvement and benefit in patients' outcomes within a matter of weeks. If you look at that on a macro scale, on a national scale, it's much harder to determine that you're being successful. And also in each small postal code or zip code area, the interventions can be vastly different. And this is often, again, where we can fail to scale because we then assume that the concept is defunct, whereas it isn't. Now, in time and with the culture buying into this mentality of operating and deploying services, that scale of effect will be seen at a macro level. Whether it's regional or whether it's wholesale national, the methodology is sound and the multiple data points of evidence can be collated and shown, but it all comes down to the culture of engagement and the ownership at grassroots level.
That's really classic, Amit. And it seems that even in this day and age, we still do the same mistake. The frontliners are not involved enough. And I really don't know why. We tend, as executives or decision makers, have meetings all day, planning, and we have those wonderful meetings. And then we go and execute, and we fail. And I have a story to tell you that I will never forget. I actually learned so much from it. I was the CEO of King Saud Medical City in 2014. And we were working hard on developing patient-centered care. And we had all those strategies, meetings all days. And one day in the afternoon, I was walking towards the hospital, and I entered the hospital, and there was a reception on the left-hand side, and there was a receptionist sitting like this on his cell phone, all right? And a patient came, and I said, "Assalamu alaikum, can you please tell me where is the heart center?" And the receptionist did not stand, did not look at the patient, and he just did this. Okay? And it was like pouring ice water on me because I realized that we did not get it right. So thank you very much. Luis, you as an emergency physician by profession and working internationally on many projects in innovation and development, one project that really caught my eyes as about the implementation of AI in leadership. Can you tell us about it, please?
Sure. Thank you so much, Dr. Al-Tamimi, and so good to reconnect, again today after so many years. First of all, thank you to the organizers for having me here and honored to attend my third Model of Care conference. Being here from the very beginning and seeing the changes and the optimization and amazing talent that has been shared over the past few hours alone is a great testimony of the transformation within the kingdom. As an emergency physician and representing an organization that is all about implementation and execution, yes, there's a strategy setting, but execution and the outcomes that are produced by that execution are what really lead the work that we all do at Mass General Brigham. One common denominator when I travel around the world on many different projects, no matter where the country is, what stage in transformation, innovation, the healthcare system, the hospitals are, is the topic and the concept of incorporating artificial intelligence to the work that we do. I was very surprised that the term AI did not come on this stage until the fourth presenter this morning, because this is a topic that is present at all times, everywhere, and also in healthcare. Tomorrow, I'll talk more about healthcare, leadership, adopting AI, in the systems, but what I would like to say is that we face a lot of challenges in our healthcare systems, financial, supplies, very importantly, our workforce burden. Are there any new tools, any new gadgets out there that can help that patient that Dr. Altamimi just mentioned, walking a hallway of the hospital and being told by a human being, what? The direction to the restroom, the direction to reception. Well, maybe there is a virtual, solution to that it could be much more pleasant than a human being that is not motivated. So people ask constantly how we do incorporate artificial intelligence into our healthcare model and provision of care transformation. And many come with answers such as, oh, we'll implement a program in robotic surgery. Oh, we will adopt a new electronic medical record that allows my conversation to be captured with my patient and then produces a note, generative AI. Or maybe there is a decision-making algorithm that pops up as a best practice when I'm treating a patient with potential chest pain, potential acute coronary syndrome. And when we implement these programs without a strategy, without a framework, without an alignment with what our vision is for our transformation in the model and the provision of care, AI fails. We're looking for artificial intelligence to take over the functions that we do best. And artificial intelligence, as I will share with you tomorrow, will not take over humanity. It will enhance humanity by helping us coordinate, collaborate, and exchange all the information that comes to us every second today that we cannot process timely for the outcomes that we are trying to achieve. So this topic keeps coming up. We'll talk more about it tomorrow, but the solution is not to implement programs that use artificial intelligence. The solution is to have a strategic program on how to implement artificial intelligence in your healthcare systems for your model of care. Again, we'll talk more about tomorrow. I don't want to reveal all the secrets yet.
Well, thank you very much, Luis. This is really a hot topic these days, and we look forward to tomorrow's talk. I also welcome Dr. Riyad Al-Ghamdi, who has just been assigned as acting CEO for the Saudi Public Health Authority, so congratulations.
Thank you.
But before that, you've worked for many years as the Deputy CEO, and you've worked on as a lead in the transformation that happened to the Saudi CDC to become the Public Health Authority, Saudi Arabia. So can you tell us a little bit about your work in the strategic work that happened in executing the transformation, towards the Public Health Authority. And I was also drawn by your role in the National Health Security Project. So maybe also tell us about this, please.
Thank you. Thank you, Dr. Saleh. And I would like to thank Mr. Nasser Al-Hakbani and all the team in Holdco to arranging this. I will start by commenting on your opening remark when you said 30% of organizations only if they are successful, if they are lucky to execute their strategies. I think in Public Health Authority we have a story to tell, and I think this is the best venue to start with. So I joined Saudi CDC in 2018, and immediately we started to work on our first strategy, which lasted for 3 years. And then after that we had, successfully gaining the Council of Ministers decision to become the Public Health Authority. And then we worked on the, let's say, what we call the foundational strategy for Public Health Authority for 3 years, which is from 2022 to 2025. So it's 2 cycle strategies. We executed very, very elegantly and very well. And now we are working in the authority to put the strategy for the next 5 years from 2026 to 2030. And during all these years, I think what kept the idea alive and all people in Public Health Authority engaged is what keeping everyone alive, which is we have a vision, we have something to aspire to achieve. In 2016, Vision 2030 was launched, and if you are very familiar with the Vision 2030, there is a full pillar about ambitious nation, which include a lot of transformational activities in the country. One of them is the healthcare transformation. But what made the difference is the KPI, the level 1 KPI in the Vision 2030, which is we want to increase the life expectancy for our people from 74.4 to 80 by 2030. And that's elaborated a lot of efforts in the national level that led to the creation of Public Health Authority. What happened that Ministry of Health used to be the big umbrella of all health-related activities, including public health and healthcare delivery. So from the beginning, we realized that to increase the life expectancy is not enough just to provide services, healthcare services. We need to work as a whole of government together to prevent risks that will impact the life expectancy of our population. And we didn't wait very long. 2016 was the launch. 2017, the Ministerial Committee of Health and Health Policy was established, which is the highest umbrella that all public health related activities and policies will be negotiated and implemented on the national level. Wiqaya was a major initiative to be enabled and established as a reference for public health in Saudi Arabia. So the initiative to create Wiqaya was financed by Vision 2030. The establishing team that started to work with Wiqaya took this mission very seriously. We want to create an organization that can help healthcare delivery, but also the whole of government to make sure that all the interventional activities to protect our people, our visitors, are there. And Wiqaya started by formulation, the Council of Ministers decision put a board of directors for Wiqaya that include all the major players in public health activities, led by His Excellency Engineer Fahd Al-Jalajal, but with a membership from major healthcare system players, but also from the municipality, from the agriculture, from education system, from human resources. We have the most diverse board of directors, all of them working together with you, with the model of care and Holdco, through the organization, the effort of Wiqaya, to make sure that your catchment population, your catchment area will not only be taken care by healthcare delivery, but also with the whole of government approach. And we had a lot of successful policies that we designed and implemented with a very promising outcomes. And that's why you said that I just assigned as an acting CEO. One of my first moves is to visit Mr. Nasser in his office, because I know healthcare delivery is a cornerstone of successful prevention in the country. And I have a very high ambition on Holdco and also all the clusters to work together with the whole of government approach within their catchment area, where Wiqaya can facilitate that, providing intelligence and reference testing, but also on the front line, we are delivering the best value for our population. One example from Wiqaya, and then I can conclude. We noticed, because we have the intelligence analysis of the mortality of Saudi population, the second most common cause of death among children below 5 is drowning, you know, and this is a tragedy that we can prevent. We work together with healthcare delivery system, with also Red Crescent, and also with civil defense to create a national policy to prevent that. In 1 year, we have 17% reduction in children deaths from drowning. And as a healthcare delivery system, you are getting a lot of benefits by focusing more resources and more birth-related diseases than a tragedy that we can prevent. Providing us with the intelligence, and we working with all the government to make sure that all these policies will be implemented at the local level is the success that we want to create between Wiqaya and Holdco and the clusters. I'm very happy to be here, and I'm very optimistic about the future. I think Holdco will provide the best model in the region, maybe in the international level, to increase the wellness of the population. Wiqaya is your ally, and I hope successfully together we make the best outcome for our nation. Thank you.
Well, thank you very much. I think we have probably 4 to 5 minutes left. I want to wrap it up by getting your advice each in 1 minute to the audience on how to maximize your chances of having a successful execution of your strategy. In 1 minute each, please.
For me, it comes down to the people. So engage your people, help them to get to the same point as you in understanding the return on investment, but then most critically follow up and show them. So it's not enough to say it, people have to live it and have to feel the return on the investment of their time and their commitment. It begins, it middles, and it ends with your people. So invest that time up front.
So, thank you. Luis?
I think it's important to get the buy-in of the workforce in the front lines. And having been involved in the implementation of the model of care in the kingdom now for close to 5 years, it's not infrequently that I hear they're going to ask me to do more for less or the same. The reality is that no one, I think, is going to ask anyone to do more. The message is we have an accountability that I think is clear and we can all understand and agree upon. Number one, we're all here to do what is best. We agree on that principle. Number two, we chose healthcare because we chose to serve others. So we agree on those two principles. What is changing potentially is accountability. Accountability to be responsible for those two principles is not to work more, is to work differently. Always keeping in mind that at the center of everything that we're going to do is the patient, their families, and our communities, our country, and the world. So it's changing the messaging a little bit, what I think it will convince people and make people pride and feel rewarded for what they are just about to accomplish, which is the implementation of a fascinating and transformative model of care and provision of care that is happening overnight. Other countries have taken 50, 60 years, even more. Our own organization in Boston, almost 200 years. You know, the example here is happening overnight. I think taking that pride and that buy-in from the frontline workforce will be absolutely key.
Thank you, Luis. Dr. Riyadh?
I think what makes success is to keep the vision alive and changing the culture, personal culture, and also the organizational culture, and aligning the personal vision with the organizational vision with the country vision. I think every day is part of your contribution to the success of this country. It's very important to create this culture of performance, high performance. We need to make the difference on regional level and global level, and you are contributing to the best thing of people health. So I think it's very important to create this culture between personal, organizational, and the country, and that's what will bring the execution to success more likely. Thank you.
Well, thank you very much, all of you. So we'll have a couple of questions from the audience. Can somebody help us, please, with the mics? I can't see. There's somebody in the back. Yeah? There's somebody in the back there. And let's have a mic on each side, please. ارفع يدك الله يخليك.
Hello. Assalamu alaikum, Dr. Saleh and the team members. My question regarding the strategy execution, and as you rightly mentioned, most of the strategies are failed at the time of the execution. How do you see the working in silos? The different teams are not aligned, and there's a kind of a very clear distinction when it comes to the strategy execution and the diversion of different aspects to this. So that is maybe the main cause of derailing or not achieving the strategic direction, and it gets stuck in the middle. So what's your take on this in the panel? You're talking about this.
I think that is a fantastic point, and siloed behavior and siloed working leads to, in the first instance, a misalignment of incentives and duplication and wastage. So again, I couldn't say if it's the number one driver for failure and execution, but it absolutely would be pathognomonic of a major driver, certainly. For me, the path to success here, obviously we can talk rhetoric about taking silo down, about integrated working, and we all say these things and we believe them, but to actually execute, we need an alignment of incentives. So we need to, and that's why there is no more exciting a place on the planet than the Kingdom's vision for 2030, because the opportunity is there and sits there to align the incentives from a ground floor up. So the chance to make sure that each of those silos simply can't exist, because in order for success to happen, everybody needs to be rowing in the same direction, whether that's from payment incentives, incentives for nothing happening, incentives for activity being appropriate and not overly inflated and so on, incentives for prevention, which I went to medical school nearly 30 years ago, and even then we knew prevention was the cure. But we still don't see it happening. So for me, the alignment of incentives sits at the core to bringing silos down, reducing duplication and waste, and actually progressing and moving forward.
Well, thank you very much. And you brought an important point. If you want to break silos, incentivize the system to do so. The systems will behave the way they are incentivized. If they find that it is in their best interest to collaborate, they will. We'll take another question. تفضل الدكتور طلال هنا في الفرنت.
Assalamu alaikum. A question for the four, or anyone of the four on the panel. If you are the head of an institution which is failing in the strategy, what would be the one thing that you will tackle first before going anywhere else, and you will try to find a solution for it? I wish that all of you answer it, including Saleh.
I don't know if we have time, but Luis, let's have your answer. So, can you repeat the question, please?
You are the head of the institution, and your strategy is falling down. And there's one thing that you want to tackle first, before anything else, to improve on your strategy. as early as possible, as quick as possible?
So to me, it's all about understanding why the strategy failed in the first place. And in most instances, a strategy fails because it never considers those that are going to be executing the strategy. I'll tell you a little example. I know we only have 1 minute, but I'll try to rush through it. As a very young chief of emergency medicine, I realized that my patients were taking enormous amount of time to be triaged, be selected, to go back into the emergency room to be treated. So what I decided to do was to put my office facing the waiting room. I could see all the patients arriving, and whenever everyone was waiting more than 5 minutes, I will take the patient myself into the emergency department and say to the nurses, this patient is here to be seen. Please start working them up. What was wrong with that strategy? I was only looking at one angle. A patient waiting out there, yes, needs to be taken care of. We all agree. But what was happening in the back? Why were the nurses busy that I was not considering? Did they ask them if the triage system was working for them or not? So that strategy was failed from the beginning because he did not consider those that were going to be implementing the strategy. I kept my office in the front and looking at the waiting room, but I changed the strategy.
Well, thank you very much, Luis, and thank you, Emmett and Riyadh. Thank you really for being a wonderful audience. I hope you enjoyed this brief discussion, and please make sure you attend Luis's talk tomorrow. Yes, your talk is what time?
Tomorrow we're going to talk a little bit about how leadership,
Yes.
so how do we incorporate artificial intelligence in the way we lead our organizations.
What time is it?
What time is it? I think it's around the same time. So it will be I will be in between lunch and you.
Okay.
Which is better than getting you after lunch, I think. Thank you.
Shukran. Thank you, Dr. Timimi and the great panelists for the amazing, rich discussion. We will now take the time for a 20 minutes lunch break due to the time constraint, and we look forward to welcome you back in 20 minutes to resume our program. شكرا، ما انتبهت له في الأخير. ممتاز، ولا أخذها منك. نرجع الساعة كم؟ Okay. Ladies and gentlemen, please make your way to the main hall as we will be resuming our program in 5 minutes. Thank you. السيدات والسادة، نأمل منكم التوجه إلى القاعة الرئيسية حيث سيستأنف البرنامج بعد 5 دقائق. شكرا لكم. Ladies and gentlemen, please make your way to the main hall as we will be resuming our program in 5 minutes. Thank you. السيدات والسادة، نأمل منكم التوجه إلى القاعة الرئيسية حيث سنستأنف البرنامج بعد 5 دقائق. شكرا لكم. موجودين؟ نطلع؟
تفضلوا بالجلوس سوف نبدأ الآن.
ضيوفنا الأعزاء، نرجو منكم التكرم بالجلوس في مقاعدكم حيث سيستأنف برنامجنا الآن. Welcome back, everyone. As we will resume, we are turning to the role of health policies and regulation in enabling innovative model of care. This conversation brings together policy and governance perspective. And to start this conversation, please allow me to briefly introduce our panelists for the upcoming panel discussion. Dr. Abdulaziz Al-Rabi'a, Deputy Minister for Policy at Ministry of Health. Dr. Al-Rabi'a working at the intersection of national regulation and system reform. Dr. Ala Marghalani, President of Legal Affairs at the Center of National Health Insurance, CNHI, shaping the national governance frameworks. And Dr. Nofin Mir, Secretary General for Health in All Policy at Ministry of Health, aligning cross-sector policy with health outcome. Moderating this discussion is Dr. Mohammed Arafat, Executive Director at MRC. With this, I will hand the discussion over to Dr. Arafat and welcome all the panelists on the stage.
Assalamu alaikum. Good afternoon, everyone, and thank you for being here. Our session today will explore how health policies moves from traditional control to enabler for innovative health care models. We'll go through our discussion today also about a very serious, very specific series of questions, specifically starting on redesigning policies, going to innovation, and then data, and finally the payer or the healthcare payer. So we'll start with Dr. Nofir Mir. Thank you, Dr. Nof, for being with us today. Dr. Nof, from your experience and your work in as a Secretary General, what is, from your perspective, which policies or regulatory domains require the most redesign to support future models of care?
Thank you, Dr. Mohammed, for having me. It's a pleasure to be among my colleagues in this panel and to discuss the policies and the regulatory ecosystem within the healthcare system and in the wider ecosystem. So if you allow me to step back and look at the wider ecosystem of the health and not just the healthcare delivery ecosystem, and acknowledging that although the health may start and end within the healthcare system, in the hospitals, it got shaped heavily in between in the non-healthcare sectors and somewhere else totally outside the corridors of the hospitals, such as the education environment, the surrounding environment, urban planning, and so on. And I will come to the domain later on. But with that in mind, understanding that the impact on my health and your health coming from 80% coming from the non-healthcare sectors, and acknowledging this and putting this in our mind, we would shift our view to the future of healthcare and understand that building the future of health does not mean building new hospitals or focusing on the healthcare delivery only, yet building the policies in the other sectors as well. Moving to the domains and understanding that 80% of the domains in the non-healthcare sectors will allow us to invest more in the policies, in the actions, putting the agenda of the health, integrating health in the policies in the different domains. And I will list few of them. And these domains will help us moving and building a system, not just treating the illness, but a system that will preserve health, prevent illness, predict risk factors, and enable an early interventions. Coming back to the domains, in the health and all policies, we are looking at the sport domain, we are looking at the education domain, the environment, the food, the housing, the urban planning, the economic policies, and we are looking heavily at the domain of the economy and the impact of the economy in our health, and also the impact of the health in the economy. So these are the domains that we are looking at. Of course, there is a subdomains under each of them. We can't forget an important domain which impact our health more than 20%, which is delivery. But I will leave it for my colleagues here to talk more about the healthcare delivery domain. But I will just shed the light on my thoughts on the important domain within the healthcare delivery, which is virtual health, data governance, activating the community, workforce, financing, and the payment models, and more of integrated domains or a system within the healthcare delivery. So having such integration between the domain within the healthcare delivery as a part of a wider ecosystem will ensure that we'll have a future of health more sustainable, more toward the prevention, more efficient, and more equitable for all.
Thank you, Dr. Noof, for setting the landscape of around the policies that we're talking about and what's the need for redesign, and especially the point about the 80% ratio between healthcare delivery policies versus other policies or other sectors that not related directly to healthcare system. Thank you again, Dr. Noof, and we'll turn the mic to Dr. Abdulaziz Rabia also to explore how can healthcare policies act as enabler rather than constraint for innovation in models of care.
Thank you, Doctor, for the question, and I'd like to thank the organizing committee and for this opportunity. I think, mashallah, Dr. Noof has covered a lot of points, tapped in on it, but if we step back and think about why do we do policy in the first place, is it more to govern and restrict, or more to send or set the direction where we want to head? So previously, and working in hospitals, most of us are aware of policies related to like number of staffing, standards, and all of these that can guide us to prevent risk. But if you look into the transformation Vision 2030, we start to see a new direction. For example, going into value-based healthcare. It doesn't tell you how to go, but it tells you that we want to achieve it. And it gives a space for the financing team or like the new payer regulators to create some sort of internal policies and methodologies to implement such policies. Now, this tells us that we need to move away from input to outcome policies. And we have seen previously, I don't know if some of you recall that home health care, telehealth was banned. There is no clear regulations. It was not even approved. But given the circumstances of COVID-19, for example, and the burden of disease that is accumulating every moment on the spending, we start to see some approvals and some, I would say, adaptation of policies to accommodate these burdens. The second thing, I think, which we have seen in many sectors, and now we have seen it also in the healthcare sector, the sandbox regulatory policies. And I think in the ministry, we have seen it in Saha. And I think also there is, yesterday I was with His Excellency Al-Ganawi, and he was mentioning that they're also working on a sandbox, regulatory sandbox, to help, I would say, innovators in exploring what type of policies, what type of, I would say, interventions that is making sure there is no harm, but also to adapt and learn from the regulators and can implement. And this by itself also will reduce the cost for regulators not to implement policies that downstream will be very costly.
Thank you, Dr. Abdulaziz. about especially the sandboxes and how can it accelerate and easy and make it easier for researchers and innovators. After we have discussed the policies and how it enables the innovation, we'll move now to the implementation, and as a key driver for implementation is the healthcare payer. So Dr. Ala, how can CNHI or Center of National Health Insurance as a national healthcare payer adapt new models of care within its governance framework?
Well, thank you, Doctor, and thank you for the scientific committee and everyone contributing to this session. I would like first to thank my peer and especially for the brilliant idea of the sandbox for the regulation. Policies and regulation is cornerstone for the new model of care in Saudi Arabia. It's an enabling channel that help us to deliver what objective we are aimed to into and make them in the real life of practicing among the provider. Today we are at the CNHI, we are trying to use all the objective in our regulation and policies in order to enable the Saudi new model of care. For example, using the health benefit packages, we are focusing into using the defined pathway of care and setting them in the stone of the health benefit packages. Also identifying the eligibility rule that help usability of the primary care and reduction of the unneeded escalation to the hospital. All those can be seen as enabling for the new model of care. Also, we are trying to shift from the usual input funded base to using a new model of financing for the healthcare. For example, using the DRGs, the value-based rules, and moving to the capitation. All those efforts being set forth in the mind of the regulatory aspect in CNHI, we believe it will help into arming the new Saudi model of care into the life, inshallah.
Thank you, Dr. Ala. Of course, governance and purchasing set the rules for the system, but again, a strong policy decisions increasingly depend on the data and advanced analytics. So back to Dr. Noof, what is the role should data and artificial intelligence play in shaping evidence-based health policy and regulatory decision making?
Thank you, Dr. Muhammad. I really love the data when it's organized, informative, and help you understand, rather than raw data and structure that could be sometimes misleading. So the journey we are taking in the health and all policies is trying to push the raw or the signals coming from the raw data to more of organized information, more to moving to structured insights, then ending with informing the decision maker. It's a journey that we can't do it alone in Health and All Policy Secretariat. And we are heavily engaging with the entities that will empower us to move from the raw data or the raw signs or signals to informing the decision making. So we are working hand to hand with the Ministry of Health, with Public Health Authority, with Sadaya, with the Authority of Statistics, with other entities that will help us really utilizing the data that we have, not just within the healthcare ecosystem. So with that in mind, we will utilize the data and the emerging technology to inform the policies. Because for a long time and for a long years, all the policies were reactive, not proactive. So using the existing data, actually not even the existing data, the retrospective data to come up with the policies and to treat existing burden of diseases, existing risk factors, and existing drivers. Rather than being proactive to the futuristic burden of diseases or the futuristic risk factors that we might face in the country. I think such shift is needed and such movement from reactive to proactive is needed, and it could not be happen without having very strong data to support the policies, so an evidence-based policies, and utilizing of the emerging technology. So the power of the prediction, having models that got built to help us predicting the impact of the policy before proposing it to our leaders. And once it's approved, moving to measuring the impact and making sure that we are in the right direction. So the predictive power is very important. The second point I want to highlight is the integration. So the integration within the health ecosystem is very important. But just imagine that we can uplift the integration to be with other sectors. A full integration between the healthcare data and the education system. We would learn a lot and we would inform a lot of policies if such integration is happening, or with the environment ecosystem, or with the sport. Such integration, I think, is coming, it's needed, and all sectors need really to work on facilitating such integration toward informing the policy. The third point, so the first one is the prediction power which is needed. The second point is the integration. The third point, what Dr. Rabia is highlighting over and over, is the governance. Having the right data governance, having a clarity in how we utilize the government, how to empower the innovation, empower the research. I'm a big fan of AI. A supervised AI within the healthcare delivery or within the day-to-day operation, but let's allow the unsupervised one as well in the research and in the innovation. With that, we will get the benefit of the data, we will inform our leaders, we will move from reactive to proactive, and we will utilize the emerging technology. I just want to make sure that Dr. Rabia will not, can answer this question with me as well, because he got a huge experience on utilizing the data to inform policies, not just as an enabler, but more than that.
Thank you very much, Dr. Nov. Mashallah, you have covered most of the critical points, but what I can add is that, as you mentioned, we used to work in policy as more of a reactive mode, firefighting mode, just to make sure that our patients are safe or the system is not on a crisis mode. So maybe if I would look at it, is enabling the decision maker to have more policy options with a stronger confidence, because sometimes decision is always costly, and it's sometimes very difficult to go back from it. And having data and artificial intelligence, for example, one of the scarcities we have in Saudi is having a health economist that can do modeling. With having some rights AI tools on place, we can have that. Also, looking into the options. I'll give you an example. I took the statistical yearbook, and I put a prompt to look into that, and then ask it about what general policy you think of or what we should think of, just to show the signals. An interesting finding was we see fertility rates are going down, but there is always a report that we're missing out in terms of bids. So these are like two different separate areas. If you're not focused on it, it's not easy to predict. You need someone who's really dedicated and aware of the system. And there's many examples you can look at it.
Thank you, Dr. Noof. Thank you, Dr. Abdulaziz, for the answers and for the collaborative answer, which is reflect that our system is integrated and collaborative. So we'll move now. We talked about policies, about innovation, about governance. Then finally, to close the loop, let's focus more on the outcome and how can we ensure the quality. So Dr. Ala, NCNHI, the Center of National Health Insurance, as a healthcare payer also, what is the use policy and regulation to enhance quality of care?
Well, thank you. Today, the CNHI, as a governmental financial or purchaser for the healthcare in Saudi Arabia, is a keystone for regulating system of the new model of care. For example, lately we have launched the mechanism of governing the relationship with the private providers. Into that regulation, we have set forth the rules and the obligation in order to enhance and focus on the outcomes. We have adopted the healthcare outcome indicators, and we are monitoring that. We will help the provider into focusing into the service itself and to promote the expectancy and the care for everyone. Also, we are about to launch the new regulation that focuses into establishing what I do believe is the first ever governmental network for the hospitals in Saudi Arabia. And this regulation will focus also into setting forth the indicators and helping to promote the goals of the new model of care.
Thank you, Dr. Ala. And again, thank you, my colleagues, Dr. Rabi'a, Dr. Noof, Dr. Ala. From what we have here today, it clearly shows that when policy, purchasing power, innovation, and data aligned, model of care can truly transform while maintaining safety, quality, and accountability. And thank you so much for your time.
Thank you to our panelists and moderator for this thoughtful discussion on health policies and regulation and how that shape the model of care. Our guests, we are honored to remind you that we will be having our honoring ceremony this evening at 7 p.m. Please, we wanted to assure and invite all of you to attend our ceremony. حضورنا الكريم نود تذكيركم بالحفل تكريم الجوائز مساء اليوم الساعة 7 مساء تحت رعاية معالي وزير الصحة أستاذ فهد الجلاجل. And for now we will be moving to our next session. For our next session, we will be shifting from health policies framework to the capability that will actually bring those or these framework alive. And now we will be turning to digital innovation and artificial intelligence and how they are accelerating integration, decision-making, and care delivery across health systems. Allow me to briefly introduce our panelists, followed by our moderator for the day. For the panelists, we have Dr. Dominique Samaha, consultant orthopedic and spinal surgeon, Mr. Joe Flangan, CEO of R1CM, Mr. Rajveer Shima, partner at KPMG, specialized in digital transformation and interoperability. And moderating this session is Dr. Ahmed Al-Anizi, CEO of Riyadh Third Health Cluster at HHC. And with that, I will hand the discussion to Dr. Al-Anizi and welcome all the panelists to the stage.
Okay. Assalamu alaikum wa masakum Allah khair. I'd like to welcome all of my speaker, and I will just give brief introduction about them. We start with Dr. Dominic, consultant orthopedic spine surgeon, and more interested in value-based healthcare service. He's a top leader in this field, and he's active member of ICHOM community. Welcome, Dr. Dominic. The second is Mr. Raj, KPMG National Leader for Digital Data and Technology in Healthcare. Welcome, Raj. And for sure, Mr. Joe, where we talk about revenue cycle management, the Chief Executive Officer of R1 with 80 billions US dollar net patient revenue, 34K associated worldwide. Thank you so much for all of you. We will start with our conference, model of care, and how can we define model of care in the context of digital transformation, and where does AI fundamentally fit into this vision?
Okay, good afternoon. So what is sure is that applying value-based healthcare in any system will absolutely need data collection, outcome collection. So, and without data and outcome collection, we can go nowhere in VBHC. Therefore, having a system, a digitalized system, allowing us to collect in a very accurate manner the data of the patient and even the clinical data, I mean by that the prompts and the crumbs, will automatically allow us to improve the outcome by adapting our treatment to the patient's need and having a better patient centricity, and will allow us for sure to reduce all the costs, because outcomes are directly linked to cost. Without data collection, it's impossible to go to move forward in VBHC. And I always give the example of what we used to do and what we do when we collect the data, analyze it, feedback, give the feedback to the patient and to the doctors. And in our experience, many of our doctors who, for instance, used to do fusion for spine surgeries are now going back to more simplified spine surgeries with less complication and better outcomes for the patient, because at the end of the day, the one and the only one who will need to judge a surgery is the patient, and it's not only the doctor. So the data would allowed us to completely modify our way of putting the indications, and hence having surgeries at less price with better outcomes. And of course the AI, it allows us now, this is the other part of the subject. AI will allow us to preempt and predict the happening and the occurrence of complication in patient, and hence adapting our surgeries and our indications to what would be the best for the patient. It's based on all what we collected as data. AI will allow you, when you give a profile, a certain profile to the system, to tell you, to predict what would be the complication, and hence try to do the best to have the less complication and less and better prices and better cost and better outcomes.
Yes. Thank you. What do you think, Raj?
I think fundamentally what patients and clinicians really want is the ability to have more face-to-face time. The ability to give care, which is something that I think is probably less than it should be. So clinically, typically you're looking at 30–40% of a clinician's time is actually with a patient. The rest is doing everything else that needs to be done. And I think that's where really AI is going to be able to be a key driver. But for it to happen, we need to effectively think about data and how effective it can be used. I think it's already been mentioned. The way that we consider automation will be really important. And when it comes to AI, I do think that the rule book of how we deliver models of care should really be thought of as something that we rip up and start again. I think if we look to embed AI into the way that we deliver care, what it will probably do is make everything we do possibly a little bit more efficient. If instead we say that there's always a reason why someone needs care in the first place, and the key outcome that we want is someone that's better going forward, and then we redevelop pathways and we really think about how AI, data, is integrated with people and the workforce of the future, I think fundamentally you will have a very different outcome. And to me, that's what a distributed model of care will really look like in the future.
Excellent. Joe, from financial aspect point of view, maybe the colleagues already covered the clinical part, but from financial aspect point of view, how do you see our model of care and AI?
Yeah, it's very interesting when you look at the clinical delivery model through the financial lens. I think what's really important is to reimagine what is the right infrastructure to support those clinicians. And so very much in line with the prior comments, I think data really matters a lot, the organization of that data. And when we look at that traditionally from a revenue management standpoint, we really think the core of that process is a clinical intelligence engine. That is a platform and infrastructure that captures all the data sources and applies intelligence against it. Now that is required in the traditional model of getting reimbursed, but it's also very, very applicable in a population health management architecture. So if you just take the coding and CDI process with AI and with the right data and intelligence configuration, we can code autonomously at an accuracy above humans, but we can also capture the clinical attributes in an HCC context above the human accuracy as well, which is very, very applicable. I think the other dimension will be, as said, reducing the administrative burden on the physician and the patient to improve the quality of that interaction, which I think will still be a human interaction for some time to come.
Thank you. Dr. Dominic, we do have one domain which is a main domain in our model of care, the chronic disease. And most of the time we are looking to be more of proactive than reactive to those chronic disease. So how can AI shift the model of treatment from treating the disease itself to preventing this disease?
Yes, so I will talk about the low back pain, which is a very well-known chronic disease, and it's extremely costly in the healthcare system anywhere in the world. So using the AI in our experience would allow you to predict and prevent if the patient would need in the future surgery or not. And hence, you can predict if this patient with conservative treatment would give as much good as with surgery. Exactly the same than in deformity cases. In deformity cases, before the deformity occurs, let's say a scoliosis, when we know that the patient has in her family some scoliosis disease, then even before the scoliosis and the deformity starts with the patient, we integrate the X-rays into the AI system. And the AI system, based on the medical history, the family history of the patient, and the X-rays, and all what we feed them as machine learning, then it will predict if this patient would or not have a deformity in the future. Wow. And then we will follow up with this patient in order to start bracing the patient as soon as she has the deformity, and avoid the surgery that is extremely aggressive in the case of surgery. So the AI is changing and is moving our way of predicting and improving the prevention of the occurrence of the deformities, for instance, in spine surgery.
So value-based healthcare is more of high quality, low cost. And in your term and in your aspect, this seems to be, no, we are saving a lot of money compared to paying a lot of money in our healthcare service.
Yes, exactly. And what you're saying is is great, because I always say that it's not a matter of having big resources that matters to reduce the cost. It's the matter of having more efficiency, people who are used to do and who do exactly follow protocols and policies in the system, so it will improve the outcome by collecting the data and analyzing them.
Thank you. Joe, I will go to the question where we have a debatable discussion about it. So in AI and digital healthcare and model of care, there is a risk to replace human, especially in our healthcare field. So is the risk there? We spoke about like 20 years back when the internet, computer, and other stuff, like people, especially the labor, we are afraid that it's a huge risk to be replaced by machines. Is the risk still growing, or it's more clear for us with AI?
I think, it's hard to predict with the rate of technology change what the future looks like. So from my perspective, to digest this question, I think it's important to put in context where we are with the intelligence, with the LLM. And I think it's been reported that a 4-year-old in their lifespan, those 4 years, consumes more information in that period and processes more information than resides in the LLMs today. So I think it's really important for us to put in perception. And I think the notion that an LLM, a large language model, which is built on all the available pros in the public domain, still will never have the potential for perception, visual perception. And so from my standpoint, I start through that lens. Now, I think when you look at administrative activities that have deterministic outcomes, and I think one of the inflection points we've clearly seen is coding coming off the LLM. And when I say coding, I'm not necessarily saying clinical coding, but as a general matter, that moment in the technology journey was an inflection point. So I think we have to assume that the administrative processes that support the human interaction between the physician and the patient will be transformed. Now, I personally think that transformation will unlock growth and quality at a reasonable cost. And so the humans today that are doing those tasks will be doing different tasks in the future, but they will be allowing a scaling curve that we don't have available to us today, because there's a scarcity of labor, especially in high growth markets such as Arabia.
Thank you. Raj, we care about productivity, and most of our people, they don't count it in an accurate way. So we have AI-driven digital innovation, how it improves productivity from physician point of view, keeping in mind the quality of the care for our patient.
It's a really good question, and something that I'm working with the NHS on right now as well. One of the phrases that a clinician said to me is, we're drowning in work, but we're starved of clinical care time. And I think it was something that was really telling to me. We've started a whole series of engagements across the UK, and also looked at case studies from across the globe of where AI is really going to make fundamental impact in terms of productivity. So I've got a couple of stats with me. So one of them was time reclamation. Ambient voice technology is hugely important. It's being trialed in different care settings, but we're seeing that actually you can save 1 to 2 hours per clinician in a day. So what does that really mean? Well, hopefully 3 to 4 really high quality sessions that they can have with the patients that they're seeing. Intelligent prioritization is a really key one. Often what we're finding is that there's a cognitive burden on making sure everything that they do, everyone that they see is effectively being prioritized. But actually, are you doing it in a way which manages risk? So that's something that we're also seeing in terms of AI risk stratification. Predictive modeling is really important, but you know, in some cases it's quite easy to achieve, but in other places we're not even at real-time like data ingestion. So it goes from real-time, it then goes into predictive. But that's something the way we're still trying to get more clarity on. Administrative automation is the key area. I think you're going to see there is going to be the biggest unblocking of time being saved, and then personalization at scale. I do think that, you know, when we look at the engagement, and we know that often the cost of care is happening from a very small, actually, in terms of people that need it the most. How is it that we can be better when it comes to that and managing it? We can't forget the human is actually effectively in the loop. I don't think that AI will really reduce that requirement. But what it will do is every time a clinician sees someone, I think that there'll be agentic elements that are being done in the process, in the background, effectively moving care out of the time that a clinician is seeing you face to face to the left, which means whether it's devices that monitor you at home, whether it's devices that look to integrate all of the different elements of home monitoring that are happening into something so that when the clinician is seeing you, they are taking basically hypotheses and making decisions with you in the session rather than necessarily using the session to gather the information.
Thank you so much. So in the next 20 years, we are expecting fast growth in AI and digital transformation. So any advice from you as a subject matter expert for the schools, the universities, to add AI in their curriculum?
First of all, I would like to come back to a question that you, to a very important subject you said. Would the AI replace the doctor? I think it will never, because until engineers would invent a machine that has compassion, AI will never be able to replace a doctor. When a patient comes to see you, if you don't examine him, he will always say, he looked at the x-rays, he did not examine me. Why I wasn't examined? Okay. And the machine will hardly examine so the AI, and to come back to your question, I think— But
this is just as a physician, you are talking about it, or because when we speak about healthcare worker, we are speaking about everybody, like from as we discussed, maybe Joe, from administrative, receptionist, also allied health, and also other staff in any healthcare organization.
I'm speaking as a patient, maybe. A patient, a patient would like always his doctor. But coming back to your question, I think that yes, and universities and med schools should now start maybe modifying their programs and educate the future doctors to AI, introducing the AI as a full entity in the medical field, because we are going toward AI, and I think that this country will be the leader in this transformation, because we are already leaders in the value-based healthcare transformation. It's well known everywhere. Everyone praises KSA for its speed in transformation toward VBHC. So in my opinion, it should be integrated very fast, and it is being done when we discuss together, it's being done, it has to be done. It's a part of medicine today.
Thank you. What do you think, Raj?
So I've been really enthused about what I'm seeing in the kingdom regarding AI's integration into healthcare and the education of healthcare professionals of the future. I would, however, say that globally, in more mature and maybe bureaucratic or maybe policy-driven countries, I'm seeing that there is a big gap between what the technology can do, which is every 5 years it's fundamentally changing something in the way that we deliver healthcare, versus the education that is currently being delivered. If you look at something like pharmacology, I think it's about 150 hours worth of education in a medical degree that someone might take. AI, in some cases where we are looking, is 10 hours. That's a big gap.
Yeah.
And I think that gap is something that we need to consider more effectively. And I don't necessarily think it's about having AI courses themselves in the education sector. I think it's about embedding it into the way that people are thinking. There is no harm in people actually being a bit more proactive. And I like the idea of innovation happening on the front line. It shouldn't be up to policymakers necessarily to think about how AI is going to be integrated. Actually, the best people, the people that know it best, are the people that are seeing the patients every day. And the ability for them to be trained effectively to understand how they can use AI and safely, I think is fundamentally very important. And just one final stat as well. So, you know, we were talking earlier. I mean, there was some great work that was done around AI and its use on pigmentation and how that could be cancerous. But actually, they found that it was it wasn't giving the right results when it came to people with pigmentation in their skin. So we have to think effectively how we're training the AI models of the future as well, and effectively using it. And that's something that we need to think about across the whole world rather than necessarily in the West.
Thank you. Joe, maybe another aspect of the question, because as healthcare worker or physician with no financial background, we usually have difficulties to understand DRG, revenue cycle management, coding, costing. Is this an important issue, should be addressed to medical school, medical college?
Yeah, I think a way to answer or a way to provide some context on the question, if you just take the coding process, and whether that coding process is for a DRG-based reimbursement architecture or whether it's for a value-based reimbursement architecture, we look at that coding process the same way. And our ambition is to fully automate with an accuracy above human levels that entire process. Today, as we sit right now, we have 100% of outpatient code sets above human level accuracy, and we have 70% of major diagnosis categories in the ICD-10 framework above human level accuracy. And so you have to deconstruct what was required to achieve that outcome. That clinical intelligence engine needs data, and so a lot of work by to create a neurological data network, unstructured and structured data that has relationships. The second thing is we have trained 15 different models. All of those models are open source, open weight models. And to do that, there's a huge need for PhD level AI scientists. And then the final layer of that architecture is the application layer. And this is different than the traditional software engineer. The engineers that can orchestrate and configure that intelligence have a different skill. From my standpoint, there's an abundance of raw intelligence. There's open source, open weight models, there's frontier models. We have all the compute infrastructure we need. I really think the constraint right now is the engineers that understand how to apply this. And so I can't stress enough the public partnerships with universities to curate this talent will be a differentiator. And from our standpoint, we can't get enough modern AI scientists or modern AI engineers right now to fuel the roadmap. So I think it's a really, really important topic. I think all too often we talk about the LLM or the compute infrastructure. I think the talent part of this is a real important thing to keep in front of us.
So where should the strategic investment be prioritized? In the core digital infrastructure, in AI solutions, or talent development?
Well, you have to do all. I like to say architecture matters. I would start there. You have to have a data architecture and you have to have a technology architecture that's AI first. It's really, really critical. If you have a legacy fixed data ecosystem, it's going to be a constraint. The second thing I would say is talent matters to our discussion that we just had. And the third thing, and I agree 100% with the comments, domain expertise matters. So today we employ 5,000 medical coders in our company. We have the top 250 coders that we take out of their jobs, and they do nothing but work with our AI scientists to train the models. So domain expertise is really, really important to marry or to connect to the technology development process. So I think it's those three components that are critical for success.
I think we have one last question, even it's 10 seconds. Raj, what do you think the biggest barrier between implementing AI in our clinical workflow?
Trust. And I mean that from a cybersecurity point of view, from the ability for someone to feel that the care that they're getting is enabled and better as a result of AI. And trust is very easy to erode. I mean, the one wrong outcome, it becomes a public thing, and then before you know it, AI is at fault, and trust then erodes really quickly. So I think fundamentally developing everything that's already been mentioned, keeping the clinician at the heart of it, but also making sure that we have something that doesn't achieve bias or ghosting in the future, something that we have enough regulation around as well, will be super important.
Thank you so much for all the speakers. So in summary, we can provide a high quality healthcare service with low cost, and trust should be there when we are implementing AI, plus doing a good job for our customer in a low cost does not mean that we are not capable to provide high quality service. Thank you so much.
Thank you, Dr. Al-Anizi, and all the panelists for the amazing discussion on how AI could or could not transform healthcare. As models of care evolve, integration becomes essential to access, continuity, and scale. And to explore how systems can be architected to break silos, we are joined by Ms. Nicole Keith. Ms. Keith is a Vice President of Clinical Integration and Operation at Mass General Brigham, leading enterprise-wide system integration and operation transformation. Please join me in welcoming Ms. Keith to the stage.
Good afternoon, everybody. My name is Nicole Keith, and many of you know me as Nikki. I'm the Vice President of Operations at Mass General Brigham. I've been within our system for 26 years, so I've seen our system evolve from being siloed to more integrated healthcare system, and I'm about to walk you through a journey that I hope will resonate with your country and with your health systems on how integration can really improve access and outcomes. So typically, care is delivered in silos in many places. Integrated care can create a better foundation for care coordination, access, and outcomes. Healthcare systems are typically designed in parts because you're designing around departments or service lines and institutions rather as a whole. The patient sees the journey as a whole, and we're sometimes functioning it in fragments, which is really challenging to improving the outcomes and access. Patients are moving through disconnected episode of care, and Dr. Nawal Noor, who spoke earlier today, gave us some really great examples of multidisciplinary care. And what we can't forget is to make sure that the care is provided in a continuity of care too, and the continuum of care. So what's happening with the patient after they're inpatient visit? Are they getting the post-acute care that they need? Are they in home hospital? Are they receiving the ambulatory services and specialty care that they can, such as cardiac rehab? There are also many delays that we see without the coordination. The delays can be from delayed urgent access to ambulatory visits or even transfers for tertiary quaternary needs. Clinicians are spending time, we've heard this all throughout the day, they're spending more times doing work versus taking care of the patients. So how can we improve that, but create a system that supports an integrated model versus it being episodic, even for the healthcare delivery team? The World Health Organization had a great quote, I thought. Fragmentation is a major barrier to achieving better health outcomes. Integration is therefore a critical strategy for strengthening health systems. It's a tool that we should all be using. Integration, as I mentioned, is going to improve better outcomes and access, but the sum of it all is critical. So when we get to the part about how you can have a unified operating integrated model for your system, you need to be sure that you're always thinking about scaling best practices, evidence-based practices, making sure your data is aligned, your data definitions. You have the same way of abstracting data as well as reporting data, and have inter-rater reliability for the data as well. Transparency is also critical. Pathways, decision-making, and accountability are all foundational to an integrated model as well, to make sure that we are improving care and making sure our patients getting the access at the right place for the right case. Also, continuity and safety is critical, and for complex patients, it's especially critical when we want to make sure that they're being stratified by their risk, or making sure that they're seeing the subspecialists that they need to see. And of course, their efficiencies are outstanding with a well-coordinated system. Before our system was integrated, when we had patient referrals coming to us through our command center or didn't have one, we were taking calls from all different entities saying, can we transfer this patient? They need cardiac surgery, they need a transplant, etc. We weren't able to do this in a coordinated way. So both of our academic medical centers that were tertiary quaternary care providers were getting the same calls because we didn't have an overarching system to make sure that we were placing the patient at the right place for the right case. Now we do. We've seen a decrease in duplicative requests by 3,000 a year. So some of the key foundations, and these are major points that you're going to start to see threaded through the rest of the discussion, is making sure that you have a shared purpose and priorities. If you don't have priorities set, and it shouldn't be 100 priorities, you should have a handful, 5 to 10 priorities that you as a system are setting, and then it cascades down throughout. If you don't set your priorities, nothing is a priority. Clear governance and decision rights. You want to make sure you know who is accountable for what at every single layer of your system, starting from the units all the way to the top of the CEO, and all the way in between as well. That way you'll have an ability to make quicker decisions, not only the right decision. Define care pathways. We've heard about this all day long. That it's very clear that even Saudi Arabia has wonderful care pathways, the system of care, and making sure compliance is followed through the entire care pathway is critical as well. Aligned operating and performance management models. That is going to be the concept we're going to really get into, and I'll share a little bit about what Mass General Brigham has done over the last decade to make sure that we are working from one integrated operating model and how it works as one thing. Reliable and data transparency, we talked about that already. So from the making sure we're bringing the vision to the actually integrated model is critical here, and we'll get into exactly what that operating model is right here. The model aligns the governance, the data, and the execution to produce the reliable patient outcomes and to access. On the right side, I kind of just tried to put it into a framework that makes sense to most of us as clinicians, and the performance management piece is at the top. It's the brain. It's going to make sure that you know your priorities, your accountability structure. The governance is the spine. It's making sure that it's connecting the strategy to the operations and the execution to the body. Structure, discipline, alignment. High reliability, you've heard about this throughout today too. We have a high reliability organization, and that is a way that we early detect when there's an issue. So we have rounds on every single unit every single day, or we're moving in that direction. We're not fully implemented yet. But it's a way that the units, so the physicians, the nurses, the housekeepers can identify if there's an issue with equipment or there's bottlenecks in getting the patient to the next level of care. and it escalates up to our CEO within 5 hours. Enterprise asset management is a way we address our flow and capacity management through our system. We have over 4,000 beds within our system, a lot smaller than your kingdom, but it's large for us to manage as a single system. So there's a lot of opportunities for optimization, make sure that the beds are being utilized appropriately and the patients are getting the care where they need to be getting the care. We don't want community care level in the academic setting if at all possible, because our occupancy is typically around 105 to 110% daily at the academic medical centers. Daily tiered huddles, we also have those, and that's what I was talking about, from the unit to the CEO within 5 hours. It's just a rapid signal escalation, and we've noticed some opportunities where there was issues with pharmacy, and the medications, rocuronium, wasn't available right away for an RSI, for an intubation, and there was a major gap noticed, and we were able to fix that gap at that unit, but we also fixed it for the rest of the entire system because it was noticed on that one unit. So again, scalability is key. And then down on the bottom, tiered KPIs. I think you're going to hear about this tomorrow too. We have a view of tiered KPIs. Our chief operating officer and our CEO aren't looking at the same data or same KPIs that our units are looking at. The units are actionable. Those key performance indicators need to be actionable and aligned with your care pathways to make sure that you are delivering the care that should be delivered, that's evidence-based, and can make sure that you're improving your outcomes in the end. The next level you'll see as we go through too, but you should have different KPIs for every level of your organization. So what changes when integration is in place? We went from a very fragmented system at Mass General Brigham to a well-coordinated system. We still have opportunities, don't get me wrong, but there have been a tremendous success from our command center, like I spoke about. We've been able to open up access. We reduced 30% denials down to 10% denials for accepting transfer requests into the academic setting. We've also reduced our failed discharges. So failed discharges in our terms are when a patient's supposed to go to the next level of care or to home, and they are stuck in our acute setting because of a transportation reason. Typically it's an ambulance patient and they can't get home because of that. So that A, extends our length of stay, B, is more expensive because the length of stay has been extended, and C, creates the bottleneck and increases our occupancy rate where it's already 105, 110%. So when we implemented PTAC in the coordination center, we were able to really load level across the system. Patients are getting community care in the community setting, tertiary quaternary care in the academic, and we're also opening up urgent ambulatory visits. So if the patient thinks they need to go to the emergency department, calls their primary care, we have the way to get them in to prevent them going to the ED, or even if they're in the emergency department, can we get them to the ambulatory setting instead? The whole idea too is really the clinician spending less time navigating the system and more time providing direct patient care. Predictability is also key. We haven't even implemented this module yet, but we are going to this year. So Epic has, and many of you I think are on Epic right now, has a module called Grand Central. And what that gives you is a whole picture of what every bed looks like. Is it full? Is it open? Is it about to be filled in your entire system? It also uses predictive analytics to tell you your estimated discharge date is going to be this date for all of your patients. So then it calculates how many open beds you'll have tomorrow, the next day, the day after that. And you can proactively start to plan your capacity management rather than being reactive. So taking, really breaking the silos in practice. So I was talking about the tiered KPIs, and you're going to learn more about this, I think, as the conference continues. But on the left side here, we have the pyramid visual, which shows that our board sees different metrics than our unit, and then the system, the entity, and the clinical service are all in between. The scorecards on the right, or you can't see them, I'm happy to share them with you, are what those measures are. But if, for example, our board is looking at effectiveness. So what is the length of stay for our system, and what's the 30-day readmission rate? Our system or entities are looking at quiet at night and pressure injuries or claudioclampsy. And our units are doing that too, but even lower, they're looking at staffing as well as infection rates, as mentioned with the CAUDI. So as we talked about integration showing up day to day in this operating model, again, you need unified governance, clear decision rights and accountability, shared and tiered KPIs at every service level, define timely escalation pathways, and cross-functional execution. And in closing here, integration really improves access and outcomes. Access improves with better alignment for demand, capacity, and flow. Our length of stay has also decreased significantly through this integrated model. We have decreased our length of stay in just the last year by 10%. So to put that into perspective for you, 1 day savings for length of stay equates to 150 million for our system. That's pretty incredible, and that's because of the opened bed days and the efficient throughput of getting more patients into the system and out of the system. And we do monitor our readmission rate to make sure we're not pushing our patients out too quickly, and we have had, knock on wood, no issues with an increased readmission rate by decreasing our length of stay by 10% across our system. Patients are reaching their right settings sooner, so our command center is now taking one call for our entire system. We're also moving toward a model where one MD accepts for each clinical service. So historically, if I had a patient request coming in from an outside hospital, we would have to call one AMC, then call the next AMC and see who had bed availability. And that now it's just going to be one call, one MD accept, and we place the patient. Care becomes more continuous, reliable, you know who to call, the one MD accept versus the fight over who's going to admit the patient. Sometimes it's fighting for the patient, sometimes you think it's not yours. Spine and neurosurgery can get a little complicated with the overlaps there. We also avoid utilization decreases, improving outcomes and efficiencies. As mentioned, our turnaround times have significantly improved too with the coordination of care, especially in radiology. In some of radiology. Some of it we're still having issues because of physician pipeline issues for radiology. And again, clinicians need to be spending more time with the patient and delivering that care where we can help create a system and a model for the system that becomes integrated, coordinated, and is looking at every single layer of your organization and creating that reliable operating model to improve outcomes and access. So I think that is it for today. Thank you so much. I appreciate your time and happy to answer any questions outside of here.
Thank you, Ms. Keefe. And now we turn the focus on how to create a unified patient journey across public, private, and military hospitals. And for such discussion, joining us on the stage, Dr. Abdulaziz Al-Rajhi, Director General at Ministry of Interior, Ms. Barbara Hakim, Health Advisory Consultant with the National System Leadership Experience, and moderating this discussion is Dr. Musa Al-Harbi, CEO of Al-Qasim Health Cluster. Please joining me welcoming all the panelists and moderator on the stage.
Assalamu alaikum. I think the previous lecture or keynote make our job really easier to talk about the healthcare and integration. As we know, most of the healthcare systems worldwide suffer from fragmented healthcare. So if we look to the care provided in one session, we'll find it okay. But if we look for the whole patient journey, we'll find it fragmented, and that it will not help and had a lot of impact on the patient. During this session now, I have an expertise in healthcare systems. First, we have Dr. Barbara Haken, and she's a medical doctor, and she was a chief executive and chief operating officer of NHS in England, and she has an extensive experience with government and policymakers in England. Welcome, Dr. Barbara. The second speaker is Dr. Abdulaziz Al-Rajihi, and again, he's an emergency physician, and he's an executive leader with large experience in quality, patient safety, and operation. And he's now the general manager of the Ministry of Interior Healthcare System. So I'd like to welcome in your behalf our distinguished speakers. We'll talk today about the healthcare integration and the impact of fragmented healthcare services. So welcome, Dr. Barbara. Okay, maybe we'll start our discussion today with the first question. What are the problems and the impact of the fragmented care if there is no integration of the patient journey? And your view from the NHS experience.
Thank you for that, and thank you for inviting me here today. In the final analysis, what really matters is that the care feels joined up to a patient. Because too often, as we've heard from other speakers, it's fragmented and we don't get the best results from that for the individual patients or for the healthcare system. And I think there are 3 or 4 really important things to make this happen. And interestingly, I'm going to start with planning. The integration of provision is really important. But actually, it does go back to how you plan services. I spent 20 years of my career providing services as a doctor, and then the other 20 years as Chief Operating Officer in the NHS in England, where the planning and commissioning of services, as well as the oversight, was what I did. And if you don't join up your planning, then actually the people at the sharp end, at the front end, will find it very difficult to integrate the care around the patient. And I think you've got a marvellous opportunity to do that as you move into ACOs, because I think that way you really can look at a holistic system for delivering all the care that you need to. In the NHS, we are fairly good at doing that because we have one NHS, but as we move for a while more to a sort of hard-edged purchaser-provider split, then I think some of that planning of holistic care moved away from us. The second area is very much about provision. And I think in the provision of care, we've all got many providers. There's no health system that has one provider doing everything. And therefore, what's really important is how do you line up the financial and the contracting and the oversight initiatives across different providers so that they drive integration rather than driving separation. In the UK, our biggest issue of integration, we don't really have much private healthcare, so the public-private is not as big an issue for us. Our big issue is the integration of hospital care with out-of-hospital care with primary and community. And that is made much more difficult for us by the fact that our hospitals, for the most part, are paid on an item of service basis, whereas our GPs are paid on a year of care basis. And that actually gives us some real problems, which I haven't got time to go into now, but I do think that incentives and contracts is absolutely critical. And then the final bit of the jigsaw for me is information. It's about the records, it's about making sure that whoever is seeing a patient, they have access to exactly the right information, the up-to-date information, everything that's happened with everybody else. And all too often that doesn't happen because too many EPR records and other platforms that you use, they're designed either for the organisation that holds them or for the professionals using it rather than around the patient. And I think if that, with the patient holding their own healthcare, we're moving in the UK now to try and create a single patient record with a front end that is an app that the patient holds, so that absolutely everybody, whoever deals with a patient, has access to all the information about them. For me, that's the most practical way of helping with integration.
Great, thank you, Dr. Barbara. Now I'm moving for Dr. Abdulaziz. Dr. Abdulaziz, what about the healthcare system in Saudi Arabia in general? Maybe we'll give more details about the military sector.
Thank you very much. And this is the first challenge, I would say. Thank you very much for hosting me today, and I'm honored to talk about my modest experience in this regard. As you know, all of you, you're aware that the healthcare system in the kingdom developed significantly over the last couple of decades, and we reach a lot of achievement. We have excellent medical capability, yet the system itself is still segregated. When I say that, I mean there are three parallel systems working together: the public, private, and finally this military system. And the impact could reach actually to the patient, where the outcome might be affected either from delay access, referral issues, where the referral system will not handle the referral across sections in a proper way, and a lot of negative impacts can be a result of that. One of them is cost, duplication of services, continuity of care, and just you can list them. And the solution definitely is the integration between all the three systems. If I want to talk specifically about the military system, it's a bit different. The focus is different, especially for the officers that they are involved in the healthcare. Most of the healthcare provided to the military is field medicine and tactical medicine, and some of them require specific requirement that does not exist in private or in public sector. Yet again, even with the military system, where you have to provide the service in remote areas, in the borders, and etc., you still have challenges in a proper referral methodology and patient access if you need to.
Great, Dr. Abdulaziz, and thank you. Back to Dr. Barbara. From how we can learn from the NHS experience, what is the best solutions in practice to deal with fragmented patient journey?
Well, I kind of outlined the three main areas that I would focus on. We've done some things well, and we've done some things really badly in the NHS in terms of our journey. And I really think that in a way we're almost following what you're doing now, in that we're moving much more back towards an ACO type model. Because I do think having a very strong purchaser-provider split, which is what they have in the United States, and they've, as we heard from the last speaker, they have all sorts of ways of mitigating against that causing fragmentation. But it can cause a lot of fragmentation, whereas if you've got one body that has a holistic view of the population and can then work through the integration of all the services, because you can't, each service has to be integrated differently. And the care for diabetics, the maternity care, the care for children, the people on the front line have to be given the tools and the ability to create the care pathway and then integrate what they're doing around it. And as I say, I think that a very strong focus on your planning so that it is one journey, a very strong focus on your finances and your incentives so that people aren't pulling against one another. And then I'm sure, I know you in this country are also working on how do you sort data out so that you have one record. But again, a strong thing for me is just make sure that your information systems are designed to focus around an individual patient and what their care looks like, rather than information systems, important though it is, that actually help oil the wheels of how an organization works.
Great, thank you. Back to you, Dr. Abdulaziz. How does the implementation of model of care help to fix the patient journey and make it more integrated?
The model of care basically shifted the healthcare delivery model from organization-centered to patient-centered. And I think the holistic approach and having the continuum of care for the patient from the early stages, even pre-marriages, checks, deliveries, etc., up to the end-of-life care and taking care of the geriatric population, that's exactly what's the model of care has an impact on the population. So it's the continuum of care. That's the main result of the model of care, the current one.
Thank you. What are the advantages of having a service line? For example, some of the systems, they use the term of service line across more than one organization or for the clusters, and the term of planned care also, to have like a one-stop clinic. Do you think this practice with the use of technology, it might help to have an integrated care for the patient?
Yes, I think working out how you can deliver the different elements of care, because I always think that there are probably 4 main types of care that we deliver to patients. You can segment it in many other ways, but there is planned care that you've just talked about, the chronic care of chronic diseases, and that's growing for all of us, and therefore the need to ensure that that care is integrated is probably the most important of all, because if you don't get chronic disease management right, you end up with unnecessary urgent care and sometimes unnecessarily planned care. But then I think it's always important to remember the health improvement aspects of this as well, because at all stages, the more that you're driving care downstream and preventing, again in the NHS, what we're focusing really at the moment, apart from the drive towards more digital, is to make sure we deliver more care nearer to the patient's home, so people don't have to go to hospital unless it's absolutely necessary, but more preventative care. We've heard a lot, you've heard a lot today about population health management, and just how we can use that in its totality to drive. And as you say, you have to work through the different elements, because one-stop shops do work very well in some occasions, but they have their limitations as well, and therefore sometimes it is about having the right care in the right place at the right time, and that may be in a one-stop shop, particularly for planned care. That can be very helpful, much less so for the other kinds of care.
Maybe it is used for the elective care more than the urgent care, the planned care. I agree with you completely. Next issue, maybe we have to discuss it today. What about the patient engagement in designing the service journey? Because always we design for the patient and we talk on his behalf. And we want to really to make the patient at the center of our care. So what about engaging the patient themselves, listen to them, their feedback, and to utilize it for a better design for the services?
Sure, I agree with you. It's very important to get the patient feedback and experience, because they are the core of our business, and at the same time they are the core of our focus. Patient engagement, listening to their comments, listening to their what they think about all the steps in their care, and sometimes you end up eliminating a lot of duplication, unnecessary steps that does not really make sense, because you look at it from an operational point of view, while the patient they think it's can be replaced by another steps or etc. But again, we have also to think about the frontliner and care provider. You have also to get their engagement, because they are the people that they're doing the day-to-day job, and we have to make sure that they really, their feedback sometimes can save a lot of times, money, etc. and improve outcomes, definitely.
Completely agree with you. Any comment about the patient engagement?
Yeah, I mean, again, it starts at the beginning, because sometimes it's about citizen engagement, because the citizens will become patients. So I think that's the one thing that's really important, is to, when you're planning your health services, engage the public, engage your prospective patients on what that can look like. There are many ways of engaging patients at the moment. Digital does give us an enormous opportunity to get feedback from patients and take their views. So I think there's much more opportunity, but again, I still think there is a slight cultural shift that all of those of us in the health services, whether we're doctors or managers, we have to just have that cultural shift that actually the patient probably knows best rather than we do.
Thank you so much. Also, the health system now and the model of care, and with the all clusters now working really for many projects for the integration. One of the initiatives by the health holding company is the Care Link, where we'll have like an organization for the patient journey from the start to the end. I hope it is one of the initiatives. We'll see its impact, inshallah, soon in the next year. So I think by that we come to the end of our session today. On your behalf, I would like really to thank our speakers, Dr. Barbara and Dr. Abdulaziz, and really it is our pleasure to have you here and to learn from your experience. Thank you so much.
Thank you, panelist and moderator. As we are moving into the final stretch of our scientific program today, we return to the important question of financing, this time at a national level. And for such a topic, joining us from KPMG, Dr. Mohammed Fayeb, Healthcare Associate Director at KPMG. Dr. Fayeb is health economist with an extensive expertise in healthcare strategy and financing, who will share insights on investing in better health for Saudi model of care. Please joining me welcoming Dr. Fayeb on the stage.
Assalamu alaikum. Alhamdulillah. Wassalatu wassalamu ala Rasulillah. Welcome everyone, Your Excellencies, distinguished healthcare leaders, colleagues. First, I'd like to thank everyone, organizers, scientific committee, and HealthCo for such impressive event. And it's my pleasure to stand here in front of all of you on behalf of Health Finance team from KPMG. Standing here today is a great opportunity to look back on the decade of implementation of transformation under the vision of 2030. And as observer and actors of such a transformation in the kingdom, we have witnessed a remarkable evolution that happened over the last 10 years. And the kingdom has moved tremendously from a system focused on building capacity to a system focused on delivering value. And this presentation today, under the title of investing in health, this is based on a study that we are launching soon in thought leadership. We are here to discuss the clinic, not to discuss the clinical protocols or facility design, but to discuss the engine behind this, which is the financial model. Our analysis in this study revealed that clinical architecture of the sector is world class, and the financial architecture requires final decisive alignment to ensure the long-term sustainability of model of care. And if we see here this kind of structure between we already succeed, or the kingdom has already succeeded to secure the access, which represented the infrastructure, and the clinical future already has been designed through the model of care with the different care pathways already in place. But if we can, still we can see a gap where we can see the disconnected plugins. And this is what we call it's a risk of misalignment. Currently, the financing mechanisms are often based on historical budget or raw activity. And this incentive volumes and the more visit and the more admission and the more procedures. Yet the model of care explicitly asks a provider to reduce volume, as we saw lots of speeches today around moving toward prevention, but while this not happening. And this friction between the finance and model of care is very dangerous, and as a financial incentive is opposite of the model of care goals or clinical goals that we need to achieve. And here there will be a struggle to survive, and the provider cannot reasonably be expected to invest in prevention if the revenue depends on sickness. And the solution, if we move to this solution in the bottom of the page, we will see that moving from passive reimbursement where the system simply pays the bill to strategic purchasing, where the system actively align every single real spent with a desired health outcome. And to understand this, all of us knows that the system now is between the payer, the provider, and the regulator, represented by CNHI, Health Co, and MOH. And between all of this, the strategic purchasing, it will be the financial tool that CNHI is implementing to maintain the financial system integrity and align with model of care. And through this purchasing or strategic purchasing, it's not only about the payment or the kind of accounting procedure, it's beyond than this. It represents the benefit design, what we will deliver, and provider selection, how we will select a provider, how we will contract them, what are the terms and conditions we are adopting, and what are the best methods for payment through the model selection memos and so on. And afterward, how we monitor the performance of those providers against what we have contracted based on the benefits and how we will pay them. And here, this is the core of our presentation today, where we showing the strategic pivot. The strategic pivot here is the finance being treated usually as a background function. It's just kind of paying for activities, and it was administrative function to reimburse historical budget. As we noted earlier, the flow in model that it tolerates fragmented incentives, and it pay for activity regardless whether the activity add value to the patient or not, which is not the ideal status that we are looking for right now. Moving to as a strategic lever and as an active driver, we are looking for buying outcomes, enforcing integration, and toward accountable purchasing. So we are not paying anymore for staff, beds, and so on, but we are paying for healthy patients. And in future, this is the financial, it will make it necessarily from financial point of view for hospital to talk to primary health care and rehab centers and other facilities as well. And from accountability point of view, this will make sure the funding is conditional on performance, and so the incentives are linked to as well. And here, this is the take-home message, that we stop asking how much did we spend and start asking what value did we create. And to operationalize this and to put it into kind of operation point of view, we are focusing into three kind of pillars, which are integration, accountability, and sustainability. I noticed lots of my colleagues through the day have talked a lot about integration and how it should work between different levels and across different also providers. The previous session was talking mainly about the patient journey across different providers, from public to private to other governmental providers. We are facing, and also we have a previous session as well on silos, and the siloed budget creates siloed care as well. If a hospital has a separate budget from rehab center, what is the incentive to talk to each other? And for example, bundle payment is one of the levers. By setting a single price for full episode of care, like knee replacement, for example, the financing forces the care to follow the patient. It makes coordination profitable, of course. And here the financing acts as a glue for the continuum of care. And from accountability point of view, we used to pay regardless of the quality of care. But from digital education point of view and monitoring, leveraging digital and AI, especially like digital platform like Nafis, now we can make sure that the care is protocol compliant as well. And this will make a new standard. Will every 1 real spent equal 1 verified health outcome? And this is what we need to achieve at the end. And from sustainability point of view, rising of cost, especially for chronic care, that we need to set a fee to manage population. We shift financial toward upstream to keeping well. Long-term resilience, we control cost curve not by cutting service, by reducing the demand for complex care through better prevention. In conclusion, the Kingdom has built the body of modern health system and the facilities, clusters, and the workforce. And now we must focus on the blood, which represent the financial incentives that flow through it. Model of care without a corresponding business model is fragile. But a model of care supported by strategic purchasing would be sustainable. Our final message here is the ecosystem fully to embrace the pivot and don't treat the finance as a utility of use, at a strategic engine that is designed to be. Thank you all for listening, and I hope I be short. I know it's late already. Thank you all.
Thank you, Dr. Fayed. As we conclude day 1, we will reflect on holistic health and effective care models. So it's my pleasure to welcome back to the stage Dr. Amit Seif and Dr. Martin McShane for this closing panel discussion. The session will be moderated by CMO of KeepWell at Health Holding Company, Dr. Luay Basudan. With this, I will hand the discussion to Dr. Basudan.
Assalamu alaikum. Good evening. Shukran. Thank you all for being here at the last session, almost Maghrib time. So hopefully this session will be excited and some information benefit for your practice. you will gain. I'm welcoming back Dr. Martin and Dr. Ahmed. They were already been with us in early morning. They have a huge experience with NHS, and they have a lot of talk about holistic health. So hopefully we'll gain a lot from their knowledge. So as I know both of you, you have the same experience, so you are welcome to choose whom to answer which question. So I go in direct question, which is really important, I think, for me and for a lot. How can holistic health be more in action, operationalized, rather than to be conceptual principle in our system?
Thank you, Jose. So I think, for me, it starts with what is holistic health. And I think if we just accept, if we speak to 10 doctors, we'll get 12 answers. So if we make it broad and say that it's considering the person in the whole, and I'll just make it a very broad statement. So thinking about their biopsychosocial model, where they live, their lives, rather than just their condition. In terms of how we can actually move to execution rather than rhetoric, which is, I think, where we have been globally for a long time, I believe, and I would love to hear from yourself and Dr. Martin, it starts with the alignment of incentives. So at the moment, we exist in many parts of the world, incentives are perverse. So you're incentivized to do more activity, to receive more payment. The hip and knee surgeon is not incentivized to help the patient lose weight, get physically fit, and not need a knee replacement, actually quite the opposite. For us to start to consider people in the whole, we need to align the incentives of the orthopedic surgeon, the provider, the primary care, the social support around them, the government and the environment to enable green spaces, outside ability to exercise, schools to help with healthy eating at a very young age. So the alignment of incentives, I believe, will be the real marker of our journey to executing on holistic health.
Okay, sound good, thank you. So second question, there's a little bit bias since our background is family medicine and primary care. So as the primary health care play a main anchor role in the health, what is their role and expectation when talk about primary health care provider and holistic health?
So I initially trained as a surgeon. And for very important reasons, I decided to go into primary care. And the experience for me was like moving from England to Japan. I had no idea, as a hospital specialist, what the role of a primary care physician is. And I think it is hugely undervalued. And one of the best examples I can give, one of the best phrases I can give is, I worked with a system in Yeovil, which is a beautiful part of England, southwest. And the GP practice had just introduced a new form of assessing their most critical patients. So every week, every day in fact, they sat down and they had a huddle in the morning where they would look at who'd been admitted to hospital with the GP, with community care, with social care, and with mental health support. And they would then decide how they, as a team, could best help those patients who were either in crisis or emerging from crisis coming out of the hospital. And I asked one of the GPs, what difference had this made to their work? And they said, I no longer feel like I'm fighting for care, I'm orchestrating it. And for me, this was, and personal experience as well was, once you move, Atul Gawande once famously said that modern medicine is a team game. Once you move from thinking of yourself as an individual doctor in primary care, but part of a team, and the sort of keystone in a team of people, you can start to help orchestrate the best possible, be the conductor of care for that individual, bring the right specialist on board, bring the right support on board. So I think primary care has a fundamental keystone role to play in facilitating the operationalization of integrated care.
Thank you. How can holistic disease-specific care model be effectively implemented in high-burden conditions such as diabetes, mental health, maternity? Yes, Dr. Ahmed.
So without repeating myself around the incentives, I think it's what you've said is really critical to think about people as a continuum. So for example, all those long-term conditions you've mentioned, you could be talking about one patient. Whereas I feel that in a non-holistic way, most of the way care is designed at the moment and implemented is around the diseases themselves, as opposed to considering the patient as a whole. So this may be more cultural than systematic, but if we start to look at people as a whole who have the long-term conditions and construct the care around them and near them, it will allow us to start moving towards a much more holistic delivery model. And there may be an element in that in how we train our physicians and how we train our wider healthcare teams, but there's also a role to play for the community and the non-healthcare infrastructure around that. And I think that will help us change our mindsets as physicians, as members of the health and care ecosystem, in how we view people and their families. I'll hand back to Dr. Martin, but earlier in Martin's slides, he showed the theogram and the journey in space and time that the patient goes through. It's hard work to be a patient. It takes an awful lot of time and energy to just be a patient. And again, that in its essence is treating the different diseases. So your dietitian, your physiotherapist, your doctor times X5, as opposed to thinking about the person and their own journey through space and time with their conditions. I'm sure you have something to add to that.
Well, I just want to be controversial. I would abolish the phrase evidence-based medicine. I think we have evidence-informed medicine. In Salford, they looked at 3,600 people with COPD. 302 of them would have fulfilled the criteria for the randomized controlled trials on which evidence-based medicine is based. So I think it is, if we want holistic medicine, we need to use the evidence to inform. It is a human endeavor, delivered by human beings for human beings. And I think we need to bring back the role of the professional in crafting the care for people.
Interesting, I agree with you totally. If we will talk about enablers, what digital health, workforce, and governance enabler are necessary to support, to sustain holistic health approach?
It's a really important question because it pertains to infrastructure in the modern world, and the talk with Raj Chima, my partners from KPMG, had a heavy emphasis on digital in the next 20 years. What does integrated care mean? And if we kind of expand that definition to answer the question, it's the utilization of the best possible tools available to us. So the use of virtual care and almost moving towards a hyper-connected state. So for example, work we've done in the US where the patient's wearables are integrated into the EMR of the hospital, allows a passive monitoring of vitals, meaning those patients don't need to even come into hospital for checkups because an early warning system will advise them if there are markers that are off, and it can cut the attendance down by as much as 80%. So if we start to think about the use of what is really quite ubiquitous technology, widely available technology, it doesn't have to be anything new and highly expensive, but leveraging the new age of digital and data and virtual access and care, it allows us to level that playing field. Now, some of the consequences of that, well, most of the consequences are positive. Some of them are an increase in provider sustainability because they can do more on a much bigger footprint, ease of access and a reduction in inequality for the actual users and the patients and their family, and a frank reduction in disease burden. So those are some of the areas. I'm not an expert and I won't get into artificial intelligence because you've got real experts here to talk about AI, but even the pattern recognition and the ability to predict admissions or people at high risk of admissions can be leveraged in this manner. So I'll give you an example of a project we ran in Essex for mental health patients. We took their data from social care and we fed it through an API into the EHR, the medical record, and combined it with their medical data. And we were able to come up with a predictive model, which was automatic, that identified patients at a higher than normal risk of admission through mental health crises. Now, one of the special issues with mental health admissions is they're incredibly long. And then you enter kind of social issues, and a mental health admission, an acute mental health admission, can result in stays up to 1 year long. So even the avoidance of one mental health admission can have a significant impact on the health and care system. So that's just one example of how we can leverage technology and leverage the environment that we now live in to provide that more holistic offering.
Great. Dr. Martin, how should success be measured in holistic health beyond the clinical outcome?
Oh, I think this is really important. So there's two measures that I've experienced use of in the last few years. And the first of all is just patient-reported outcome measures. Hey, if anyone's done any online shopping recently, I know many of you won't, but I have, and I constantly get asked, what was my experience like? Everyone seems to want to know what my experience is like, except healthcare. And I think that's really important. So feeding, but one of the most interesting measures we used when we were delivering the Population Health Management Development Programme across England was patient activation measurement. And I always remember a woman who had really severe problems, mental health problems, unemployed, recently bereaved, had become depressed, and was picked up as a high-risk patient, as Amit just described. And the team reached out to her. They measured her patient activation measurement, which goes from 1 to 4. 1 is, I'm completely at, I need you utterly and totally. Tell me exactly what to do. And 4 is, move over, I'm in charge. And she received help, she received intervention, mainly non-medical, a lot of it non-medical, which relieved her depression and helped her cope with her medical problems. But she got back into work, she got housing, and she moved from patient activation measurement 1 to 3 in 9 months. She suddenly realized she could cope with her life. She wrote a letter to her doctor saying, "Thank you for giving me my life back." Now, to me, we do not do enough to measure the experience people have and feed that back. And in fact, when they do the feedback in hospitals, which is a numerical score and some free text feedback, the nurses and doctors find the free text feedback that patients give them the most important aspect that tells them about their experience, because often we don't know the impact we're having on people unless they tell us. So those two measures, I mean, we've got loads of other biomedical measures which are important, and Pache, my earlier point about evidence-based medicine, but they're important. But I still think we don't look about, are we really empowering this person, and are we giving them a good experience? So patient activation measurement, patient-reported outcome measures.
Thank you. Dr. Ahmed, if you can enlighten us about some structural barrier that prevent holistic care from being embedded into both primary health care and in the hospital.
So, I mean, if I think of the main structural barriers, I think about the infrastructure of the health and care systems around us. So each organisation effectively operates with their own remit, their own budget, their own records, and their own lens and their own view, and importantly, their own outcomes. So that the health system, for example, doesn't have any impact or ownership of the happiness of the patient, just to be a bit kind of contrite to make the point. So we're already existing in an environment where we have very complete and separate bodies that don't communicate with each other, but also don't have the same objective outcome measures. I apologise to any orthopaedic surgeons in the audience. This is absolutely not meant to be directed. It's the easiest analogy I can draw. An orthopaedic unit is set up to provide orthopaedic operations, hip and knee replacements. They are not in any way incentivized or have any visibility on good diet and exercise and weight management or physiotherapy pre-op. So we already, by definition, have created a siloed environment where the patient is almost a commodity passed between them to receive their transaction, get the transaction, and then go to the next entity. So that is the first, but the main major structural barrier that I see. The next one would be kind of a health and care system cultural environment that we operate on. We all go through our training, whether we're doctors, nurses, physiotherapists, and we become very disease and specialty focused. I mean, general practitioners, we can argue that we're probably the most versatile out of all of those, but we're still looking at everything through a medical lens. We're not necessarily looking at the social environment. We're not necessarily taking the accountability for healthy eating and education of children and healthy food choices and so on and so forth. So it's another barrier in the way that the system is simply from inception in terms of the accountability each of us hold in the system. The last area I would say is kind of patient empowerment. So it's not an easy fix, and please don't think I'm saying it is. But I don't believe we've created an environment in medicine in the last 50 to 100 years where the patient is empowered and given the ownership of their own health and well-being. I still feel we largely exist in a more paternalistic system where access to medicine are very much viewed as something you go to have done to you, as opposed to, let's say, your investments, your financial investments, which is very much something that you will go and do for yourself. So why is one different from the other? So those are the three kind of barriers that I see that really have a significant impact.
Dr. Martin, if we move to some of the workforce capability gaps, like skills, training, culture, that may limit the effectively delivery of the holistic care, particularly in behavioral health and lifestyle medicine.
I think this is incredibly important. And I go back to my team analogy. I know I am not skilled at everything. I'm very skilled, but I'm not skilled at everything. And I can draw upon the skills and expertise of other people in my team. So the first behavioral thing is to get over the idea that as an individual, you have to do everything. Facilitate becoming part of a team. Know your team, know how best to deploy it and use it. However, most of my development throughout my entire career has been because I've been afforded the opportunity of training and education by the NHS and others, but mainly the NHS. And I realized that actually creating time for development and learning within the work schedule of everyone is really, really important. I mean, I had transformative experiences, both clinically and in understanding the management of the system, but also when you come to behavioral and more general health, I think we need to really go right back to the fundamentals of, instance, for medical training, just starting right at the very beginning, the emphasis on, what really is the 80-20 rule in health. What keeps us healthy? It's nutrition, it's exercise, it's sleep, and it's relationships. Being lonely, being socially isolated is equivalent to smoking 17 cigarettes a day. So let's be realistic about our limitations. There's an enormous amount of good we can do, but are we really a health care system or an illness addressing system? And if we want to be a healthcare system, I think it is about understanding and becoming part of that team, knowing we can't do everything, and being able to bring on other people. I hope that's helped answer your question.
Yes, I hope it's clear for everyone. Dr. Ramit, what financing and incentive model are required to shift from active-based service to value-based holistic care delivery?
So this is the ultimate question, and the answer is not one that anybody really wants to go down. We need to move to pay for nothing happening. So an upfront investment in, okay, let me back up. Martin will correct me, but I believe over 70% of deaths worldwide are through non-communicable disease. It's in excess of 70%, I believe. 70% of deaths are non-communicable diseases. Now, non-communicable diseases, as everyone in this room will know, are due to obesity, smoking, lack of exercise. They're diseases that happen that are largely environmental, not physiological. The easy way easy, not simple, not easy, sorry, I should say, way to wipe out and eradicate non-communicable diseases is to invest in a healthy lifestyle that means our bodies develop and age in the way that they were designed to do, which is as hunter-gatherers who ate what we could, only ate whole foods and exercised an excessive amount every day. Now, that sounds impossible, but then if you look at countries like Japan, it's exactly what's happened, because they have made a huge upfront investment in 5, 6-year-old children in what a healthy plate looks like. They penalize employers if their employees are overweight. They instigate exercise and movement as part of daily living from a very, very young age, and they make it very difficult for people to eat high-calorie, low-cost, ultra-processed foods, which we all know, once the palate is used to them, are highly addictive and very, very difficult to get away from. So if we think on a societal basis, if we didn't spend X billion on high-tech infrastructure, secondary, tertiary, quaternary care websites, and we spent a small fraction of that on early years health, nutrition, exercise, and then a broader infrastructure basis made it very easy for people to exercise, to be outside, to have social interactions and social relationships, we would see a potential eradication of non-communicable disease. The rub, Dr. is that we would not see it in a financial quarter, and we would certainly not see it in a financial year. We would see it generationally. And that may be one or, well, to satisfy a CFO, let's put it that way. So to get it on paper, we could be talking many, many, many years. But that is the truth of it. So that upfront investment is the way. Martin, go.
I'm going to challenge a little bit my colleague Amit here, because one of the things I used to think that public health initiatives took years, decades to implement. Okay, I'll give you 2 examples from my personal career. One is I was an accident and emergency doctor in Leicester in 1982. 1982. That is when the seatbelt law was introduced in the UK. Why do I know that? Why can I remember the exact year? Because I used to pick glass out of people's faces 3 times a day in the A&E department, and literally overnight it stopped. The seatbelt law was introduced. I stopped having to pick glass out of people's faces. In Bolsover, a deprived ex-mining area in Derbyshire, they had above average heart attack, cardiovascular adverse events, above average. We introduced a program of smoking cessation, exercise prescription, and statins. In 3 years, not 10, not a generation, 3 years, the community in Bolsover went from above the national average to below the national average. And I've realized that actually lifestyle changes, having that structural effect, can actually do things faster than perhaps heretofore we've believed.
Thank you. I think we should find where's our area that we need to apply this project. One last question from my side to conclude, and it's really, maybe it's not easy to answer, but about the stigma, especially here when we talk about mental health, about obesity, and lifestyle-related condition, how we can address that to enable early engagement and in continuity of care. Especially when we focus about mental health, especially in our community, it's not easy to talk to patients, how we can go over this stigma.
And just to emphasize, when we did this work on population health analytics in the UK, as you know, if people had a physical problem and they had a mental health problem, just anxiety or mild depression, it quadrupled their costs of care. We neglect addressing mental health at our peril in the healthcare system. So how do we do this? I think we make people aware of the value and the benefit of doing this, and we give people the wherewithal and the support and enablers. So we don't just, as Sandra was told, go out and take more activity. We actually link them up there and then to part of our team who will help them do that. I don't know what more you'd say on that.
Well, I mean, I think you're right. And I think the thing with stigma is if we accept the stigma, we'll never progress. So my advice would be we think big, but we start small. And the change starts with small levels of acceptance and normalization. And the key for me in that is empowerment through knowledge. So whether we want to accept mental illness is a thing or not, 7 out of 10 people in this room, in any room, have it to some degree or other, if not more. And during the pandemic, that was closer to 9. Exactly, maybe certainly tomorrow. So empowerment and acceptance and normalization is a journey, but we don't let the size and the length of the journey defeat us. We think big and we start small.
Thank you. I enjoy it a lot. If you have any conclude message that I didn't ask you about holistic, please.
No, I would just like to thank you and just say good luck. You're doing the best work in the world. And I look back on my career, I wish I could do it all again with all the warts at the drop of a hat. I'm jealous and envious of you because...
You have time, Martin, don't worry.
Yeah, I agree. Thank you all for being to the end, and thank you for our distinguished speaker.
Thank you. Thank you, our panelists, Dr. Luay. What a session to end our scientific program for day one. Thank you all who participated in such rich and engaging scientific program today. And as we close day one of our scientific program, the discussion has been taking us from strategy to execution and from innovation to real-world integration. And before we conclude, I would like to warmly invite all of you to join us this evening at 7 p.m. for the honoring ceremony held under the patronage of His Excellency, the Minister of Health. It will be a truly special experience where we will hear inspiring stories directly from the patients, the real voices that reflected how the Saudi model of care has touched and transformed their lives. Thank you again, and I look forward to welcome you again tomorrow. ضيوفنا الأعزاء، أود تذكيركم ودعوتكم جميعاً لحفل التكريم في هذا المساء الساعة 7 مساءً تحت رعاية معالي الوزير أستاذ فهد الجلاجل، حيث سنسمع قصص ملهمة يرويها مرضى أثر نموذج الرعاية السعودي على حياتهم مباشرة، لنرى الأثر لنموذج الرعاية وما يعمل عليه. شكراً لكم، نراكم 7 مساءً.